people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention.
Manas,
Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hi, I'm Dr. Anita Saxena, Professor in the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Secretary, Society of Renal Nutrition and Metabolism, India. With pleasure, I welcome the faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease in order to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of several conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular disease, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in these patients. This year, the theme of the advanced course is Feeding Well in Chronic Kidney Disease. Don't miss the inaugural ceremony, as we will be releasing an educative booklet on Eat Well to Stay Well, nutritional guide for post-renal transplant patients. We also publish quarterly the Journal of Renal Nutrition and Metabolism. I'm sure you will enjoy being with us for 2 days, and the deliberations will update you with the latest developments in the area of renal nutrition and enrich your clinical practice. Revere and thank you for your attention. Hello. Okay. Agitate. Okay. Agitate. Okay. Hi. Good morning, sir.
Hi, good morning. Good morning.
Good morning. Good morning, sir. Good morning, sir.
Good morning, Dr. Sampath. Dr. Sampath.
Dr. Sampath, you are muted.
Good morning, sir.
Hi, good morning.
Nice to see the smiling face of Anil sir in front
Uh,
of so much of tense moments in Delhi.
Dr. Sampath, I think your
Yeah.
volume is a little low.
Is it? What should
You
I
are
do?
using a headphone or?
Yeah, headphone.
Actually, please disconnect the headphone and connect again. I think your volume is too low.
So, Sudhir, shall we go live now?
Now is it okay?
Yes, ma'am. Yes, ma'am.
Yes. Dr.
Right.
Sampath, it is quite okay now.
Thank you.
Actually, you are right. Nothing for us to smile. Things are very bad for
Very
us.
bad. Very bad.
Yeah. So, shall I start, sir?
Yes,
Yeah.
sure.
Good morning, ladies and gentlemen. Welcome back to 7th Advanced Course in Renal Nutrition and Metabolism. This is the second day of the course, and the theme of our course this year is Feeding Well in Chronic Kidney Disease. So we start our first session, which is session 9 on management of specific on dialysis. I guess this is our first session on dialysis. Sorry about that. So we start our session 6, that is maintenance dialysis, and the moderator for this session is Dr. Amit Gupta. Dr. Amit Gupta is currently Director Nephrology and Transplantation at Apollo Medics Super Specialty Hospital, and he is the former Professor and Head Department of Nephrology, SGPGI-MS. So may I request Dr. Amit Gupta to invite the speakers and the panelists.
Good morning to all of you. It's a pleasure to be back this morning, and I'm stepping into the chairs of in the shoes of Professor Georgie Abraham, who's been held back for with some family function. My co-panelist is Dr. Lalit Agarwal, who I would request to join in as well.
Dr. Lalit Agarwal will not be able to join because most likely he's in Delhi because of some COVID emergency.
Lalit Agarwal or DS Ray?
Both of them are stuck up with COVID emergency in their family, and
So
probably their health issues.
Anyone else?
You can invite Dr. Sundar.
Dr. Sundar is on the list. Is there?
No, ma'am, not joined now.
You can ask him to join, please.
Okay. So anyway, we have a team of excellent speakers who will all be panelists, and we can have a discussion at the end of the presentations, if all of them are around. So we first have, I believe, a video about hemodialysis. This is basically an introduction about how hemodialysis is done, and all those who are new to the field of nephrology.
I'm not even put it.
Dialysis. Dialysis is a process through which waste products are artificially removed from the blood to compensate for the presence of an abnormally functioning kidney. In a healthy kidney, waste products, excess fluids, and electrolytes such as sodium and potassium are removed from the body in the form of urine. In the case of kidney disease, the loss of kidney function results in the increased accumulation of excess waste, toxins, or fluid in the body, thereby causing other complications such as hypertension, heart failure, pulmonary edema, metabolic acidosis, and hyperkalemia. Dialysis is performed in the following situations. 1. Acute kidney failure, or 2. To remove drugs or poisons from the body. Dialysis could be of two types. 1. Hemodialysis. 2. Peritoneal dialysis. Hemodialysis. This is done with the aid of a dialyzer, which is a machine present outside the body, which removes the toxic substances from the blood. A vascular access site is created by first numbing the area with local anesthesia and creating an arteriovenous graft by connecting one of the arteries with a vein with the help of a plastic tube, or an arteriovenous fistula by directly connecting one of the arteries with a vein. Once the graft or fistula has healed, hemodialysis could be performed for the patient. At the start of the process, 2 needles are inserted into the fistula or graft, allowing a circuit to be set up with the dialyzer. Blood flows out of the body into the dialyzer, which consists of filtering fibers that remove waste products and excess fluid from the blood, and a dialysate, which acts as an absorbent solution for undesirable substances in the blood.
All right. Okay.
Blood purified in this manner is returned to the body through the tubing into the second needle at the access site. When the hemodialysis session is complete, the needles and tubing are removed, and the patient is allowed to return home.
Kanita, you are muted. Okay, so now that we've done this video, we now come to the lectures, and we have very interesting topics to be discussed, and very important in the field of dialysis. And we have excellent speakers who will be speaking on these topics. And the first topic would be about importance of achieving dry weight in maintenance dialysis patient. Now, dry weight is something which, as nephrologists, we know is of extreme importance because it would help in reducing the requirement of antihypertensive drugs. It would make the patient feel better. But it is an art that we need to develop because there are now equipment to assess how dry weight, what is dry weight, but still you need a lot of experience to assess and to bring the patient to his or her dry weight. Dry weight again is something which is not constant, it sort of can fluctuate. And we have none other than Professor Sampath Kumar, who's a senior consultant nephrologist at the Meenakshi Mission Hospital in Madurai, Tamil Nadu, who is speaking on this. Sampath is an excellent clinician who has long years of experience in the field of dialysis, who is an excellent interventional nephrologist as well, and an excellent speaker. So may I invite Sampath to kindly deliver his talk. Over to you, Sampath.
Thank you, sir. Can I share my slides?
Yes,
Yes, sir.
please.
Yes, sir.
Yeah. Good morning to all of you. At a time that health emergency is staring at the nation, it is extremely important that we continue our academic pursuits side by side uh, in addition to the patient care. And I would congratulate the organizing team for the excellent arrangements, digital arrangements being made for this important meeting. So, over the next 20 minutes, I will be talking to you about how dry weight is very important. The achieving dry weight is extremely important in hemodialysis, and what are the tools that we have to assess the dry weight, and how do we harness the technology in achieving dry weight. So why is it important? You know that this is a most downloaded and most viewed slide telling us about the increasing levels of mortality when you compare it to the mortality in general population. A 25-year-old dialysis patient has an annual mortality which is equivalent to a 85-year-old general population figure. You can understand the tremendous increase in the mortality of patients who are taken up for dialysis, and it is equivalent or even worse than the mortality of a patient suffering from advanced carcinoma. One of the important reasons why this happens is that heart failure and heart disease and cardiovascular disease are the center stage of this increasing mortality, and it is the chief driver of mortality in hemodialysis patients. And we don't have to look far as to why this is happening, why heart failure happens, because if you just have to look at the water which is cleared of urea based on a continuous weekly KT over V according to a chosen method of dialysis, you can see that a normal kidney clears as much as 1000 liters per week. And when you go down to the patient who is anuric, who is having hemodialysis 3 times in a week, the levels go down to as low as 80 liters per week. And not only the urea, but it is water, which is the most important uremic toxin. Nothing is Nothing much is spoken about the water as an important uremic toxin. We always focus our attention on urea, but water, mind you, is the most important uremic toxin which kills the patient. So, if you see that hemodialysis 3 times a week, and you can even go down and think that it is as low as 60 liters per week in patients who are on weekly 2 times uh, hemodialysis, which is almost the norm in most of these centers across the country in India today. And when you see the fluid compartments of the 70 kilogram man, what is most important is that the hemodialysis machine addresses the intravascular volume, and which is, when you see the total body water of a 70 kg man is 42 liters, the effective arterial circulatory volume is only 700 ml, and the venous circulation holds close to 2.3 liters, and most of the water as extracellular water resides in the interstitial compartment of 11 liters, whereas the intracellular compartment also boasts of 28 liters of water. So in a patient whom you target an ultrafiltration volume of 3 liters, you can immediately see that the total plasma volume is only 3 liters, and you need to remove and also dialyze as much as 4 times the effective circulatory volume, which is only 700 ml. So you can see that this is a real challenge for the physiology, body's physiology already, which is at the doldrums because of the uremic milieu. And every hemodialysis session is a tightrope walk for the patient's physiology, because when you are going to ultrafiltrate more, the patient is going to go in for hypotension with a washed out feeling and cramps and whatnot, and also cardiac and cerebral ischemia. And when you have a patient who has got inadequate ultrafiltration, long-standing issues creep in, like hypertension and enhanced cardiovascular disease. So, as beautifully put in by our chairperson, it is an art rather, and it is a science embedded into an art. So the precision fluid management is extremely important in hemodialysis, because if you remove too little and leave too much into the circulation, then the patient goes in for multiple cardiovascular issues like sudden cardiac death, congestive cardiac failure, LVH, hypertension, poor quality of life, and arrhythmia. And when you are too aggressive, you have these issues staring at you like loss of residual renal function, poor quality of life, bowel ischemia, myocardial stunning, and intradialytic hypotension, which really puts spokes into the patient's enthusiasm, as we shall see. So it is the most important aspect is that most of our patients, more than 70% of our patients, are volume overloaded rather than volume depleted. And what is the most important driver of volume overload? It is the sodium excess, which begets volume excess. When you have a patient who cannot stay away from the sodium in food, dietary sodium excess produces increased osmolality of the extracellular fluid, increases thirst, polydipsia, and you have the recipe for disaster, edema, hypertension, and congestive cardiac failure. So there are different definitions. So you know that how important it is to achieve dry weight, not too much, not too little. There are different definitions of dry weight. This is the ideal post-dialysis weight that allows a constantly normal blood pressure to be maintained without antihypertensive medications. The second definition says that body weight at the end of dialysis at which the patient can remain normotensive until the next dialysis without antihypertensive medication, and dry weight is not the actual post-dialysis weight. It is the ideal post-dialysis weight allowing for a normal BP. So every definition of dry weight stresses upon the blood pressure. We'll see whether it is correct or not. The operational definition of dry weight is what we always follow: the body weight at which the patient is asymptomatic, normotensive, on minimum antihypertensives, with a preserved organ perfusion and maintained residual renal function, which is again a very important aspect of especially during the early years of hemodialysis, because it is being linked to the health outcomes and mortality benefits in patients and in patients on hemodialysis. So what do? We don't have access to very advanced technology in most of the centers, so we rely on the physical examination for the volume assessment, like jugular venous pressure. It has been said that any JVP elevation above 3 to 4 centimeters will tell you that there is a volume excess, presence of hypertension, presence of crackles, edema, and weight gain. So this is fraught with lot of variations due to the age, muscle mass, intracellular, the interstitial cell compliance. So can blood pressure be a surrogate for intravascular volume? So almost all the definitions have told us that the dry weight will be low when the blood pressure is well controlled. The dry weight is at optimum levels. So it is correlated with intravascular volume during the peri-dialysis period, but there are issues like vascular calcification, which is extremely important, very prevalent in patients who are on long-term dialysis, and arteriosclerosis and cardiac dysfunction, which act as significant confounders to the relationship. You can have patients with volume depletion having showing hypertension because of the uh, vascular calcification, and also you can have patients with volume overload due to cardiac dysfunction showing hypotension. So you can have two ends of the spectrum are possible. So what do you do? Watching the trend is crucial. An increase in the pre-dialysis blood pressure is a main sign of salt and water overload, and low blood pressure post-dialysis or postural hypotension persisting for a few hours suggest saline depletion. So a very useful and a bedside assessment will be very good. What you do is at the end of dialysis, when you think that you have achieved your ultrafiltration goal, you just ask the patient to wait and do a postural blood pressure assessment, say at the end of half an hour, and see where you are. If there is no reduction in the postural blood pressure, you know that you have not increased ultrafiltration more than required, and if you find that there is a postural reduction, you can to some extent come to a conclusion that you have got to be careful in setting the ultrafiltration goal in the next dialysis. Mind you, there are multiple confounders like autonomic insufficiency, cardiac insufficiency, etc. But these are good bedside tools which will lead the way for you. Medicine is not in black and white, but in shades of gray. Normotension per se does not exclude volume overload, and hypotension during dialysis again does not necessarily indicate that the patient has reached dry weight. So intravascular volume excess you can check with the help of JVP or CVP measurement. Again, not frequently done because of the invasive nature. Edema can be present in advanced stages of saline overload, but a severe saline overload can also exist without edema, which we have repeatedly seen. Patients with absolutely no edema, you do a lung ultrasound, you can see that the lung is clogged with water. So does a protocolized dry weight reduction improve the blood pressure in a hypertensive dialysis patient? So this was a famously quoted trial, the DRIP trial, which was undertaken by Agarwal. You can see that in patients who are randomized for patient who are dependent on the so-called increasing ultrafiltration with looking at the trending of the blood pressure, the systolic interdialytic ambulatory blood pressure came down when you probe the dry weight by a factor of 7 millimeters of mercury, and the post hemodialysis weight came down by a factor of 0.9 kg. The odds ratio for the systolic blood pressure reduction of 10 millimeters of mercury was significant by a factor of 2. But the conclusion is that you can aggressively probe the dry weight and bring down the blood pressure, but mind you, the patients also have enhanced intradialytic signs and symptoms. Now, we have seen the level 1 investigation, which are bedside, which are clinical. What are the other investigations? You can do certain biochemical investigations like atrial natriuretic peptides, which to some extent are surrogates of volume. So you check the ANP levels pre and post dialysis, and if you see that there is no sharp reduction, you can say that the intravascular volumes are still high. Brain natriuretic peptides and the cyclic GMP levels also are best assessed as research tools. They cannot be substituted at the bedside for most of our patients. So what about other investigations? Bioimpedance, Crick monitors, IVC diameter, lung comets, and what the future holds for us. Bioimpedance, again, not available in most of the centers. It is a very good tool which tells us about the extracellular water it assesses the extracellular water. Mind you, extracellular water, as I already told you, consists of both interstitial compartment and intravascular compartment, and our aim, focus is on the intravascular compartment. So bioimpedance falls short of that assessment because it assesses only the interstitial or the extracellular water. On that score, it is not giving us enough indications of the volume excess. So the disadvantages of bioimpedance are the availability and the cost. It is costly. The equipment is costly and identifies ECF water and not intravascular volume or water, and the limb water or the limb assessment versus the trunk assessment is also important. So then it takes us to the next level of the so-called crit line monitoring, where the probe is attached to the hemodialysis machine at the level of the inlet of the blood into the dialyzer, and you can see that it will detect the increasing hematocrit when the water is extracted from the intravascular volume. You can see that the hematocrit increases and it judges the intravascular volume. So when there is an hematocrit increase, there is also a delta blood volume reduction, and this is being looked into, and the patient is able to, we are able to identify. So delta blood volume, when it is kept between -3 to -8%, you can see that the relative blood volume slope is what is ideal and what is safer. When there is a sudden crash of this blood volume, then the patients go in for a hypotension. So has it delivered? So this was a Klein study which was published in JASN 2005, where they looked into the conventional assessment versus the crit line assessment, and lo and behold, you can see that when you have the crit line assessment for the blood volume reduction and you act on that, you can see that the hospitalization and also cardiovascular deaths were increased. So telling us that crit line monitoring will identify fluid overload, but trying to induce deliberate changes in the relative blood volume can be counterproductive. So this takes us to the intravascular volume assessment. Again, these are taken away from the radiologist to the attending nephrologist with the increasing impetus on the point of care ultrasound. You can assess the intravascular, the IVC diameter, and at expiration and inspiration. If there is an enhanced inspiratory collapse, you can see that there is a volume depletion. If there is no collapse, there is enhancing or increasing intravascular volume. Volume assessment in hemodialysis. This is a beautiful study done by Edwin Fernando at Chennai, which was published recently in the Indian Journal, where they looked into the golden, the assessment, that is the CT scan, and they looked into the B lines by ultrasound and also IVC collapse, and they found that significant evidences can accrue if you probe the B lines in the lung, and it can assess, it can tell you whether the patient is requires increasing ultrafiltration to reach the dry weight. So this is what is the outcome of the study, and it also highlighted that the poor sensitivity of the clinical parameters has already been mentioned. Edema is sensitivity is only 40%, crepitations are only 11%, and dyspnea is only 52% to know the increasing intravascular volume. So again, dry weight reduction guided by lung ultrasound on ambulatory blood pressure in hemodialysis patients also has shown up that it is very useful to probe and address the reduction in the B lines in your patients on hemodialysis to reduce the blood pressure. And when you compare the various technologies, you can see that lung ultrasound scores over other methods. So there are multiple newer tools like left ventricular end diastolic pressure measurements from finger photoplethysmography. These are not yet coming to the common use. Cheetah sensors pasted onto the chest, which assesses the changes in the stroke volume, and wearable ultrasound patches and oral sodium sensors. All these are the technology for the future, not yet come to clinical use. What is the Lakshman Rekha of ultrafiltration? It has been shown that 13 ml, you remember the bad number, 13 ml per kilogram per hour is the Lakshman Rekha, which should not be crossed in a patient on hemodialysis. How do you do it? By extending the dialysis time, reducing the ultrafiltration rate, and also you have to educate the patient, most importantly, about the sodium and water restriction. So do practices in management of dry weight assessment and also intravascular hypotension affect the patient outcomes. So these are the DOPS findings, where when a unit is very aggressive about dry weight assessment protocol, you can see that all-cause mortality reduces. And orthostatic blood pressure measurement, very useful, very simple, which reduces the hazard ratio of cardiovascular events. Use of lower dialysate temperature again reduces the cardiovascular mortality. But online volume indicator like crit-line monitoring may increase the hazard ratio, and sodium modeling and profiling again may increase the hazard ratio. So hemodialysis facility practices relating to the management of fluid volume and intradialytic hypotension are really associated with patient outcomes. So I'll just stop with this slide. This is the penultimate slide. Scribner, way back in the 1960s, told us in his prophetic words that in the case of dialysis patient, a low normal level of extracellular volume should be maintained by the powerful tool of ultrafiltration along with dietary sodium restriction, which are the only proven method of controlling blood pressure and volume in hemodialysis population. A statement which stands true even today. So there was a song initiative where they asked the patients which is important from your angle. When the health professionals always think about death, mortality, cardiovascular disease, etc., patients think that ability to travel, fatigue, dialysis free time. So you can see that how patients their inputs are totally different, perspectives are totally different, and what they want from the health professionals are really different from what we want from them. So there is a disconnect, and this is what we have to achieve to reduce the disconnect between these two. The dry weight assessment in hemodialysis, clinical examination has poor sensitivity with a high specificity. When combined with lung comets, assessment becomes better. But mind you, patients may not be very appreciative of your efforts, because if you are aggressive about probing the dry weight, their symptomatology increases. I think I will close down and thank you for this excellent opportunity. Thank you.
Thank you, Professor Sampath. That was an excellent talk, and you sort of gave us the reasons why dry weight is important, why and how do we sort of try and achieve dry weight, what are the various methods, both clinical as well as with diagnostic tools. And as you said, the expression is art embedded in science. I think that's the catchword for this thing. So we'll have a more detailed discussion and questions on your topic at the end of the session. And we'll move on to the next lecture, which is actually the topic is on quality dialysis for preservation of nutritional status. And this lecture will be delivered by Professor A.K. Bhalla. Professor Bhalla is the chairman of the Department of Nephrology at the Sir Gangaram Hospital in New Delhi. He is also has been awarded the Padma Shri by the Government of India, and he is the president of the Society of Renal Nutrition and Metabolism. Dr. Bhalla has extensive work in the field of dialysis, and he would now be talking to us about how do we give good dialysis in order to preserve the nutritional status of the patients. Over to you, Dr. Bhalla.
Thank you, Professor Gupta, for inviting me for this talk. At the outset, I would like to thank Professor Anita Saxena for giving me the opportunity to deliver this talk, and congratulate her for organization of excellent renal course of nutrition and metabolism. After excellent talk on dry weight in hemodialysis by Professor Sampat Kumar, now my next 20 minutes I will be talking about how to give a quality dialysis for preservation of nutritional status. As we all know, actually most of the studies, whatever we have seen in the literature, are about nutritional interventions in dialysis patients. So there are not many studies available in literature about the impact of quality dialysis on nutritional status in dialysis patients. So I'm really glad that Dr. Anita Saxena has given this topic to me, and I could do some research and find some literature on this. Even sound initiative slide by Dr. Sampat Kumar, even when health care professionals, he gave the list. In that list also, in fact, the nutrition was not mentioned. So somehow we always ignore the nutritional aspect of our patients. Actually, that is very important for morbidity and mortality in these patients. We all know that protein and energy wasting is a very common problem in patients of advanced renal failure and patients who are undergoing maintenance hemodialysis. And there are different reports available in literature about the prevalence, which roughly varies from 18 to 75% in adult maintenance hemodialysis patient. So on an average, we can take it around 40%, although some Indian studies give it figures as high as 85 to 90%. In hemodialysis patient, the presence of protein energy wasting is one of the strongest predictor of morbidity and mortality. And in addition, we have it has been shown that 1 unit decrease in BMI increases the risk for cardiovascular death by 6% in these patients. And 1 gram fall in serum albumin level is associated with a 39% increase in risk of cardiovascular death. This picture shows that how the protein energy wasting is affected by loss of kidney function, uremic toxins, then comorbid conditions. Majority of the time patient is diabetic, having cardiovascular disease, psychological factors, then dialysis associated catabolism, then metabolic derangements like metabolic acidosis, hypogonadism, growth hormone resistance, and hyperparathyroidism again has been found as a very important factor leading on to protein catabolism in these patients. Most of these patients are having low dietary nutrition intake. And as we all know, the dialysis itself is a chronic inflammatory state. And that inflammatory states lead on to protein energy wasting in this patient. That's why there is a MIA syndrome, which leads on to malnutrition, inflammation, and leading on to atherosclerosis, cardiovascular disease. Plus, these patients are frail and having depression. And in addition, these patients are more prone to infection, acute as well as chronic infections, tuberculosis being very common in our country. So this shows that how protein energy wasting is affected by various factors. I will discuss my talk in these outlines: dialysis procedure, then dialysis membranes, quality of water, hemodialysis versus online hemodiafiltration, then adequacy of dialysis, and uremia related problems. how these various points impact the nutritional status of our dialysis patients. Now, dialysis procedure itself is a chronic inflammatory state. I think it is a very important point which has to be highlighted, that dialysis itself is a chronic inflammatory state. And certain things are removed, especially in hemodialysis, like amino acids, peptides, protein, glucose, water-soluble vitamins, and various other bioactive compounds. It may promote protein catabolism due to bioincompatibility, but because it is a abnormal artificial surface and blood is coming for 4 hours in every session and maybe 12 hours in a week, and it is coming in contact with water, so much of water, almost 120-liter water in every session, and that all leads on to various catabolic conditions in the body and leading on to inflammation. Even the vascular access itself has been found to be a very major inflammatory factor as in dialysis patient, more so in tunneled catheters or internal jugular catheters, less with AV fistula. Similarly, in CAPD patients, less with Pencroft catheter. Now, as I said, dialysis removes about 10 to 12 grams of amino acids in every session, peptides, and about 1 to 3 grams of protein is lost in every hemodialysis session. This figure can be high in PD patient, may be as high as 6 to 8 grams or 10 grams per day in CAPD patients. Then some amount of glucose also is lost in dialysis, and some of the patients can go into spontaneous hypoglycemia, and we may have to give extra glucose in dialysis to prevent that complication. And there is a release of various cytokines due to bioincompatible membranes. And various endocrine disorders of uremia, right? We have resistance to the action of insulin, insulin-like growth factors, hyperuricemia, and hyperparathyroidism. These all lead on to hypercatabolic state in the body. Then we know that there is a gastrointestinal bleeding in these patients with frequent blood sampling, blood sequestered in the hemodialysis as well as tubing. So that all factors lead on to anemia in these patients. Now coming to hemodialysis membrane, which is the most important part of hemodialysis procedure. Earlier we used to use a cellulose membranes, which were actually natural membranes, but then it were having much more bioincompatibility. Then we had substituted cellulose membranes, which were semi-synthetic, and now we are using synthetic non-cellulose polymers, which are having high permeability, and these are more biocompatible membranes. And as KDO has already recommended that we should use biocompatible membranes in hemodialysis sessions. The various types of membranes are available, like polyacrylonitrile, polysulfone, polycarbonate, polyamide, and PMMA. And these range from low to high flux quality of these membranes. The most common used membranes is polysulfone membrane. Now, what is the impact of this bioincompatible versus incompatible membranes? If we have more of incompatible membranes, then there is a more protein catabolism, more chances of infections. It impacts more residual renal functions, which is very important in these patients, whether it is hemodialysis or whether it is peritoneal dialysis. And pulmonary changes, especially when there is a complement activation and certain microthrombi formation, which gets sequestrated into the pulmonary circulation and leads on to pulmonary compromise, respiratory compromise in these patients. And the same way, residual renal function is also affected in these patients. Now, next is quality of water, how it impacts the nutritional status of dialysis patients. As I mentioned that about 120 liters, if we have a dialysis blood flow of 500 ml per minute, then we have 400 liters of treated water coming into contact with the bloodstream of patients in dialysis patients through a semi-permeable membrane. So quality of water is very important factor, which is responsible for causing inflammation in these patients. A study in Morocco was performed to see the effect of quality of water on nutritional state, inflammation, and need for EPO in these patients. The water treatment was done according to the standard protocol and was monitored regularly during the study period to ensure acceptable levels of bacterial count as well as endotoxin levels. It showed that improving the biocompatibility of hemodialysis with the use of good quality water, patients acquire a better nutritional, inflammatory, and hematological status of these patients. So there was a definite benefit of using good quality water. This just to show that what is ultra pure dialysis solution. It decreases the CRP as well as IL-6 levels. It improves response to EPO. It promotes better nutrition. It reduces plasma levels of beta-2 microglobulins. It slows the loss of renal function. It lowers cardiovascular morbidity. And what are the criteria of definition of ultra pure water is bacterial levels below 0.1 chlorine-forming units per ml and endotoxin levels below 0.03 endotoxin unit per ml. This was a study published in NDT in 2013. Now, hemodialysis versus online hemodiafiltration. So online hemodiafiltration uses ultra pure dialyzed fluid, and biocompatible dialyzers use and works on a combination of diffusive and convective processes for extracorporeal dialysis. So now there are more and more studies, especially from Europe, have come into the literature showing the benefit of online hemodiafiltration. This is how on the left side, this is a 5008S machine, that is where the patient is on online hemodiafiltration and using a F60 dialyzer, which is a high flux dialyzer. And on the right side is a 4008 machine, which is a conventional hemodialysis. There is a cost difference of around 1,000, minimum 1,000 rupees between the two dialysis. This was a study of protein stores preservation study, PSET study, where which showed that high volume online diafiltration on nutritionals, and this was a only study actually I could find its impact on nutritional status. And they evaluated the effect of online hemodiafiltration on nutritional status in these patients. And the hypothesis was that whether conventional hemodialysis versus online hemodiafiltration, there was a better nutritional status after online hemodiafiltration. So they compared these two populations, and they found after 1 year that their patients on online hemodiafiltration had better preserved muscle mass, increased protein intake, reduced inflammatory markers related to uremia and dialysis, supporting the hypothesis that high convection volume benefits nutritional status and prevent protein energy wasting in hemodialysis patients. This was our own study where we compared the level of inflammatory markers in chronic kidney disease patients on online hemodiafiltration versus conventional hemodialysis. This we presented at American Society of Nephrology in 19, I think, where we showed that there was a definite improvement, significant improvement in inflammatory cytokine removal, like HSCRP by 33%, IL-1 by 13%, IL-6 by 33%, TNF-alpha by 22% after 6 months. This was the set of patients, 60 patients who were initially on conventional hemodialysis, and then same patients were put on online hemodiafiltration for next 6 months. And then we compared these inflammatory cytokine parameters. So it may indirectly help prevent development of cardiovascular disease, malnutrition, improved mortality in these patients who are otherwise malnourished, having high cardiovascular risk, and not eligible for early transplantation. Online hemodiafiltration offers improvement in hemoglobin, erythropoietin resistance, serum albumin, as well as phosphate clearance. So this actually impact of water on nutrition, this highlights that how much we should invest on water. And water actually it is a very costly affair. Like plants, I have seen plants at SGPG now, at PGI Chandigarh. All these are actually Fresenius RO plants, and the cost is almost more than 1 crore rupees. But it is worth investing that much money to have the better quality dialysis in these patients. Next is impact of KT by V on nutrition. So this was the study published in 2008, where it was nutritional status of patients by seeing the effect of adequacy. And they did all the anthropometric parameters like dry weight, height, arm circumference, triceps, Steinfort thickness, mid-arm muscle circumference, and body mass index in these patients. And patients were divided into two groups, where KT by V was less than 1.2 and more than 1.2. And they showed that the well-dialyzed patients presented better level of serum albumin, and with an influence of gender and age on correlation of the analysis. So this was the main conclusion from this study, that there was a better level of serum albumin when KT by V was more than 1.2. UK Renal Association Guideline 2010 also mentions that the dose of small solute removal to prevent undernutrition, the recommendation is that the dialysis dose should meet the recommended solute clearance index guidelines like KT by V in these patients. And similarly, now to see the effect of KT by V on nutrition in CAPD, we know that there is a much more protein loss during peritoneal dialysis. And this was a study published in 2003 from Hong Kong by YK Low, where they showed actually that even after 1 year, there was not much difference in the serum albumin and hospitalization rate in these patients, but requirement of erythropoietin was less in patients who were getting adequate dialysis. When the adequate parameter, they had that more than KT by V of more than 1.7 and weekly creatinine of more than 70 liters per week. Now, another very important factor, which now we have started recognizing, is metabolic acidosis. And now you must have seen that most of the patients are actually on soda bicarb oral tablets since last few years. So mid-week pre-dialysis serum bicarbonate levels should be maintained at 20 to 22 millimoles per liter. In patients with venous pre-dialysis bicarbonate persistently less than 20, oral supplementation with soda bicarb and increasing dialysis concentration to 40 should be used to correct metabolic acidosis in these patients. Because again, the metabolic acidosis has been found as a very important factor leading on to chronic inflammation as well as protein energy wasting in these patients. Coming to various vitamin loss during dialysis, we know that water soluble vitamins are lost during dialysis, and there is a level 1C recommendation that these should be prescribed in these patients, like thiamine, riboflavin, niacin, pantothenic acid, pyridoxine, biotin, folate, cobalamin, and ascorbic acid. Yesterday, Dr. Georgie had shown very nicely the role of exercise in these patients, how exercise benefits, even slows down the progression of CKD. In hemodialysis patient also, that they should be encouraged to do regular exercise. Even during dialysis sessions also, we should encourage them to do some kind of exercises, even like they can do some cycling also while move their legs while they are lying on the bed for 4 hours. Anabolic agents that they are not routinely recommended. However, they have demonstrated some improvement in serum albumin level and lean body mass, but not mortality, and these medications have significant side effects. So there is no clear-cut guidelines to give anabolic steroids and agents to these patients. As far as oral nutritional supplements, there is a whole lecture by Dr. Umesh Khanna, so I will not discuss, but there, if the patient is not able to take orally, then even oral as well as parenteral nutrition should be given to these patients. To conclude, the dietary prescriptions, apart from dietary prescriptions, correction of metabolic acidosis, therapeutic interventions for comorbidities, adequate dose of dialysis, intervention on dialysis techniques, membrane type, seeing the quality of membrane, and overall dialysis quality. If we monitor that, definitely it is going to improve the nutritional status of these patients. And this is one of the very important therapeutic intervention in malnutrition of our dialysis patients. Thank you.
Thank you, Dr. Bhalla, for this very exhaustive and a very detailed talk, where you emphasize the need for improving the quality of dialysis in order to improve the nutritional status of the patients. And I'm grateful that you brought out some very important points that many of us tend to forget. We'll have a more detailed discussion on your lecture during our panel discussion. And it takes me great pleasure to also invite my co-panelist, Dr. Sundar, who has joined. And Dr. Sundar and I, we go back a long time. We both took our DNB exams together in 1986. So it's been a long friendship since then.
Thank you. Thank you, Amit.
It's nice to see you, Sundar.
Thank you.
You lost more hair, I guess.
I know. Losing more thanks to phone calls for getting beds and in the hospital.
Yeah.
One is continuously ringing for beds for ICU admissions.
I know. So I'd like to now invite Professor Ashok Kriplani. Dr. Kriplani is one of the foremost and the senior-most nephrologists of the country, a very well sought-after nephrologist who, by patients as well as his colleagues from across the country, and has made a name for himself even across the world. Professor Kriplani has extensive experience in the field of nephrology, spanning well over 40 to 50 years in this field, and has an expert on the field of dialysis and hypertension. Professor Kriplani has been the past president of the Indian Society of Nephrology, and he would be speaking today on the rationale for high protein and high energy intake in patients of chronic kidney disease in stage 5 who are on dialysis. We talk about these patients requiring protein, high protein and high energy, but we need to understand why this is so. And there'll be no better person than Dr. Kriplani, who's an excellent speaker, who will take us through this topic. Over to you, Professor Kriplani, please.
Good morning. Thank you, Amit, and for having me on this conference, which I have been attending every year, and Dr. Saxena for inviting me to do this talk on the pathophysiology of what already, luckily for me, Dr. Bhalla has already introduced the subject, and I have to now only explain the rationale of why we need much more protein when we shift from non-dialysis CKD to dialysis CKD. And just to inform Sudhir, I hope you are there. I'm going to share my slide, Sudhir, so you don't need to change. Just please confirm that you are able to see the slide, and I'm sharing it with you, and I will be changing the slides. Sudhir,
Yes, sir, please. Yes, sir. Yes, sir. Please.
I'm
Please
doing
share.
my own slides. Yeah, thank you.
Okay, sir.
All right. So Dr. Bhalla has very nicely shown that there are major issues in dialysis. I will change the slide now. Yeah. I will change the slide. Yeah. So they very nicely shown that there are major issues when you switch over to dialysis in protein metabolism and what is properly known as protein energy wasting during maintenance hemodialysis. So we see here today.
Sir, sorry to interrupt you. Sir, sorry to interrupt you. Please share your slides, sir.
You're not able to see?
No, sir.
Oh. Just a minute.
Sir, please open your PPT first, and then there is a green button called share screen, and click on that and select the PowerPoint and share.
About now?
Yes, sir. Now it's
Yes,
visible.
sir, we can
And
see it.
please
And you
go to the
can
full screen mode, sir.
screen, yeah.
Yeah.
Is this okay?
Yes, sir. Yes.
Got it? Okay.
Hello, Sebastian.
Yes, sir.
Yeah. So we are going to look at the rationale. Yeah, I'm just going to speak on the rationale, the pathophysiology. So if you see today's KDIGO guidelines on non-dialysis, you will look at the dietary protein intake advised, and you would be shocked to see 0.55 to 0.6 dietary protein per kilogram of ideal body weight, not total body weight, but ideal body weight. So today, what is being recommended for non-dialysis patients who are trying their best to reduce the progression from non-dialysis to dialysis by every which possible way, this is a recommendation, and the addition, of course, of additional keto analogs reduces the requirement to almost 0.4 per kilogram of ideal body weight. Now, keeping this in mind, those who are clinical practitioners of nephrology like myself will be shocked, and the dietitians will be shocked when I tell them that this is the new recommendation. And what it is going to do to the patient when he reaches dialysis, and what condition is he likely to reach, given that we Indians particularly are not able to maintain as much protein intake as the ordinary American does. So let us see the rationale for that recommendation. Brenner said that there is hyperfiltration. Hyperfiltration causes renal reserve within the single nephron glomerulus GFR, single nephron GFR, and extends and exhausts the renal reserve. And this hyperfiltration is driven by two things: high blood pressure, intraglomerular hypertension due to that, and protein overload. Next slide. And these are the uremic toxins, which we know come from nitrogen mostly, and almost effectively only from nitrogen, not from carbohydrate and fat. And these are the toxins which accumulate and cause the severe uremic effects on the metabolism. Next slide. Now, what is the current recommendation for patients on maintenance hemodialysis? 1 to 1.2 grams of ideal per kilogram of ideal body weight. And together with this, in both recommendations, there is a need for 35 kilocalories per kilogram ideal body weight. So the patient, when he is restricting his protein, has to eat enough carbohydrate and fat to produce that many calories. And we really have a major issue because 40 to 50% of patients in CKD for us are diabetic, and the diabetic patient does not want to increase his carbohydrate intake. And if he does not increase his carbohydrate intake, he is going to chew on his muscles and get the calories from his muscles. And I'll show you the picture of the neoglucogenesis that is required from the muscles. And that is where his muscles start wasting, and condition in which he appears in the dialysis unit for the first time is quite unacceptable. And not only that, you will see that the shift over from the patients, you may think that the patient will be very happy to eat that much protein, but you will see that is not going to be that easy. And we have our diabetologist colleagues and the diabetic dietitians who will protest that you are increasing the carbohydrate calories, and that is going to make the glucose control difficult. And this is where the interaction leads to major issues and causes the patient to arrive in the dialysis unit for the first time in a bad shape. Also, a large number of patients arrive for the first time in dialysis having never had any metabolic control prior to that. So they are Those are the ones who do not work by lysis, they work by crisis. They suddenly come with uremia. So you can imagine their condition. Next slide. Now, what does protein energy wasting in hemodialysis result in? It results in high risk of hospitalization, high risk of death, and most important, our patients are getting ready to get transplanted. And post-transplant outcomes depend particularly on the condition in which you transplant the patient. And this leads, if the patient is in protein energy wasting state, to poor wound healing, increased risk of systemic and local infections, and protein catabolism in the post-transplant immediate period. The operation itself is a severe burden on the body metabolism, and many good patients after the surgery will have a serum albumin of 2.5. And in addition, if they already arrive to the dialysis, to the transplant table with 2.5, you can imagine how difficult the post-op period will be. Now, these are the nutritional parameters that textbooks will tell us to use, and there are so many to assess the condition of nutritional state prior to starting the dietary treatment and modifying periodically accordingly. But the most important ones that we use clinically are these 5. The less than 85% of ideal body weight is an excellent parameter. And during dialysis, the patient continuously being reevaluated and reducing his dry body weight will tell us that the patient is in a protein energy wasting state. Ideally, one should have every month serum albumin tested and also serum cholesterol. And many patients are thrilled to see a cholesterol of 34, but I'm not. The serum albumin ideally should be less than 4. The pre-albumin less than 300, which we don't routinely do. The dry weight should be assessed. And of course, those units which do more aggressive assessment, the subjective global assessment is available. But the important way to make out the inflammatory state is the CRP. So it's very useful every month to do the CRP. And that gives us a warning that things are not going well. And very importantly, in the past, when there was no KT over V, we used to look at the pre-dialysis creatinine. And the patient would come back with a creatinine of 10 and complain, sir, see, my creatinine is not going down. And I would have to try and explain to him that look at this next door fellow whose creatinine is 5 pre-dialysis and see how unhealthy he is and how healthy you are. So the creatinine pre-dialysis was a good way of assessing the nutritional state of the patient. Now, looking at this chart and trying to explain to you what exactly is happening, you see that the malnutrition in these blue lines down here, how do I move this? Yeah, this, yeah. So you see 2 factors. Oh my, sorry, leave it. Dialysis-induced malnutrition is on the left side, and the non-iatrogenic factors for malnutrition are on the right side. And this complex slide tells you that due to poor appetite, alteration in taste, there is low energy and low protein consumption. You see the diet quality is low. The monotony of the diet prevents the patient from eating, and there is impaired transport and metabolism and glucose of glucose and amino acids, leading to gluconeogenesis, which requires energy, and that energy is pulled out from the muscle proteolysis. And you have inflammation coming from dialysis access factors, dialysis inadequacy, dialysis frequency and duration being less, dialyzer membranes producing problems, and dialyzer reuse causing problems. So these are iatrogenic on the left side and non-iatrogenic on the right side. So you have this protein energy wasting, which is due to 2 things: exaggerated protein degradation and decreased protein synthesis. Now, the factors of malnutrition, I will show you in the next 5 slides. and how to understand them. First of all, most important, as I explained to you, the previous malnutrition. I've explained that in detail. I've explained to you the reason for previous malnutrition. Large amount of it is due to the advice that the patient is getting. Secondly, the reduced protein energy intake, which is due to inadequate counseling, anorexia, taste disturbances, digestive side effects of drugs, and frequent hospitalization. Every time you go to hospital, you get hospital food, and there are 4 or 5 procedures. There's a scopy, there is a fistula and NBM, etc. All these add to poor intake. The anorexia is mostly explained by multiple factors. The uremic toxins produce anorexia, and the amount of leptin available is increased, and leptin is a satiety hormone. It doesn't allow hunger, and leptin degradation and excretion is poor in dialysis and in CKD. Therefore, the leptins increase and cause anorexia. Many patients have peptic ulcer, gastritis, esophagitis, diabetic gastropathy, which delays emptying time and gives us a feeling of fullness, doesn't allow the patient to eat well. And many unpalatable medications like calcium, sevelamer, it tastes like chalk, and many patients eat it halfway through their meal because it's necessary to eat together with the meal, and you can't take it separately. And of course, the soda bicarb, you know, the original soda bicarbs were made as digestive tablets, and it was written there to chew or to suck, and this causes blisters in the mouth. So luckily now we have soda bicarb preparations which release outside once they have gone into the duodenum because of the way they are prepared. But they give gassy sensation, distension, and large number of tablets are going on, 3 to 4 tablets a day, 3 times a day, so 9, 12 tablets. There are psychosocial ideas, and deliberately many patients try, even during dialysis, to eat less protein, because they've already understood from prior that this is going to reduce the generation of uremic toxins, and they don't want to come 3 times a dialysis. So they keep telling me, doctor, don't worry, I'm not eating protein, please let me do 2 times a week dialysis, not 3 times a week dialysis. And the other factors are primary intercurrent illnesses. You know that, and our data has shown that 1 in 6 of every CKD that we look after has TB. And that adds to the severe malnutrition state, lack of appetite, and poor health. A large number used to have hepatitis B before, luckily not now because of the immunization. But there are still hepatitis C. Luckily, hepatitis C is curable, but many are not treated. And their appetite and their treatment is very difficult, expensive, so they eat less. Add to it, in the terminal stages of liver disease, gluconeogenesis from the liver doesn't take place well. And when you do dialysis, especially if you do dialysis without glucose, glucose is excreted out into the dialysis fluid, and that causes the patient to release glucose from the liver. But if the liver is bad, you get spontaneous hypoglycemia. And these all are energy wasting processes leading to muscle wasting. So glucose in the dialysate, if you put it, it's got problems. If you don't put it, you waste glucose, and that's where energy gets wasted. And that's where you need more energy. And so reduced dietary intakes, catabolic state, and chronic inflammation, as shown by CRP. Next slide. So you see here the CKD causes uremic toxins, causing increased CRP, increased nitric oxide, increased inflammatory interleukins and adhesion molecules and adipokines. All of these lead to malnutrition, atherosclerosis, coronary artery calcification, and a different type of coronary artery calcification. It's not the point-to-point that you see in the ordinary high cholesterol atherosclerosis. This is a medial, what used to be Monkenbeck type of sclerosis, not in the intima, but in the media of the vessel. And this, it's not an endothelial calcification, but a medial calcification, very difficult to stent, very difficult to operate upon, leading to heart failure, anemia, and mineral disorder. That's MBD. So you have this syndrome called malnutrition, inflammation, atherosclerosis, worsened by the lack of protein, which increases all this vicious circle. Next slide. And you see in this study from Japan, this is, they took 61 patients who had high CRP. Out of these, 30 had the combination of cardiovascular disease, malnutrition, and inflammation together, and separately 13, 16, and 11 had these individually. And the survival rate, depending on the number of comorbidities seen, increased from 0 to 3. The survival worsened, as you see in the lower slide. So you see here that then come the endocrine and metabolic factors. As Dr. Bala has explained, protein metabolism causes acidosis, and acidosis causes worsening of malnutrition and adds to this MIA syndrome. Additionally, anemia, inadequate removal of uremic toxins, hyperparathyroidism and FGF23, hyperleptinemia and growth hormone resistance, and IGF-1 in insulin-like growth factor resistance, all add to the malnutrition. And then come the dialysis related factors. The inadequate KT-OV, how many of our departments really are doing KT-OV? And if you started doing it, you'll realize vascular access problems, inadequate frequency of dialysis, inadequate volume of dialysis. Most patients will have low KT-OV. Add to it, we have now all shifted from the cuprophane to the cellulose acetate to the polysulfone and the synthetic membranes, but all bioincompatible membranes used to liberate complement factors and activate interleukin, causing chronic inflammation. Additionally, if the water is not good and you have endotoxin, you get backfiltration of endotoxin into the patient, and that adds to the malnutrition. There are also, I will show you in the next slide, which luckily Dr. Bala has shown, the amino acid and protein losses and vitamin losses, because of which, next slide. So the nutrient losses in cuprophane membranes were very high. Free amino acids, 4 to 9 grams, 2 to 3 grams of free peptides. In the high flux dialyzers, the nutrient losses were less, but the albumin losses started because the porosity of the high flux dialyzer is higher. And you know, we use for myeloma high cut dialyzers, which remove protein in large amounts. So you get large amount of protein loss. So you get, in the higher the flux of the dialyzer, more is the albumin loss. And if you keep reusing the dialyzer, especially if you reuse the polysulfone with bleach and formaldehyde, more than 10 times you have large losses and loss of efficiency of the dialyzer. Additionally, I mentioned the glucose in the glucose-free dialysate. And if you use glucose dialysate, you get ants and fungus. And if you don't use, you get extra gluconeogenesis with energy consumption and muscle protein losses and muscle protein proteolysis. Next. So then in my last 2 slides, I would like to say that these are the interventions that are necessary, which unfortunately you have been taking it up in various forms now. There has to be adequate dialysis dose, and the adequacy has to be checked. So daily dialysis is a good form of getting over this issue. Correction of acidosis and supplementation of dialysis correction with oral tablets. Even if you see the pre-dialysis value and you find a potassium of 5.8 and bicarb of 16, then during that interdialytic phase, correction of acidosis is necessary. Oral and enteral dietary supplementations, which of course will be spoken to us by Dr. Khanna. Parenteral nutrition, interdialytic and intradialytic. So interdialytic interdialytic parenteral nutrition, various fluids are available, growth hormone, EPO, all correct these issues. And finally, to improved outcomes, the most important is a trained dietitian. If you don't have trained dietitian, nephrologist cannot be a trained dietitian. Dietitian has to have time. Nephrologists don't have time to talk about calories and NPA, etc. And patient information is very important. Patient should understand why this is being done. Additionally, if he cannot get palatable food, because even though you are increasing the you're increasing the protein, the potassium, sodium, water are still restricted during dialysis. So the use of nutritional supplements is very good for these patients. Dietary advice, increase in energy, talking to our diabetologist and saying, look, don't worry about the high glucose. First of all, the higher insulin levels will take care of the high glucose as the CKD gets worsened. But please allow me to increase to 35 per kilo body weight using ideal body weight. And most important, don't forget to monitor. Frequent monitoring of the items that I mentioned are most important for handling these cases. Ladies and gentlemen, I thank you for your kind attention. It's been a little bit of a stop sharing. Bit of a boring subject, but physiology is always a little boring. I've tried my best to make it clinical, practical, and any questions I will answer at the end.
Yeah, Professor Kriplani, you've done a great job, a marvelous job in making this topic so interesting. And you've emphasized the importance of improving the nutritional status of our patients and what is the reason and the rationale behind doing so in order to achieve better outcomes. The most difficult aspect is to try and make the patients eat better once they've started on dialysis, because they are used to a certain dietary regime prior to starting on dialysis, and many of them just don't want to sort of eat differently once they're on dialysis. Now, we have 3 more topics in the session, but I think we can have a few minutes of question and answer related to the 3 topics, and I'll request Dr. Sundar, my co-panelist, to make some comments on the 3 lectures that you have had. And if there are any questions relating to them, we can take them right now. Dr. Sundar, would you like to talk about the importance of dry weight and any comments on that, as well as the comments on the quality of dialysis and about the rationale of improving the dietary intake? Sundar, you're muted. I think you have to unmute yourself.
Thank you, Anita and Amit, for calling me here. In fact, it was quite a surprise. I just got back from my walk and I had my breakfast in between. And I start out with Sampath. I think he spoke eloquently on the dry weight issue, which is an important factor in our dialysis management. And Sampath, you rightly said about what patient wants is different from what we want.
Yeah.
I can remember actually when I had my own heart attack and was admitted in the hospital, my cardiologist worried about my stent and other things, but I was more worried of my constipation.
Yeah.
My transplant patient used to tell me, sir, constipation. Those days I used to ridicule them. I give you a transplant, your life is saved, don't bother about constipation. But when I became a patient, that constipation was more important than anything else. So I think your point is very valid. We have to look at it from the patient's perspective. That is one. Then the talk by Balla, I think Balla, my good friend, he's done such a good talk. I don't think I can comment anything. It's a difficult topic. So I would leave to the audience to comment on that. And as usual, Ashok, I am his fan actually, Ashok Kriplani. And I still remember the first talk he gave in CMC Vellore when I was doing my nephrology. He said, I'm coming from Bombay with sullied hands. He said, because those are unrelated transplant was going on. And then what he used to say about dialysis in those days, which is true, is only people like, the underworld, the ambassadors, and the VIPs would get dialysis. Now things have changed. I think now down the line, in the last 35 years, Amit said that we took the exams together, 35 long years. And Ashok, as usual, has made this topic, a difficult topic, simple. And I find this quite often, most patients, you tell them you've got CKD, the first thing they tell you is I've been asked to stop dal, I've been even a vegetarian. In my own opinion, I'm a vegetarian. I know that for a vegetarian, whatever you do, the protein intake is not more than 40, 50 grams. And for a vegetarian, normally I don't restrict proteins in my CKD patients. So I think it's very important what you stress on these factors. I think I'll open the discussion to the panel and we'll go ahead with whatever you have. Amit, please go ahead. Thank you.
Yeah. Sampath, I have a question for you.
Yeah.
I mean, you gave us ways and techniques of how to sort of determine dry weight and achieve it.
Yeah.
But what is the practical thing that you do in your patients? I mean, how do you go about achieving your patient starts on dialysis? Sort of, how do you what is the ultrafiltration that you order? So if you can tell us, and that things are simple.
Most often I rely on the clinical parameters only, even though literature tells us that these are all very poor guides. I don't have access to regular lung ultrasound, regular IVC assessment.
Most of us don't actually.
Yeah, we don't
So,
have.
so, so,
So
so
it is only a clinical assessment, and also the generally we take the hypertension as the surrogate for the fluid, and
so the patient comes with a weight gain of say 2.5, 3 kilos, or maybe even 4 kilos at times.
Yeah.
So do you sort of advise a greater ultrafiltration than what he has gained weight to go and gradually bring his weight down? How do you do it?
no, rather than again I don't go beyond say 2.5 to 3 liters in a 4-hour session. Whatever be the weight gain, I always tell them to come back for more frequent dialysis rather than achieving ultrafiltration in a single dialysis.
Yeah, Professor Kripalani has something to say. Yeah.
To Sampath, I think you have made a very valid point. Whatever the weight gain, any attempt to remove more than 2.5 kilos in 4 hours is going to lead into some disaster. 95% of the patients will go into hypotension, but 5% will go into hypertension. Now, there are habitual offenders. So what I do for these people is to tell my technician first 45 minutes pure ultrafiltration, no dialysis. Remove water 1 kilo in that period, nothing much happens. And then reduce his dialysis or give him 45 minutes more and let him have 4 hours of dialysis. That helps. Otherwise, in 4 hours, removing 4 liters from 6 is going to create trouble. I mean, it's the physiology. So this is my method. Remove in pure ultrafiltration, no dialysis, 1 kilo, and then take off another 2.5 in 4 kilos. But I mean, there are habitual offenders there. You cannot win from them. And on Monday morning, the 3-day gap, or Tuesday morning, the 3-day gap. This is the biggest problem. Even the the compliers will have this difficulty on Monday and Tuesday morning.
K.C. Prakash has a point to make, I think.
Yeah, there are two issues. One thing is regarding the weight gain. There are many patients nowadays with this long-term dialysis patients. There are many who don't obey the rules. I have got patients gaining 4 kilos, 5 kilos. What I do as a punishment, I call them for 1 extra dialysis.
And pay more.
That doesn't deter them. That doesn't deter them. So I was just thinking that why not extend the dialysis? Like in our 1 unit, satellite unit, what we have done, we will charge you the usual charge for 4 hours. Next, for 5-hour dialysis, extra 1 hour, you have to pay 250 rupees extra. For 6-hour dialysis, you have to pay. So extend the dialysis and try to remove. See, we're leaving them with 2.5 liters removal alone. In these habitual offenders, they land up with cardiac problem. They land up with severe cardiac failure. It's a catch-22 situation, but we can't help it. In this, we have to do something good for them, though they are disobedient. That's one thing. Second thing is, what I wanted to ask Sampath was, Ballal. No, I'm sorry, again, Kripalani, how frequently...
You're getting old, Prakash.
How frequently, Kripalani, do you ask your dialysis patient to be reviewed by the dietitian?
I have 2 dietitians in my clinic. They work 4 hours each every day. At each visit, after finishing with me, they go back to the dietitian. We also have 1 dietitian in the dialysis unit. So when they have difficulties, when we visit the dialysis unit, I refer to the one who is there. Otherwise, the 2 part-time technicians, at every month, the patient comes to my clinic to be reviewed, which is not in the hospital, is outside the hospital. Let me clarify. So it is like 10-15 minutes is available to them. Of course, if they want to catch their bus, I can't help it. But they are allowed to sit, and when I have potassium problems, I make sure that the dietitian comes to me and then takes him there. Otherwise, he'll run away and not attend. So it's difficult. Diet is, but without a qualified technician, dietitian, you cannot enforce these things. I'm quite certain that we have to improve the extra services to our dialysis patients. This is the problem, that we have to have social worker who says, paisa nahi hai, kya karne ka hai, kidhar se lane ka hai, how to pay. These 2-3 things, if we do, we improve the quality without improving anything else in the dialysis. These are support services, without which we are going to have trouble.
No,
that's
does
a
your
very important point
dietitian?
that you made, Dr. Kriplani, that it's a very important to have, I'm sorry to butt in because we are running short of time. Just one question, last question, Dr. Anil Bhalla, that you said that the quality of dialysis plays a very important role, and you showed us the various types of dialysis machines that are available in the market. Unfortunately, unlike Gangaram Hospital, which has the best machines available, most of the peripheral centers would do with uh, lesser quality of machines. Now, so what would be your suggestion to them, actually, because they can't afford to buy very expensive machines?
Yes, sir.
And as
First
well
of
as the dialyzers
yes,
that
sir.
you suggested, the high flux type, which
Yes, sir.
again are difficult to, more expensive.
First of all, sir, I would like to make a comment that now we have to change our mindset of twice a week dialysis or thrice a week dialysis, as we were doing 35 years back. Now we have to adjust ourselves, our practices to patient's choice. So now time has come to start nocturnal dialysis, daily dialysis, or as Dr. K.C. Prash was mentioning, if patient is not following adhering to the guidelines of fluid intake, then maybe extra dialysis. So the time has come now. There is a significant number of population in our country who can afford anything. So we must have the best setup available in our country, apart from for those who can afford or who cannot afford. So all kind of facilities have to be there. In our dialysis unit, we have 52 machines. Out of 52 machines, now 32 machines are of online hemodiafiltration. The Fresenius 5008, which costs about 11.5 lakh rupees. As I mentioned, our RO, double RO plant costs about 2 crore rupees. So we have to, now, once the patient has been put on online hemodiafiltration, he will never go for a 4008 machine. So that is the kind of difference. That is the feelings of the patient, how comfortable he feels. Itching is less. Intradialytic hypotension is much less. BP variability is much less. So that is very important. So another, just one comment more is about interdialytic weight gain. A European best practice guideline had mentioned it as that 4 to 4.5% of dry body weight is the ideal interdilated weight gain, which is allowed. So maybe that, as already Dr. Sampath has mentioned, that we should never do ultrafiltration of more than 3 liters in these patients, because that creates more problems to these patients. So I think we should adhere to if they can have control over interdilated weight gain.
Okay, since we're running out of time, I think we'll sort of stop the question answer session and panel discussion on these 3 lectures right now. And
Dr.
we move on to the next. Yes, please.
I'm just saying goodbye because I have to do another talk at 11 o'clock. You know, we are suffering from a disease called webinaritis. So I must.
So, thank you, Dr. Kriplani, and it was wonderful
seeing everybody. It's such a pleasure to meet up again, Prakash.
Yeah, thank you so much indeed.
Amit, Sundar, Sampath.
Thank you, Ashok. Bye.
I'm leaving the meeting. Thank you.
Take care. Take care. Bye.
So we'll move on to the next part of our session, and that will deal with the peritoneal dialysis and on certain other issues. So may I request the organizers to start the video on PD.
So what is peritoneal dialysis? It is a treatment that removes waste products and extra fluid from your blood, and it is often called PD for short. In PD, your blood is cleaned from inside your body, not outside. Many people consider this an advantage over hemodialysis. PD is done every day, 7 days a week, and you do it yourself. The fact that it's done daily is an advantage because salt, water, and waste products never build up in your body.
To do PD, you'll need a soft tube called a catheter placed in your belly. This is done by minor surgery. There are 2 main types of PD. The first type is called CAPD, which stands for Continuous Ambulatory Peritoneal Dialysis. In this type, you will connect the catheter to a special tube that allows 2 to 3 quarts of a cleansing fluid to flow into your belly. The cleansing fluid is called dialysate. It takes about 10 minutes for the cleansing fluid to fill your belly. Once that's done, the catheter is capped so that it doesn't leak. What happens next is an amazing process. The lining of your belly acts as a natural filter. It lets the waste products and extra fluid in your blood pass through it into the cleansing fluid. At the same time, the lining of your belly holds back the important things your body needs, like red blood cells and nutrients. The cleansing fluid must stay in your belly for several hours, depending on your body size and how much waste has to be removed. This time is called your dwell time. Afterwards, you drain the cleansing fluid from your body into an empty bag and then throw it out. You repeat the in and out process usually 3 to 4 times per day using fresh cleansing fluid. This process is called exchanges. Because it cleans your blood while it's inside the body, it can be done anywhere and any time, at home, at work, or while traveling.
The other main type of PD is called APD, or automated peritoneal dialysis. In this type, a machine called a cycler does the exchanges for you while you sleep. In APD, you'll connect your catheter to the cycler at night before you go to sleep. You will not be doing the exchanges yourself during the day. Instead, the cycler will do the bag exchanges for you, automatically filling your belly with fresh solution and automatically draining it out. The cycler is a mechanical way of doing the exchanges for you while you sleep. Except for this, CAPD and APD are the same process. The type of PD you choose will depend on your lifestyle and your preference. You may start with one type of PD and switch to another, or you may find that a combination suits you best.
Let's pause for a quick recap about the 2 different types. In one type of PD, you do the exchanges yourself, usually 3 to 4 times a day. No machine is used. In the other type, a machine called a cycler does the exchanges for you while you sleep. In both types, blood never leaves your body, and you will need a catheter permanently placed inside your belly.
Okay, so we've had this video which gives us a brief introduction about what is peritoneal dialysis, etc. And the next lecture actually will be on the understanding of the basics of peritoneal dialysis. And the person giving this lecture is one of the pioneers in the field of peritoneal dialysis in this country, Dr. K.C. Prakash from Chennai, who is the chief of nephrology at the Apollo hospitals in Chennai. And Dr. Prakash, after Dr. Georgie had started the CAPD in India, Prakash had sort of started his program at the Apollo hospital, and it became one of the largest programs in the country. And Prakash has an excellent experience in the field of peritoneal dialysis. So it will be a pleasure to listen to Dr. Prakash about the basics of peritoneal dialysis, both CAPD and APD. Over to you, Dr. Prakash, please.
Able to see my slide?
Oh, you have to share your slides. You will not be able to see.
Oh, no, it disappeared here.
You have to open the PPT first, then share.
PPT is opened.
Then you can share.
You can see a button.
Share screen button.
Share button has disappeared. It was there.
But I got it.
You got a magic computer, I guess.
No, I think I'll go and open it again. No, I'll go to the Zoom link and again I'll open it.
Now, can the organizers, you shared your slides with the organizers, isn't it? So they can.
I've already shared.
Yes, sir, we can share. Arnav?
Okay.
Yeah, the organizer is able to share.
Where is Prakash? He seems to have disappeared.
He's probably trying to rejoin, I guess. I mean, I don't know.
Along with the green button, I think he also has disappeared.
Yeah. Can we then?
Okay.
Yeah,
Can see?
is back.
Can see the slides?
No, we can't see your
We can
slide.
see you. We can see you.
Now I
We can
think
see
the organizer, I don't know, I have already shared.
But where is your green button?
Arnab,
Oh, while
you
other
can share, please.
participate, somebody else is sharing the slide, it seems.
Sir, now you can try, sir. Please
Try
open
now.
your PPT, and there is a
Open
in
PPT
the
first.
Sorry,
Open the PPT first.
I opened already.
Then
And
the
then you
green
go
button.
to share screen.
Then go to the green button.
No,
Share
green
screen.
button is not there, it's gone.
How is it? I am seeing the green button in my screen. What is it? How is it
In
gone?
your screen, it might be.
No, just raise your cursor a little above your this thing. Raise the cursor.
Go exit from the full screen, then you may be able to see it.
No, I think he has exited totally.
अर्नब आप शेयर कर दो स्लाइड्स को.
Is someone sharing the slides?
Yes, sir. Yes, I'm just sharing.
But where is the speaker on?
Sir has left the meeting and rejoined me.
Dr. Prakash, on behalf of you, our technical team was already shared the slide. Please command next slide. They will put the next slide.
Okay. Now, can you see the slide?
Is that the first slide about video introduction?
Amit, can you see the slide?
Yeah, we can see one slide, but that's written about video and
Anna, please.
About video. About video.
Go to next slide.
Yeah. We can see this.
Initially, I would like to I should thank the organizers and Dr. Anita especially for inviting me for this talk. And with all difficulties in sharing slide, which I have been facing first time in Zoom meeting here, I don't know what's the problem with me. I don't blame anyone. I would like to talk few slides about the video, what you saw. It just in nutshell spoke about the types of peritoneal dialysis, how easy it can be done, and what are the advantages. I'll be talking subsequently about the basics of peritoneal dialysis. Now, peritoneal dialysis, as most of you know, is a process of removal of waste products from the body. It's carried out inside the body, not outside the body, like in hemodialysis. This is considered as an advantage that everything is happening in our body. And this is done 7 days a week. So this prevents accumulation of salt, water, and toxic waste products. Next slide, please. Now, there are two types of peritoneal dialysis. One is called CAPD, that is continuous ambulatory peritoneal dialysis. The other one is automated peritoneal dialysis. Next slide. CAPD is carried out manually to a catheter implanted surgically. A dialysate fluid, which is also called cleansing fluid, is infused into the peritoneal cavity. The fluid is kept for 4 to 8 hours, and that is called dwell time, depending upon the patient's characteristic and the test results of clearance and PET results. During this time, the peritoneal membrane removes toxins and water. The peritoneum holds back certain important things like nutrients, not totally, but reasonable amount. Then the fluid is drained out. This whole cycle, that is infusion, dwell, and draining out, is called exchange. The exchanges in CAPD are done by self, the patient himself or herself. And one may require 3 or 4 exchanges every day during 24 hours or a daytime PD. Next slide. APD is automated peritoneal dialysis carried out by the machine called cycler. Exchanges are carried out at night. Patient not performing the exchanges manually. The cycler is programmed for exchanges. That's number of, that's duration of dwell time, the amount of fluid, and etc. The type of PD, either automated or CAPD, depends upon the lifestyle of the patient and patient's choice. Next slide. So now coming to my talk, understanding basics of peritoneal dialysis. I'm not going in depth of the peritoneal dialysis. That's what I was told to understand. So next slide. Now, when you look at the history of peritoneal dialysis, it all started in 1923, where Ganter applied the PD technique in humans, and the same year he published his work. Till 1946, nothing much was done, and then Fine et al., they performed intermittent continuous irrigation of peritoneal cavity. That turned out to be the basics of peritoneal dialysis. Then in 1959 came the development of catheters. Prior to this, they were using glass tube and etc. for installation of fluid. But 1959 came the nylon catheter period and then PVC. And then Koff in 1968 designed his first PD catheter, which is still being used now and named after him. Monchreff and Popovich in 1975 demonstrated continuous peritoneal dialysis. That is, the dialysis is going on in 24 hours. Only problem was he was using glass bottles at that time because the collapsible bags were not available. And this used to cause hell of an infection at the rate of 3 to 6 patient months. That's every 3 to 6 patient months of patient on dialysis, the patient used to pick up an infection. Next slide. Then came the real change. In 1977, Aureopolis used plastic wearable bags with spike system. Till then, the patient will go to the hospital, be on dialysis, disconnect and come back. While so many times disconnection and connection led to infection. But after wearing plastic wearable bags with spike system, the disconnection and connection was very less and the incidence of peritonitis came down. Then in 1980, Bon Christiani devised Weisset, which again was further improvement than spike system, single tube dialysis designed by Aureopolis. And this flush before fill technique also further reduced the peritonitis rate. And in the same year, Bazzato devised double bag system, that's twin bag, which we are using even now. And with this further, the infection rate came down. And then Buxo designed APD or CCPD, which has been modified since then. It was a bigger machine. Now you have smaller machines. Next slide. So what happened with these devices being modified every few months or few years? There was reduction in peritonitis from 1 in 3 to 6 months to 1 in 56 months, improvement in outcome, and more acceptance and survival. Next slide, please. Now, peritoneum, it's a bilayer membrane covering the abdominal organs. It's got 2 layers, parietal and the visceral, and in between is the peritoneal cavity. This peritoneal membrane is not designed for peritoneal dialysis. It has got various physiological functions, and the total surface area of peritoneal membrane is 1 to 2 meters square. The peritoneal space in normal persons contain about 100 to 200 ml of fluid. Next slide. This is just to show you that this is the peritoneal catheter in the peritoneal cavity, not in the intestine. And this is connected to a twin bag. That is, this is attached to the bag filled and this goes to the drain line. Next slide, please. So what is the procedure of peritoneal dialysis? During PD, the dialysate is instilled through the tube, which is called peritoneal catheter, into the peritoneal cavity. After prescribed time, the fluid is drained out. this whole procedure, the whole process of installation, dwell time, and draining out is called exchange. Such type of exchanges, 3 to 4, are carried out per day. The time the fluid is kept in the peritoneal cavity is called dwell time. Dwell time and number of exchanges are based on certain calculations, that is creatinine clearance, both peritoneal and urinary creatinine clearance, and peritoneal equilibration test. Next slide. Now, this is another diagram to show what happens. This is full bag, and this is the drain bag. The patient is draining out fluid first. Then after full drainage, this bag is let into the peritoneal cavity. Then he takes his dog or probably wife for a walk. That's what is the full exchange. Next slide. Now, PD is actually, this is not a correct slide. PD should be offered to any patient. It's not that only older patients, diabetics, cardiac patients, or those with heparin contraindications. Patients, this should be offered to all patients who prefer PD. And also PD is offered to patients where no HD facility is available. This is reasonably uncommon nowadays in India, because all over you have hemodialysis facility. But in 1980s, there are many places where there was no hemodialysis facility, where we used to offer somewhere 1990s, not 80s, we used to offer PD for these patients. Next slide. There are certain contraindications for PD. Patients with peritoneal fibrosis, adhesions, or gut disease or malignancy, intra-abdominal. Relative is a huge hernia, having diverticulosis, severe lung disease can cause aggravation of dyspnea in these patients. Obesity causes reduced clearance, psychosis, or patients having colostrum makes it a little difficult to perform peritoneal dialysis. Next slide. Now, coming to these catheters, this is what is the Tenkov catheter. They are reasonably same. All are equally good. Not that one is superior to other, but different designs. This one is having only one cuff. This is having two cuffs. That is inside over the peritoneal membrane, then down in the subcutaneous tissue. This is the intraperitoneal part. This is over the peritoneal membrane and the subcutaneous tissue. This is the coiled catheter. This coil is to prevent omental adhesions. You know, when the catheter goes in, being a foreign body, the omentum comes and wraps it, and then it causes difficulty in performing the exchanges. Swan neck, again, to prevent the catheter migration. Sometimes you put in the catheter in the peritoneal cavity, and the whole omentum wraps it and takes it to the hypochondrium and prevents drainage. So this is for preventing the drainage problems. But however, even if a good catheter implantation, these catheters also gives good results. Then we have the Toronto Western catheter, which has got a hat-like thing again here to prevent migration and omental adhesions. Next slide. Now, how do we insert this catheter? Nowadays, mostly laparoscopic assisted insertion so that the patient can go back in the evening itself, morning come and get inserted, and by evening out. Then there is open surgical method, where few places still practice. And of course, as an outpatient or in emergency, trocar and cannula is still done in few cases. Next slide. Now, how do we start this PD? PD usually we should wait for about 10 to 14 days for the wound to heal and peritoneum to heal, so that we can start with reasonable exchanges. That's called a regular start. Sometimes a patient comes in an emergency state with high urea creatinine, acidotic, then there is no dialysis facility, or the patient has got a bad vascular access where the veins are thrombosed and there is no way to perform hemodialysis. There, in these patients, you have the catheter implanted and you can start immediately by giving small exchanges. That's called break-in exchanges. The problem with break-in exchanges, if you try to infuse more fluid, then you have peritoneal leak And that's a miserable state for the patient and the doctor. Now, after 4 to 6 weeks, it's worthwhile performing peritoneal equilibrium test to decide membrane permeability. Now, each person in this life, everyone in this world also behave differently. So does the peritoneal membrane. Some membranes are very leaky, they equilibrate very fast. So you keeping the dialysis solution longer time will lead to absorption back of urea and creatinine, absorption back of fluid, and you have an unsuccessful dialysis. Some membranes are very slow in leaking out toxins. In these patients, you have to keep longer time. Beyond a certain amount of time, beyond a certain period of time, keeping this fluid can lead to underdialysis. Now, after performing the peritoneal equilibration test, deciding the duration of dialysis to be carried out per day each cycle, we perform weekly creatinine clearance to decide about the adequacy. Please note, the PET is different from weekly creatinine clearance. You have to have the PET characteristic to decide the type, the duration, the number of cycles to be given. And then you do the weekly clearance to decide whether the patient is receiving adequate dialysis or not. Next slide. Now, we have intermittent peritoneal dialysis. That is the usual one which we were practicing before. Even now in many places, small towns, it's practiced, wherein the patient comes with severe renal failure. We insert a stiff catheter. Nowadays, even Tenkoff catheter can be inserted. And they undergo about 24 cycles or 36 cycles of 1 hour each, and then go back home. But the one which we are talking is CAPD, which is done manually, that is 24 hours, 3 to 4 exchanges, usually 4 exchanges are carried out, or DAPD, daytime ambulatory peritoneal dialysis with night dry. This is also carried out manually. Daytime you can have 3 to 4 from morning till night, and night you can keep the abdominal cavity, peritoneal cavity dry. Then you have automated peritoneal dialysis using cycler. Next slide. Now, CAPD is carried out by patient during the daytime manually. Dialysis fluid is infused into the peritoneal cavity. Dwell time ranges between 4 to 8 hours, suitable for patients, as I told you, for high average or low average. In high patients, of course, let me tell you, peritoneal equilibration test is, the patients are characterized into 4 types: high, high average, low average, and low. High means very highly permeable peritoneal membrane. In these patients, more than 2 hours, if you keep the fluid gets reabsorbed into the blood. The urea creatinine goes back into the blood. In low, you have to keep 8 to 10 hours for the urea creatinine to creep out, or even some amount of fluid to come out. So obviously you can't give more than 2 exchanges or 3 exchanges, so you have inadequate dialysis. So best is to have a high average or low average patient to perform adequate peritoneal dialysis. Next slide. APD uses cycler to perform exchanges. APD in CKD can be used as continuous cycling peritoneal dialysis. That is, continuous means actually daytime also you do manual exchange, and nighttime also you have the cycler doing the exchange. On nocturnal intermittent peritoneal dialysis, where you connect the patient nighttime and perform 4 to 5 exchange from night, maybe around 8 or 9 p.m. to morning 6 or 7 p.m. Tidal is what very rarely practiced. I'm not sure how many centers practice, wherein we infuse about 2 to 3 liters of peritoneal fluid. We drain out about 1.5 liters, keep 1.5 liters in, and then you go on doing exchange with remaining 1.5 liters. That's tidal. Hybrid systems are nothing but you have both cycler and manual. You can go on doing it, interchanging it. That's called hybrid. Next slide. This is the first cycler which was designed by Buxbaum. You can see the glass bottles and you can see the drainage bottle here. Now, this was always practiced in hospitals. The patient had to come to the hospital, and here is the pump. You can see the size of this machine. Next slide. Next slide, please. And these are the new cyclers, compact, where the patient can carry anywhere. Even if he is traveling, it can be carried. Next slide. And this is the same new cycler with the collapsible bag attached to it. This is not a 2-liter bag. This is 5-liter bags. So you can have 5-liter, means you can do 2.5 liters, 2 exchanges. You have 2 attached 5-liter bag. That means 4 exchanges of 2.5 liters you can perform at night time. Next slide. There is increase in use of APD, and this initially was preferred by patients who were very high transporters, but now the patients have started deciding for themselves, and any type of patient can go on automated peritoneal dialysis. Next slide. This is just to show you what is CAPD. Here, this is the night time. You have a long cycle, long dwell time, and during daytime, you can have 4 hours each dwell time. So 12 hours or 13 hours here and remaining night. In APD, you can have 4 cycles per day. In daytime, you can have either a dry period or you can have a long cycle with icodextrin. Next slide, please. These are different other types of dialysis. This is the other types of exchanges. This is the CAPD which I showed you. This CAPD with night exchange also. This is night exchange where you have little longer exchanges and daytime smaller exchanges, short period exchanges. This is NIPD where you have cycler doing shorter exchanges, maybe 5 to 6. Again, daytime it is dry. Again, night you connect it to cycler. This is CCPD, continuous. Here, nighttime you have the shorter exchanges and daytime you have a long exchange done. Again, night you connect it. You have APD with 2 daytime exchanges. If the patient requires more dialysis, you have to do 2 times, and daytime and night you can have. These are usually preferred in obese patients, very heavy patients who are more than 100 kilos weight, and anephric patients also. And this is small nighttime, this thing with short evening exchanges. This has to be modified according to the requirement, depending on the creatinine clearance. And tidal PD is nothing but you don't drain out fully, drain only half of it and infuse half each time to increase the clearance. Next slide. So, peritoneal dialysis works. It's a semi-permeable membrane, allows solutes and water to be transported from vascular system to peritoneal cavity and vice versa also. Next slide. Let us come to principles in PD. There are 3 main principles. First one is diffusion. This is the main thing. What is diffusion? Diffusion is movement of solutes from high to low concentration, such as urea and creatinine. I'll be discussing it later. Osmosis is movement of water from low osmolality to high osmolality. And convection is during the osmotic movement of water, solutes are being dragged with this water. That's called convection. Next slide. So diffusion is movement of solutes across the peritoneal membrane from higher concentration to lower concentration. The examples are high urea and creatinine moving out from the blood in capillaries into the pleedy fluid. Next slide. This is what happens. This is the dialysis fluid. This is blood with high urea and creatinine. As time goes, it equilibrates. And once it equilibrates, you have to drain it down. What happens is, if you keep continuously, as the concentration of urea and creatinine increases here, and as the body starts producing more urea and creatinine, beyond a certain time, this will start moving after equilibration back. There can be a back leak. So beyond the optimum time, you should not keep the peritoneal fluid in the cavity. Next slide. So there are certain factors influencing diffusion. One is concentration gradient. peritoneal surface area. That means higher the concentration gradient, movement is faster. Peritoneal surface area, larger the surface area, better clearance, better diffusion. Membrane permeability, as I mentioned earlier, higher the membrane permeability, faster the diffusion, lower, slower the diffusion. Solute characteristics, smaller solutes move fast, larger solutes move a little slowly. Dwell time. Dwell time to certain level helps in diffusion. Beyond a certain time, it may reverse the whole thing. Dialysate volume, to certain extent, can help in diffusion. More dialysate volume in the peritoneal cavity causing increased hydrostatic pressure will prevent diffusion. Next slide. So convection. Convection means the solutes move across the peritoneal membrane in an orderly flow from where the osmosis force is going through. Through that, the solutes like urea and creatinine starts coming out with the flow of the fluid. Next slide. Osmosis is movement of water across the peritoneal membrane from an area of low concentration to a higher area of high concentration. Here in PD fluid, we have got high concentration of PD fluid due to presence of, we'll come to it then, and presence of glucose. And nowadays we are using icodextrin also. Next slide. So factors affecting osmosis, PD fluid dextrose concentration, we have 1.5%, 2.5, 4.25. And new solution, not reasonably late. It's already there for a decade or more, icodextrin. The advantage of icodextrin is it doesn't get absorbed into the blood. Here, glucose gets absorbed into the blood. So the osmotic drive comes down. Longer you keep, more glucose gets absorbed into the blood and there is less osmotic drive. Icodextrin persists in the peritoneal cavity, so you can keep the peritoneal fluid for 8 hours, 10 hours, still you can get reasonable ultrafiltration. Dwell time, depending upon the permeability of the membrane. Peritoneal surface area, again, larger peritoneal surface area, better osmosis. Hydrostatic pressure, inversely, if the hydrostatic pressure increases in the peritoneal cavity, it will reverse the water flow. Oncotic pressure gradient helps in osmosis, but as the peritoneal fluid gets diluted, the oncotic pressure changes and it can reverse the flow. Next slide. So the function of dialysis is it removes toxic substances and metabolic waste, reverses the symptoms of uremia, re-establishes normal fluid and electrolyte balance, maintain positive nitrogen balance, it prolongs life, have the maximum level of quality of life. Next slide. So I would like to conclude that peritoneal cavity is used as a dialysis system. In peritoneal dialysis, it can be carried out manually or with cycler. Peritoneum is a fantastic semi-permeable membrane and it applies a principle of diffusion, convection, and osmosis. It gives freedom of movement and reasonable relaxation in diet. Next slide. Thank you very much.
Thank you, Prakash, for this wonderful and exhaustive lecture on the basics of peritoneal dialysis, and you have dwelt in great length about how this is done and the importance of PD as such. Only a word of caution to you is that you mentioned at the end of PD exchange, you take the dog or your wife for a walk. If you now equate the dog and your wife, you may not be allowed entry back into your house after the walk. So that's the that's only taking in a lighter moment. So we come back to the questions at the end of the session, and I would now like to invite Dr. Umesh Khanna, who's one of our senior nephrologists from Mumbai, the excellent nephrologist, a great speaker, great orator, and who will be speaking on a very important topic about oral nutritional supplements as well as an intradialytic parenteral nutrition for the prevention of protein energy wasting. Now, this is something which requires a lot of attention, because how do we prescribe, what to be prescribed, whether oral should be allowed, or should we combine this with IDP, and particularly in our critical care, critically sick patients? So Dr. Khanna is presently the director of the Kidney Associates at Mumbai. And over to you, Dr. Khanna, please. Umesh, you have to unmute yourself.
Good morning, friends. The advantage of talking after Dr. Kriplani and Dr. K.C. Prakash is that you are not the first one who has difficulty in connecting with the computer, connecting with Wi-Fi, connecting with Zoom, and of course, connecting with the audience, which all of us are facing difficulty during the online. Yes, I'm trying to share my screen. Yes.
To open your presentation.
Yes, I'm doing that. Yeah. Maybe I should have opened. Yes, it's open. And can you see my presentation?
We can see your slides. You can just put it on full screen.
Yes, I'm trying to do that. So connecting to the computer and the Wi-Fi is achieved successfully. Connecting to the audience is really difficult because although there are a few participants, how many are actually connected with their earphones and how many are in the kitchen, toilet, bedroom, or playing with their kids is difficult to decide. I have put Dr. Arun Shah's name also in the presentation because some of the slides are borrowed. My topic for today is ONS IDPEN in Pew. And of course, from Lucknow, Dr. Anita Saxena and my friend Dr. Bhalla from Gangaram. I should not forget another short form, and that is Mia, whether it is Bade Mia or Chote Mia. So we need to cover up various topics: Pew, ONS, IDPEN, and Mia. But then the best part of SRNM is the bhaichara, the brotherhood, which we see in our seminars, that a lot of your topic is covered by your brothers earlier on, and therefore you can quickly finish it in 20 minutes because some of the part of the agenda is already covered. So that's the best part of it. Now, what is protein energy wasting has already been done, but just in a nutshell, it's almost similar to a bad uremic malnutrition. And it's already spoken of that it is the strongest risk factor for morbidity, mortality, and impaired quality of life in dialysis patients. And there are various reasons for malnutrition in CKD, and the rates, as mentioned by Dr. Bhalla, were varying from 40 to 75%. And there are different methods of evaluating protein energy wasting, which has been dealt with in the previous prescription. And somehow subjective global assessment, or HGA, is widely used by qualified dialysis technicians because it's robust and quick to administer, has its own limitations that it requires training and is based on clinical judgment. Now, when you devise nutrition therapy in a CKD, you should consider all the nutrients while planning the treatment. And we know that we consider the calories, the fluids, the proteins, the carbohydrates, the lipids, and of course the electrolytes, the phosphorus, and the macro and micro nutrients. So all that is important, and hence the role of ONS also. And that's why I'm just building up a prologue to the discussion. We also had some discussion on the protein recommendations, and very eloquently Dr. Kriplani talked about the role of proteins, and therefore I'm just trying to bring out the various guidelines of professional bodies, the KDOKI, the British Dietetic Association, the SPEN, and the ERA EDTA as to the amount of protein required for non-dialysis patient, the hemodialysis patient, and the peritoneal dialysis patient. On an average, non-dialysis less than 0.8, hemodialysis and peritoneal anywhere between 1.2 to 1.3 grams, and at least 50% of them should be high biological value. Also, the importance of adequate calories was brought out by Dr. Kriplani. Reducing salt intake has been one of the favorite talks which I have taken at multiple fora, and that also should be kept in mind. And as the amount of, as the GFR drops further and further, potassium intake should be restricted as the kidney function worsens, especially because our patients are on AS, ARB, certain drugs, medications. Many of them are on inadequate dialysis, and somebody talked of the Monday or Tuesday morning syndrome of the sudden deaths which occur because of hyperkalemia. The importance of acidosis has been touched upon, and by no less an authority than Dr. Sundar, the topic of constipation and its importance has also been covered. So phosphorus, I think, is going to be a topic by itself, wherein my friend Dr. P.P. Verma is going to talk about how plant-based foods are better than animal-based foods, which are better than processed or enhanced foods. So the other aspect which is important is the nutritional requirements in AKI, where the protein requirement is much more, almost 1.5 grams per kg per day, with some extra for the infused amino acids to be infused based on the losses in the renal replacement therapy. And a lot of our speakers spoke on the importance of energy or calories intake. Similarly, the summary of requirements for CKD management, as I dealt with earlier also, in the non-dialysis CKD, how much should be the energy, how much proteins, how much salt, much potassium and phosphorus, all that is either covered or will be covered by the other speakers. So coming back to my presentation of ONS, PNS, and its role, I thought I will take a clinical case and run you through that. So here's a 63-year-old male, CKD5 on hemodialysis through a right internal jugular permacath. He's diabetic, hypertensive, ischemic heart disease, hypothyroid. He came to us with altered sensorium and hypoglycemia. His other relevant histories doesn't have a caretaker, is living alone, is a smoker, has had recurrent hospitalizations for infections, some of which were due to perm cath infections. Repeated changes in dry weight, in the sense that his dry weight kept on going down over the last 6 months. Is clinically dry, cachectic, scratch marks over trunk and legs for itching. And his lab parameters are not good, obviously. His hemoglobin is 7, his BUN or BUN is 124, which would mean almost a urea of 250. Creatinine is 12. His potassium has gone up to 6, and his acidosis is bicarb of 18, with a phosphorus of 9, a uric acid of 8. And as was expected, his total proteins are 5 with an albumin of 2.2. So obviously, no marks for guessing that he is a case of malnourishment. And what is the cause of his protein energy wasting? And there are many such factors in this specific case, and we see many of them in our private practice fitting into this criteria, especially if we are not dealing with the rich and affording class or those who are already having insurance and so on. One, of course, is inadequately dialyzed twice a week, and we did hear a couple of lectures talking about the importance of adequate dialysis. Underlying inflammation because of the presence of the perm cath and recurrent infections. He has acidosis, he has anemia, he has hyperphosphatemia, he's a smoker, and is depressed as he's staying alone. So what next if the patient has protein energy wasting? We can't straight jump to ONS or IDPN, but there are all other things which need to be carried out. So obviously you'll correct for the cause of fever, and we heard very eloquently the importance of water treatment plant and how you must invest in good pure water or ultra pure water. So correct the cause of fever, whether it's due to the RO, whether it is due to the perm cath, or he is harboring any pneumonia or infection because he is malnourished. try and correct his nausea and vomiting with whatever means possible, prokinetics, etc. Treat his GI symptoms, encourage him to patient to eat well, which can only come with the help of an empathetic dietitian who knows a subject well. Dialyze the patient well, as was pointed out earlier also, more frequently, good quality, look into your RO plant and try and improve whatever nutritional status. So what's the strategy of treating a protein energy wasting? So there are different feeding strategies stepwise as we take this patient through. The most important is the dietary advice with a nutritionist or a nutrition counseling. And obviously home food is encouraged, and the patient has to be given what is good for him. But here, as in many other cases, there aren't any caregivers or somebody who can look into it, which is more common abroad, less often here, but slowly nuclear families, that also could be a problem. So good nutrition counseling, which has been already highlighted by the previous speakers. The next part is, after a good home or hospital meal comes the importance of counseling plus oral nutrition supplement or ONS. If for some reason the home food is insufficient or is unable to fulfill the requirements, then enteral or ONS could be added. Enteral nutrition or tube feeding would be the next step if we are unable to achieve the targets. And only lastly, finally, one can consider parenteral nutrition. But as is often the case, you will have to sometimes combine stepwise many of these factors: home food, hospital food, ONS, and then sometimes additional, if not complete parenteral nutrition, but some aspects of it like amino acids, etc., or glucose during dialysis has been used in practice. So anyway, to summarize, the nutritional therapy in a dialysis malnourished patient is orally most important meals during dialysis. Now we are in the COVID time or COVID period, and this is one of the major challenges that I face in units, because we've now formed a policy because of the rampant COVID in dialysis units of no meals during dialysis, because the mask is down, and with vomit or sneezing or coughing, we all are aware how COVID can spread in the dialysis unit. So if you talk of non-COVID times, then meals during dialysis is one of the excellent method of nutrition, and some hospitals do practice it. Some peripheral units do allow meals to be brought and fed to the patient during dialysis. One of the simplest, easiest, and more nutritious way of handling dialysis patients. And then, of course, renal specific oral nutrition supplementation has been in practice for some time, whether we're talking of CKD 1 to 4 or the dialysis patient. In both these groups, renal specific ONS is an important thing. Those who are critically ill or more malnourished or hospitalized, they could be in addition on tube feeding, and at times even from home, a patient has the combination of ONS through the tube feeding or of course in addition to oral feeds. And lastly, a few cases you may have to start IDPN. Never to forget the whatever small role of pharmacological intervention in the form of prokinetics. Some people who are depressed, maybe a small dose of antidepressants. Easier said than done, because many of them cause a lot of drowsiness and constipation, etc. There is always a questionable role of anabolic steroids, which find favor with a few people, and some people do use it. The International Society of, or the ISRNM guidelines for management of protein energy wasting in CKD basically does talk of indications for nutrition intervention, especially if patient has poor appetite and poor oral intake. And Dr. Kriplani did dwell on the reasons for poor appetite very eloquently, and there's no point in repeating it. Inadequate dietary protein intake, which starts from CKD 1 to 4. And again, a lot of speakers did speak to us about how the whole country is already on a CKD diet, inadvertently taking a low protein diet without even being asked to take so. The role of albumin, pre-albumin was also discussed. Again, a small rider here that albumin could be low even in some cases due to inflammation or volume overload can give you a falsely low albumin. But more often, of course, you have to keep in mind low albumin as a nutritional marker. An unintentional weight loss or a reduction in the dry weight more frequently, which you need to reassess. Worsening nutritional markers and so the moment you have any of these parameters, you have to start apart from the oral home food, additional specific oral nutrition supplement may be given. Then look at those parameters. If there is improvement, continue to maintain this nutrition. And this algorithm probably explains some of the ways in which we can manage. So oral nutrition supplementation provides benefits for managing PEW. Yes, over the past 2 decades, there are 11 studies which have shown outcome benefits of ONS therapy for managing protein energy wasting in CKD patients on dialysis in different ways. Lowers mortality, improvement quality of life scores, increase in body weight, maintenance of lean body mass, hemoglobin, and of course, many of them with lower fluid need, you could manage it if you have renal specific ONS, improvement in serum albumin, calories and protein intake can be improved and well tolerated. And some of them cause constipation and many of them cause, in fact, they look after constipation and a patient has good bowel movements, which in itself is an added advantage because constipation is an area which is so vital for a patient's well-being in our country. Again, the meta-analysis does indicate that ONS improves albumin and energy and protein intake. What about blenderized foods, which is there in many of the corporate hospitals, and a commercial enteral formula versus blenderized food or liquidized formulas? Are commercial enteral formulas better or preferred over blenderized foods? So some of the advantages of commercial formulas are complete or balanced nutrition, osmolality is known, lactose and gluten-free, of course, not so big an issue in many of patients, supposedly more sterile compared to the blenderized meals. Easy to let it go through the Ryle's tube and culturally sensitive. So the other features of renal specific ONS is it's a complete formula, has macronutrients, micronutrients, it meets physiological needs based on the stage of CKD, not in our country, but in, of course, even we have introduced one liquid ONS, which hasn't yet been very popular, but abroad we have different other forms, bars, puddings, etc. Adaptability to improve compliance and tolerability as a milk replacement, because some people don't like milk and so maybe in water you can use it. It could be a recipe during meal times. Now, what if the patient does not take orally? Now, always use the gut, and therefore at times if he cannot take oral feeds, then you're forced to put Ryle's tube, or in patients who have difficulty or prolonged Ryle's fooding, then those patients where there's a fear of aspiration, etc., peg feeding may have to be done. So if GI tract is a problem, only then one has to resort to intradialytic parenteral nutrition. Of course, as we discussed earlier, you would try various other pharmacological means also. So we come back to the same thing, that if oral intake remains insufficient, one can use enteral tube feeding, which is the next step for those patients who have a functional intestinal tract but are unable to meet nutrition needs with mere home food plus ONS. Then you can resort to enteral tube feeding. And this proposed algorithm, although it's a very crowded slide, but if Dr. Anita Saxena is going to share some of the slides with the participants, then maybe one can go into the details. But basically it tells you that every CKD patient, one has to do periodic nutritional assessment, dietary counseling of a trained dietitian, various methods of assessment, which we have gone through it, check whether he is on appropriate diet in terms of proteins, energy, phosphorus, salt, vitamins, etc. And then if there are indications for nutritional interventions, then in the form of poor appetite, poor oral intake, or unintentional loss of dry weight, or sarcopenia, or biochemical factors like albumin, cholesterol, etc., or you have calculated SGA or MIS score, and then all that, you start using CKD specific oral supplement depending on the stage of CKD. 1 to 4, the supplement is different, and stage 5D is different. So last 3 to 4 minutes of my 20 minutes which are left, and therefore my friend, or who's loaned some of his slides, Dr. Arun Shah had done a study which is published in JAPI on the role of ONS supplementation in hemodialysis patient, the Indian experience. And he used NEPRO-HP, which was provided to 77 CKD patients on maintenance hemodialysis over 3 months, and did show efficacy parameters which were improved in albumin levels, weight, hemoglobin, the safety factors of potassium, phosphorus was also looked into, and other parameters like SG and MIS scores, and did show improvement. What about IDPN? Yes, it's a nutritional support which is designed for dialysis. Infusion of amino acids, dextrose, and lipids during dialysis, given 2 to 3 times a week, depending on what the patient's schedule is. More often, it's the amino acids and glucose, and in some cases, lipids, and therefore the providing of calories and proteins will differ into what solution you use. It may improve appetite, strength, overall well-being. It may improve the dry weight through increase in the muscle mass and improvement in albumin level. How do you administer IDPN? It's infused over the entire dialysis treatment. When you calculate the fluid removal, you calculate the volume, take into account the volume which is infused. It should not be given simultaneously with a blood transfusion of the same line as IV iron. Plasma amino acids are replenished during IDPN, and you can monitor like you monitor other nutritional parameters. Is it really helpful, and how much? Again, I put too many question marks in this, the most important line. And there are surrogate markers which show improvement, but the real improvement in mortality studies are yet not available. The jury is still out. So the last 2-3 slides. So my observation of the Indian CKD patients in general, as far as diet is concerned in the last 30 years, is that they are poorly informed about nutrition in all stages of CKD. They do not want to pay for dietary advice. They listen to doctors, but do what their relatives, friends, neighbors, their dhobi, their panwala, whatever they advise. And of course, we now have the University of WhatsApp, or Dr. Google and his friend, the YouTube. They all add to the confusion in diet, which is already prevailing in the minds of the patients. Most patients, as was mentioned by almost all the speakers, they continue the pre-dialysis low protein diet. And they believe, as Dr. Kriplani pointed out, higher the creatinine on dialysis, poorer the health, and are very happy to see a low urea or a low creatinine or a low cholesterol report. They are ill-informed about the value of serum albumin. In fact, many of the blood tests which they do not even include the albumin levels. So to conclude, protein energy wasting is common in patients CKD at various stages and is associated with poor clinical outcomes. Nutrition screening and assessment are necessary before recommending nutrition therapy to determine a diagnosis, which will be basically the basis of what nutrition therapy will be given. It requires an individual and systematic approach and not one size fits all. Clinical evidence supports supplementation of renal specific ONS to improve multiple clinical outcomes, not very clear about IDPN. Nutrition therapy should be given a pride of place in CKD management. And here I must take a pause and congratulate Dr. Anita Saxena, the SRNM as a body, Dr. Balla, and all the people who manage SRNM, that that this is extremely important to be a part of the treatment protocol of CKD, and should be spread to all corners of the world and all corners of the country, and which is what I feel we are doing a very great job of holding these conferences, including the advanced stage. CKD diet would change different stages. Meals on dialysis safe and efficacious and should be encouraged. Renal specific ONS is helpful in many patients. IDPN is safe because there were concerns about its side effects, etc. They are not as much as one is scared of. And again, I'm repeating, is doing a great job in imparting knowledge in renal nutrition. So Mumbai Kidney Foundation and Kidney Associates extend a very warm invitation to all of you to attend the next SRNM Con, which will be hosted by Mumbai in September 2021. The dates would be announced based on the Ganesh Chaturthi festival and things like that. We thank the office bearers of SRNM for reposing faith in us and allowing us to host this prestigious meet, and we all seek your blessings for it. Thank you.
Thank you, Umesh, for this wonderful and talk, and which you sort of delivered in an extremely simple and a lucid manner. And
I was told that learning would be done in the first 4 chapters, in the first 4 lectures, and you have to just keep the audience from going away or sleeping. That was the mandate that was given to me. So
you kept the chairperson also away.
Yeah.
So not only the audience. So I think that's a great achievement. Nevertheless, we move on to the next talk, and that would be the last talk of this particular session. And this is based on this is on management of hyperphosphatemia, and this will be delivered by Lieutenant General Prem Prakash Verma, who's the director and head of nephrology at the Venkateshwar Hospital, New Delhi. General Verma had been the past president of the Indian Society of Nephrology. Again, has an extensive experience and knowledge of the subject, and he would be talking on this very important talking about hyperphosphatemia and how do we manage this in our dialysis patients. Over to you, Professor General Verma.
Thank you very much, Professor Amit Gupta. Are the slides visible?
No, sir, your slide is not visible. Sir, kindly share your slide.
Is it all right now?
No.
No, sir, please stop sharing and open your PowerPoint. Then there is a green button called share screen, and click on that. Select the PowerPoint and share again.
Sharing.
Share screen.
Yes, sir. Now it's visible. Please open your PowerPoint, sir. Yes, sir. Your PowerPoint is also visible. Please
now make it slideshow.
Full screen mode. Yes.
Go to slideshow.
There's something.
Oh, Jesus.
Is it all right?
Yeah, it's perfect. Please go ahead.
Thank you very much, Professor Gupta. And I must, before starting, compliment Dr. Anita, Dr. Bhalla, and team. And I have been participating in all the 7th advanced courses or annual conferences. And I must admit, every year, the scientific content is gradually going up. And this has become one of the looked after and sought after conference. Thank you very much.
Sir, may I say that you are appearing there as the torchbearer of SRNM? Could you spot yourself in that?
Yeah. Well, the topic given to me today is the management of hyperphosphatemia. I heard Dr. Anita herself yesterday and other speaker Bharat Shah also talking about this topic. I'll cover whatever has not been covered by them. We all know that gradually, as the CKD progresses, the incidence of hyperphosphatemia goes up. Despite the poor nutrition in our country, 70 to 100% of patients, by the time they are dialysis dependent, have hyperphosphatemia. We know, the slide is not moving. Yeah. As the CKD progresses and the GFR decreases, we know that initially it is the fibroblast growth factor 23, which starts rising, and then parathyroid hormone, and lastly, it is a phosphate which keeps rising. So it is initially the FGF23 and parathyroid hormone. They cause the phosphaturic action and do not allow the phosphate to go up. Is phosphate really bad? That is a question. Now, this is a study of healthy population, mind you. GFR over 60, no proteinuria, almost a 1 lakh of by patient, not patients, healthy population, and followed up for almost 6 years. And what you find that as the phosphate level is higher, the mortality keeps increasing. This is in healthy population. Now come to CKD population. Again, we know that with every milligram rise of phosphorus, the risk of death increases by 18%. And this is again a similar data which is showing that as the phosphorus level keeps increasing, the risk of death keeps increasing by 18% for each milligram of phosphorus. As a matter of fact, if you really ask me, the CKD means 3 P's. That is blood pressure, the checking of proteinuria, and third is checking of hyperphosphatemia. Now, this is a recent study which came last month only. This is in atherosclerosis, which is again showing that hyperphosphatemia causes an increased risk of sudden death in patients on hemodialysis. How does hyperphosphatemia harm us? We all know that it is a soft tissue calcification in cardiac valve, in solid organs, and it is a cellular phosphate which activates the gene which triggers the transformation of vascular cell into osteogenesis, and the vessel wall becomes thick and calcified. Besides that, high phosphate also inhibits 1-alpha hydroxylase, low vitamin D formation. So over months to year, bone density decreases. Additionally, the PTH and vitamin D derangements result in abnormal bone architecture. Now, how to manage hyperphosphatemia, the topic. We have got only 3 options: the phosphate binders, removal by dialysis, and the dietary manipulation. I'll come to dietary manipulation in the end. First, the phosphate binders. We know that if we take calcium-based phosphate binder as number 1 salt, you look at how much is the binding of phosphate per gram of calcium carbonate or calcium acetate. The best binding is by lanthanum or sucroferric oxyhydroxide. If you look at the Lancet famous study published in 2013, which clearly showed that the all-cause mortality is 22% higher in calcium-based phosphate binder vis-a-vis non-calcium-based phosphate binders, whether this is pre-dialysis population or dialysis population. Well, if you look at the equivalent amount we take as standard calcium carbonate, you find that if you have to take calcium carbonate 8 tablets to balance the phosphorus level, this may be 10 tablets with sivalimer, and with sucroferric oxide, it may be 3 to 4 tablets. Now, how much phosphate binding we can have with these tablets? Let's say daily consumption of protein in a 60 kg dialysis man is recommended to be 72 grams or 70 grams. We know that each gram of protein roughly has got 14 to 15 milligram of phosphorus. So you are taking 1000 milligram of phosphorus a day. If we take absorption as 60%, we have taken 4200 milligram per week. Phosphate binders, if you are taking regularly, you can bind up to 2100 milligram of phosphorus. But mind you, compliance with phosphate binder is only 25%. Even in the Western world, compliance is less than 50%. Let's come to dialysis. How much dialysis will help? This is the famous study by Dogri Das and all, which said that we require almost 18 to 30 hours of dialysis per week. That means daily dialysis. What Dr. Bhalla was trying to talk some time back, that if a person is on daily dialysis, possibly the phosphate binders and other things are not a problem. But in India, the commonest is twice a week dialysis. How much it gets removed? Now, this is a study which again telling you that there was initially some doubt that people felt that in the first 1 hour there is more removal, in the next 3 hours there is a less removal of phosphorus. Well, this is a myth. If you look at this, the phosphate removal in the first hour and the subsequent hour is almost equal. Therefore, if you want to remove more phosphorus, you will have to prolong dialysis. In each dialysis, you are able to remove 700 to 800 milligram of phosphorus. That means if a person is on thrice a week dialysis, he gets 2100 milligram gets removed with this, and 2100 milligrams get removed with phosphate binder, he can be a happy man. But unfortunately, this is not the story in most of the patients. Now let's come to the dietary manipulation. How to manage. Now, I'll talk on 5 aspects: the bioavailability, protein phosphorus ratio, hidden phosphorus, effect of boiling, non-veg versus vegetarian food. If we are talking about sources of phosphorus, we talk of common cereals, pulses, dairy products, etc. Let's come one by one. We will not go into the formulas by which we can calculate, as I said, roughly 15 milligram per gram of protein. Now, if you look at the cereals, what we take, whether it is wheat, jowar, bajra, whatever, every 100 milligram is having approximately 300 milligram of phosphorus. An average Indian labor class is taking much more, but average person is taking 200 gram of carbohydrate, cereals per day, which makes 600 milligram. Come to pulses, all pulses, whether rajma, lentils, peas, they have got approximately 300 to 400 milligram per 100 gram. So even if you are taking 40 to 50 gram, 150 milligram phosphorus is coming from here. Come to dairy products. Milk, approximately 100 ml has got 100 milligram of phosphorus. Leave aside cheese and all. So average dialysis person, if he is taking 300 ml, he is taking 300 milligram of phosphorus. Let's not talk of fruits and vegetables because they are not the bigger sources. Let's come to non-veg food. Approximately, whether it is a fish, beef, whatever it is, approximately 100 gram will have 200 milligram of phosphorus. And if a person is taking average 200 gram, he is taking 400 milligram of phosphorus. Let's combine all. So by cereals, pulses, dairy products, nuts, dry fruits, non-veg, or cheese or non-veg, whatever, we are taking approximately 1200 to 1500 milligram. And as I said, we're taking absorption of 40 to 60%, 600 to 800 milligram phosphorus we are taking every day. A question of bioavailability, as I mentioned, as has been discussed yesterday also, the plant-based food, the absorption of phosphate, because our body doesn't have phytates, is less than 50%. Anything 30 to 40% of plant-based food phosphorus is absorbed. Whereas animal food, it is 60 to 70%. And if we are talking of additives or processed food, they have got the highest bioavailability with 80 to 100% absorption. Let's come to third important point, phosphorus protein ratio. As I mentioned, milk, suppose it has got 100 milligram phosphorus per 100 ml. Protein is 3.5. So 100 divided by 3.5, it is 28:1 ratio. Let's take chicken. 100 gram has 200 milligram phosphorus, 25 gram protein. So ratio becomes 8:1. The best form of protein is the egg white. You will find there is 5 milligram phosphorus in each egg, whereas there is 3.5 gram of protein, ratio is just around 1.2, 1.3. So we have to take phosphorus, take foods with a phosphorus protein ratio of preferably less than 12. Lesser the better. So you can pick up what food you want to take. If you look at this, again, I'm highlighting because this is an important aspect and must be known. If you look at milk, yogurt, cheese, the phosphorus protein ratio is pretty high. Absorption is 40 to 60%. And if we come to that non-veg, the protein ratio is low, but absorption is 40 to 60%. If we come to plant proteins, the absorption is less. I'll skip this. Now let's come to hidden phosphorus. If you look at the American diet, almost 40% of the hidden phosphorus is there. Now this phosphorus is in additives. Just a minute about even the drugs. Lisinopril, if you take 10 milligram tablet, it has got 32.6 milligram phosphorus. Commonest tablet being used, amlodipine, 10 milligram tablet has 40 milligram of phosphorus. That means if a person is taking 2 tablets of amlodipine, he is already taking additional 80 or 100 milligram of phosphorus. So we must know which are because all the processed foods, what we pick up from chicken, fried chicken, or whatever, or fresh chicken, they add monodisodium phosphate or potassium triphosphate to preserve color and shelf life. And the absorption of this phosphorus is 70 to 100%. Now, this is a US data which only showing that American diet can have approximately 40% of total phosphate intakes only from additives. And if these people are apprised and taught that you have to look whenever you are buying a foodstuff, they find that possibly educating end-stage kidney disease patient to avoid phosphorus-containing food additives results in modest improvement in hyperphosphatemia. This point has been hammered repeatedly by everyone. What we need is qualified, educated nutritionists, which can teach people. Now, coming next to vegetarian compared to the non-veg food. There's a small study, meat diet, vegetarian diet. If you can see, same calories, same amount of 78 gram of protein, both are taking. One group is taking the vegetarian diet, other is taking the meat diet. And after some time, they give a washout period and the diet crossover and the diet is changed. What you find that if you are looking at before meat diet, if the phosphorus was 3.5, after a week of meat diet, it becomes 3.7. Plasma FGF23 rises from 72 to 105. Now, come to next one. Before vegetarian diet, if they become vegetarian, from 3.5, after a week, phosphorus is going to 3.2. Likewise, the FGF23 is coming down. Likewise, the PTH is coming down. So this is very important point. One has to know that this topic was discussed by Dr. Bharat Shah yesterday. I will not harp again. Besides knowing that the vegetarian diet has got high amount of bicarbonate, if you are taking a non-veg diet, besides other harms, you are also producing more acidosis. So vegetarian diet is better for phosphorus control. And lastly, the demineralization of a wide variety of food for the renal patient. That is the boiling. If you look at the boiling of a food for 10 minutes, 20 minutes, 30 minutes, look at this. The protein content is not changing. This is important. But the phosphorus content from 72% going to 46%, almost 33% drop, and in 30 minutes going further down. Now, this is the data again showing that if you are boiling the food and throwing the water, look at this blue chart. This is a dry matter. look at the protein content, which is this maroon color. The protein content by and large is remaining same, whether you are boiling for 10 minutes, 20 minutes, 30 minutes. But if you look at this light yellow, the phosphorus content is steeply coming down. So this is again a chart which is showing that the phosphorus reduction from vegetable, legumes, meats, floats, and cheddar cheese reduces anything from 50% to 70% if you are boiling the food. I think I should stop here, and enough to say the boiling reduces phosphorus contents without changing the protein content. I will summarize and say again, hyperphosphatemia increases the mortality, and KDIGO recommends that phosphorus level be maintained with a normal range. Recommended phosphorus intake is 600 to 700 milligram per day, and average phosphorus content of protein is 15 milligram per gram of protein. Dialysis session removes approximately 700 milligram of phosphorus per dialysis session. Phosphate binders can remove 300 milligram of phosphorus per day if a patient is compliant. And unfortunately, majority of the patients are not compliant with phosphate binders. Without dietary control, therefore, phosphorus homeostasis is extremely difficult. The phosphorus absorption from vegetable source is 30 to 50%, and from animal source, 60 to 70%. We should take proteins from sources where the phosphorus protein ratio is less than 1:12, and egg white is the best form of protein. Food additives, especially processed food, should be shunned. They have got the hidden source of phosphorus, and health education is an important component of phosphorus control strategy. Vegetarian food is certainly better than non-vegetarian food for phosphorus control. Boiling of food is an easy way to reduce phosphorus intake without compromising the protein content. It can result in almost as much as 50% reduction in the phosphorus content. Thank you very much. Like this Siachen photo, keeping phosphorus homeostasis is not easy. Possibly over here at the upper end is possibly a nutritionist who can guide the people how to manage this. Thank you very much.
Thank you, General Verma, as usual. That was a wonderful talk. And, and I think you've highlighted the very importance of phosphates being controlled and how best we can try to achieve that. Since we're running short of time, may I request my co-panelist, Dr. Sundar, to kindly say a few words and wind up this session and about comments on the three topics that we've had. Dr. Sundar, please. Dr. Sundar, are you there?
Thank you, General Verma. As usual, you have explained a tough topic. In fact, phosphate is a tough topic to deal with. And I learned a lot, from you. And you made it very simple. And generally, as you rightly said, in India, I am a vegetarian and I swear by vegetarian diet for me and my patients. And you have reiterated the fact that vegetarian diet is good for kidney failure and especially with dealing with phosphorus. I think a lot of work has been done by the renal nutrition guru, Dr. Kalantar Zade. And if you read his articles, we know that vegetarian protein and phosphorus play an important role. And I'm sure the role of a nutritionist is very important in this. But as Umesh rightly said, that more than the nutritionists, the patients want the doctors to tell us. And they also listen, as you rightly said, to Dabdobi and Chaiwala, whatever. But nevertheless, I think we still have a role based. Still patients have trust in us and we need to know how to go about it. And Dr. General Verma has done a great job in illuminating us on this important topic. I don't think I have any other comment to make. I open the floor for any other question from the audience or the viewers, I would say, virtual audience. Thank you.
I think, Sundar, we have to wind up because they are saying that we are already overshot time. So if you have any comments on any of the three lectures that I've made, and then you can.
I think KC Prakash wants to make a comment. We'll go with that. KC.
Only one question. It's not a question. Yeah, a sort of question. Dr. Verma, do you think nowadays with modernization and you see more of frozen food available, these frozen non-vegetarian items, they contain very high amount of phosphates as preservative, and that is the main cause in West for hyperphosphatemia. Do you think India is going to face same thing?
I fully agree. I think that very rightly said by Dr. Prakash that there is so much of phosphorus because for preservation you require phosphates. And once we are also going on the same line of buying the processed food, buying the chicken or mutton from outside and bringing home, we are going into more phosphorus levels, more phosphorus. You mentioned, as you said rightly, that in India we have got a poor population who are not eating well. At one stage, we say the protein intake is poor. The whole of India is on CKD diet. At the same time, all of us are find that our dialysis patient, 70% have got hyperphosphatemia. But how are they developing hyperphosphatemia? Possibly, this processed food is playing one of the role there. I think the study done by Dr. Anita, possibly in stage 1 and 2 also. I believe yesterday you were mentioning something that even stage 1 and 2 people are developing phosphorus level, which is going up.
Also the milk-based protein that we are taking in large amounts, and that I think is one of the reasons why.
Sir, sorry to interrupt you. We are running 1 hour late. That's why
we wind up the session and we hand it back to the organizers. Thank you so much for giving.
Thank you all of you. Yeah, thank you very much.
Thank you.
Right, now we move on to the next session, that is session 7 on nutrition and COVID. And for this, I invite Dr. Ratan Jha and Dr. Sundar Sankaran as moderators. Over to you. Dr. Ratan Jha is a senior consultant nephrologist in Hyderabad, and you just heard Dr. Sundar. He needs no introduction, so over to Dr. Ratan Jha.
Ratan, I think you run the show for me because I think I've been sitting from the morning. I hand it over to you. It's your show. You're the showstopper. Go ahead, please.
Good morning to all of you. Welcome to this interesting session of nutrition in COVID times in patients who are either on dialysis or not on dialysis, but require some kind of suggestion. So for this session, we have 2 talks by none other than Dr. Anita Saxena, who is going to talk about the first talk is on the general concepts of nutrition in COVID, and the second talk is again going to be delivered by her on the issues of managing nutrition in a patient of dialysis in the COVID times. Professor Anita Saxena is to start her first talk. I invite her to go with her presentation.
Sure. Thank you, Dr. Jha. And can I share my screen now? Okay. Right. So here I am. Okay. So. Right. So good afternoon, everyone. And yes, I'm going to take up 2 talks. Actually, the first talk that is on nutrition in COVID, the guidelines, that was supposed to be taken by Dr. Davi, but because he's not able to come, and so I will be presenting the talk. I've compiled that talk very quickly. And right. And so the first talk I'm going to take on is the irregular dialysis due to patients on irregular dialysis due to COVID-19 pandemic lockdown. So how do we manage them nutritionally? So it was Megan Freeland, a copywriter and strategist who helps the healthcare companies move forward, said, most viruses don't disappear no matter how much we want to. The novel 2019 coronavirus is no different. And then Dr. Anthony Fauci, the director of the US National Institute of Allergy and Infectious Diseases, who spearheads White House Coronavirus Task Force, said, we will see that novel coronavirus will strike again and re-emerge later this year as second wave in the October-November period. Now, India has more than 130,000 patients who need regular dialysis for survival. March the 25th, 2020, last year, was the first day of India's nationwide lockdown, and dialysis patients were amongst those hit most by the restrictions, with the media reporting patients dying because they were unable to get timely care. Now, 13 January 2021, this year, India's active COVID cases declined to 2.14 lakhs after 197 days, but the globe again has come under the grip of second wave of COVID-19 pandemic. So patients on dialysis, according to the Government of India Ministry of Health and Welfare guidelines for dialysis COVID statement, says that the patients on dialysis, whether they're on maintenance dialysis or on CAPD, are also vulnerable group to COVID-19 because of their existing comorbidities, repeated unavoidable exposures to hospital environment, and immunosuppressed state due to CKD5. Now, in end-stage renal disease, we know body's balance of several minerals and fluids is maintained by dialysis. Dialysis treatment requires radical lifestyle changes, including water and food restrictions, regular attendance at dialysis unit for treatment, and continuous use of medicines. Now, irregularity in dialysis sessions subjects patients to mineral imbalances, which greatly contributes to morbidity and mortality. So what if there is lockdown again and the patient undergoes and goes for irregular dialysis? And so what is going to be the way out? The issues which need to be addressed in patients who are going to be on irregular dialysis or even otherwise who are regularly on dialysis are volume overload, hyperkalemia, hyperphosphatemia, uremic symptoms, inflammation, uremic toxins, and metabolic acidosis. So moving on to volume overload, so we're going to talk about fluid restriction and sodium restriction. Now, restoring fluid balance and preventing interdialytic weight gain is the goal of dialysis treatment, because fluid retention is associated with cardiovascular mortality in chronic hemodialysis patients. And we've had beautiful talk by Dr. Sampath Kumar, excellent talk, and he's covered most of the things that I would have wanted to talk in this. So fluid volume and hemodynamic management in hemodialysis patients is an essential component of dialysis adequacy. Chronic fluid overload, defined as more than 15% above normal ECF, equivalent to 2.5 more than 2.5 liters on average, unlike interdialytic weight gain, exhibits more than twofold increased risk of mortality. So therefore, restoring salt and water homeostasis in hemodialysis patients and achieving dry weight is the target of ESRD management. If you have a look at this box is just showing you that during the interdialytic phase, the patient undergoes chronic hemodynamic stress, that is because of fluid overload, hypovolemia, hypertension, congestive injury, and cardiac remodeling. So a patient is actually uremic. He has uremic symptoms like anorexia, nausea, vomiting, retention of sodium, and uremic toxins. So therefore, between two consecutive dialysis, the treatment's weight gain is due to fluid retention. Hence, interdialytic weight gain is a function of oral fluid intake that includes routine food ingestion and is associated with poor all-cause and the cardiovascular survival. So this figure is actually showing you that fluid and sodium accumulation in dialysis patients occurs over time due to repetitive positive fluid imbalance. So this figure is showing you high interdialytic weight gain is associated with high risk of death in these patients. Now, Dr. Sampath Kumar has already covered this area, how the fluid status has to be assessed and how it has to be monitored. Quick recap, we have to go for clinical assessment, the non-invasive instrumental tools like lung ultrasound, which he showed, bioimpedance, which he showed again, blood volume monitoring, you can see on the right-hand side, and cardiac biomarkers and sodium modeling. So here, this is my own work, that's why I'm showing you that we use the blood volume monitoring in some of the patients. And you see this gap here. What happens is the moment the hematocrit reaches its threshold, the ultrafiltration is stopped. And so the crashing blood pressure can be prevented. And this is what we did. And we've published this work as well. Now, optimal management of fluid and sodium imbalance in dialysis patients consists of adjusting salt and fluid removal by dialysis and by restricting salt intake and fluid intake and gain. Educating patients on fluid goals and advising them to share standard measuring cups and spoons for quantifying salt is a very good approach for these patients. Replacing fluids in such cases where the patients are not on regular dialysis. So what you can do is you can replace fluids like milk and yogurt with something solid like paneer or cheese or chicken or fish or egg white. and soya nuggets and soya protein. And also telephonically, if you can counsel your patient, that will be a reminder for fluid restriction, because it is important, because salt restriction is required, because otherwise the patient feels very thirsty. And so therefore you have to be reminding the patient of not to be taking excessive amount of fluid if he's not coming to the clinic regularly because of lockdown or something. And to quench thirst, you can use lozenges, which can be taken twice or thrice a day. But they do have some disadvantage in terms of GI upsets and all. And patient education on low salt diet can reduce interdialytic weight gain by 30%. A post hoc analysis from the hemodialysis study on 1,800 chronic hemodialysis patients showed a significantly increased risk of death with a dietary sodium load of more than 2.5 grams per day. So if you have a look at this table is showing you that in case the serum sodium is 138.3 or 3.9 milliequals, the UF requirement is normally 2.9 liters per session. And here, this is a study in which the patients were kept on low sodium and low sodium diet. And here in this column, you can see the patients who were on low sodium diet, that is less than 2 grams per day, compared to patients on the right side, which were on more than 2 grams of salt per day. They found that the post-dialysis weight gain was less in the patients who were on less than 2 grams per day of salt, and the calorie, potassium, and protein intake was also lower in these patients. And so the patients who were taking more than 2 grams of salt per day were more prone to getting hyperkalemia. So the advice for such patients is that you should take, I would go for JNC's advice, that is recommendation that is less than 1.5 grams of sodium and reduction in the salty processed foods and cheese and meat. The KDOK advises less than 2.3 grams for better control of blood pressure and edema. Modification of lifestyle is required, 40 minutes of exercise or 5 every day, or walk for 5 days a week, and dietary interventions like low fat intake, and patients will have to avoid canned foods, fruits, pickles, fruit jams, because these contain salt as preservative. And hyperkalemia can result in these patients from irregular dialysis, acute exposure to a high potassium meal, and from accumulation of potassium by consuming a high potassium diet regularly. Now, high serum potassium requires potassium restriction, and we know that serum potassium correlates closely with nutritional markers, in particular the NPCR, suggesting that patients who eat more protein also tend to have a high serum potassium level. Now, if you have a look at this figure is showing you that the pre-dialysis potassium of 4.6 to 5.3 milliequals is associated with greater survival, and a potassium level of less than 4 or more than 5.6 milliequal is associated with increased mortality. So hyperkalemic patients who undergo maintenance hemodialysis against lower dialysis bath may have better survival to prevent deleterious cardiovascular effects, and this will also correct serum potassium levels. So dietary strategies should be used to avoid large fluctuations in serum potassium concentration while maintaining adequate nutrition. Now, we know that 1 gram of protein contains 1 milliequal of potassium, so restrict dietary protein to tolerable thresholds to restrict potassium intake in patients who are on irregular dialysis. Restrict fruits and leafy vegetables in these patients who are not able to come to the dialysis unit for irregular and they're on irregular dialysis. If serum potassium is more than 5, we know that we have to stop their fruits intake and their green leafy vegetable intake, and we must encourage them to leach potassium from the leafy vegetables. Now, hyperphosphatemia is a strong predictor of mortality in advanced CKD stages. And as you just heard Dr. P.P. Verma, excellent talk by him. I'm not going to talk about hyperphosphatemia. In fact, I can skip some slides where we have to restrict phosphorus between 600 to 700 milligrams. And you know that the protein has a linear relationship with phosphorus. 1 gram of protein contains 13 to 15 milligrams of phosphates. So as you increase protein intake, the phosphorus intake is going to increase. And a patient who is on irregular dialysis and is non-compliant to phosphate binders also is at a risk of developing hyperphosphatemia, and consequently, it's not a good thing. So we have to restrict protein in these patients. So if patient is missing dialysis, reduce protein intake to control hyperphosphatemia, and we must advise phosphate binders to these patients, which have to be taken with meals in order to control hyperphosphatemia. Now, this paper is a beautiful paper on the power of hyperproteic nutrition in end-stage renal failure, which is like real therapy. And this advocates that if patient is missing dialysis, then on a non-hemodialysis day, advise protein-free diet and restrict foods rich in potassium and phosphorus. And on dialysis day, what you can do is you can increase the protein intake from to 1.2, 1 to 1.2, so that the hypercatabolic effect of dialysis is combated. And reducing protein intake while keeping energy intake stable by increasing carbohydrate and fats maintains good nutritional status and prevents need for high doses of dialysis. So this is once weekly dialysis, and you can see that this is a comparison between of patient survival on once weekly dialysis and patients who are on regular dialysis. So you have higher patient survival when you restrict protein, and you have enough carbohydrates and fats supplying energy to these patients. This is yet another paper which is talking about once weekly hemodialysis treatment combined with low protein, low phosphorus, normal to high energy diet on non-dialysis days and high protein on dialysis day. Now, low protein intake will also take care of uremic symptoms. So, but low daily protein intake or decrease in its magnitude over time will be associated with increased risk of death in maintenance hemodialysis patients, because the nutritional status is going to come down. So you have to combine keto analogs with low protein diet in these patients. This is a paper by Giovanni and Locati on integrated dialysis dietary program, in which they prescribe very low protein diet, that is 0.3 to 0.4 grams per kg body weight per day of protein, along with keto analogs. However, this approach was not very successful, as there were about 67% dropouts in this program. So this program was remodified as combined diet dialysis program, in which they actually gave 0.6 grams per kg body weight per day of protein along with keto analogs. And the outcome was the patients were able to overcome uremic symptoms. There was a better control of, there was adequate metabolic control, because there's this kind of diet reduced generation of uremic toxins and preserved residual renal function, and avoided, excessive ultrafiltration, which is given more frequent in more frequent dialysis, and that can actually worsen renal perfusion. And if the patient has a little bit of residual renal function, then there is always a risk of losing even that amount of residual renal function. And at 96 months of follow-up, the same remaining patients, however, had higher cumulative survival rate in the combined diet dialysis program. And this is yet another paper by Stefania Caria on once weekly session of dialysis combined with very low protein diet, low phosphorus diet, and supplemented with keto analogs. Now, this figure is showing you the diurnal variation of phosphorus in blood and urine studies in meat diet versus vegetarian diet. And as Dr. P.B. Verma has already talked about this, you can see that patients who are on meat diet, the phosphorus, calcium, and fractional excretion is higher in them, and compared to the vegetarian diet. So patients who are on vegetarian diet, they have, they are much better off, and they have lower PTH levels also. So prefer vegetarian-based diets for control of phosphorus homeostasis, because only 40 to 50% of phosphorus is going to be absorbed. And one has to restrict protein-rich foods, dry fruits, hard cheeses, egg yolk, meat, poultry, and fish, cola beverages, snack bars, instant products, and refrigerated bakery products. And also you have to prescribe foods which are low in protein and phosphorus ratio. And of course, there's so many equations are available to estimate the content of phosphorus based on amount of protein on a mixed diet. Now, moving on to inflammation, uremic toxins, and irregular bowel movement in our patients, which warrants fiber-rich foods. So this is an update on inflammation in chronic kidney disease patients. With the key message that modification of physical activity and dietary supplementation of fiber and probiotics are inexpensive approaches to reducing inflammation in these patients. And regular walking, they have shown, has exerted anti-inflammatory effects. So there have been a reduction in the ratio of plasma IL-6 and IL-10 levels. And also this is a nifty trial which was discussed yesterday. This also has shown that symbiotic therapy in CKD stage 5 has anti-inflammatory role. And dysbiosis of microbiota can be improved by taking plant foods, pulses, and fiber, that is 30 to 40 grams per day, with careful consideration of potassium levels to reduce generation of uremic toxin, and also to have adequate metabolic control and reduce oxidative stress. So here you can see that dialysis clears uremic toxins like indoxyl sulfate and precresol sulfate. And if the patient is missing dialysis, ensure high fiber diet to the tune of 25 to 35 to 40 grams per 1500 calories. And these are the foods of, which are good sources of fiber, like whole grains and cereals. Now you see this figure is showing you reduction in uremic toxins on introducing insoluble fiber in the diet. Last year, we presented in the late-breaking clinical trials at ASN Renal Week this multi-centric enzybiotic study, in which we showed that over 90 days, if you give enzybiotic therapy to the patients, the precresol and the indoxyl sulfate levels come down, and there is improvement in the quality of life. So the take-home message of my talk is the two things are clear from last year's experience and this year's experience is that we do not understand enough about this virus. And second, we cannot let our guards down, even if the number of infections decline and vaccinations proceed apace. So the ideal diet prescription for a patient on irregular dialysis would be to restrict fluid, low salt, low protein, preferably vegetarian protein, along with the keto analogs, and high fiber and proteolytic enzymes and probiotics should be recommended to the patients. Although I know about the pill burden the patients have, yet you have to weigh the benefits of these and to prevent volume overload and uremic symptoms, formation of uremic toxins, and to control inflammation and soda bicarbonate supplementation is important to control metabolic acidosis. And you have to feed these patients very well. There's no doubt about it. So thank you for your attention. And I will move on to the first talk now, which is on guidelines for nutrition in COVID. Now, the reason why I picked up Dr. Ashwin Dabi for this talk was that you see this best practice position paper of IPN for nutritional support of SARS-CoV, patients' nutrition support in SARS-CoV-2, he is the lead author of this. And I thought he was the best person to talk about this here in this session. So anyways, I've compiled the guidelines from American Society of Parental and Enteral Nutrition and SPIN and Society of Critical Care Medicine, and so on and so forth. So as far as recommendations are concerned, there are no specific guidelines on nutritional management of CKD patients. Nutrition management of the ICU patients with COVID-19 is in principle very similar to any other ICU patient admitted with pulmonary compromise. So the most common reported reason for intensive care unit admission for patients with severe coronavirus disease are either hypoxemic respiratory failure leading to mechanical ventilation or hypertension requiring vasopressor support. Now, this is an algorithm which is a 10-step nutritional management of patients with the COVID disease. So here, the step 1 is check malnutrition, then go for optimization of nutritional status, supplementation with vitamins and minerals is important, regular physical activity, oral nutritional supplementation is important, then enteral nutrition has to be given to the patient, and then medical nutrition, medical nutrition in intubated and patients, non-intubated and intubated patients. These are all dealt with in this in my subsequent slides. Then medical nutrition in intubated ICU patients who are critically ill and who are overstaying in the ICU, and also the nutrition in ICU patients with dysphagia. So the patients who are at risk for poor outcomes and high mortality following infection with SARS-CoV, namely older adults and polymorbid individuals, should be checked for malnutrition through screening assessment. I'm not going to define polymorbidity. We know that the check should initially comprise the must criteria, or for hospitalized patients, NRS 2002 criteria. Now, must criteria is a 5-step screening tool to identify adults who are malnourished, at risk of malnutrition, undernutrition, or obese. So it has 5 steps. The step 1 is BMI score. Step 2 is a percent weight loss score. And step 3 is to establish acute disease effect. And step 4 is adding up steps 1, 2, 3, and obtaining an overall a score for the malnutrition. Then use management guidelines or local policy to develop a care plan. So step 5 is that if your patient has 0 score, then he is at low risk. If he has 1 score, then he has medium risk of developing malnutrition. And if he has a score of 2, then he's a high risk of developing malnutrition, and you have to treat him properly, energy requirement, protein, and, well, of course, a proper nutrition prescription for him. And then you have to reassess subjects identified at risk as they move from one stage to the other stage. Now, NRS 2002 predicts risk of malnutrition in hospitalized patients, and it takes into consideration the BMI, the weight loss within 3 months, reduced dietary intake in the last week, ICU status, whether the patient is in ICU or not. And if the patient has low risk, then he's rescreened weekly. But patients who are at risk of malnutrition, they have to be considered for a nutritional advice. Now, energy requirement in these patients should be assessed using weight-based formula: 27 kilocalories per kg body weight per day. Total energy expenditure for polymorbid patients under more than 65 years of age: 30 kilocalories per kg body weight per day if the total energy expenditure is for severely underweight polymorbid patients, and 30 kilocalories per kg body weight per day of energy is the guiding value for energy intake in older patients. Now, this value should be individually adjusted with regards to nutritional status, physical activity level, and disease status of the patient. Now, adapted to the energy needs should be the fat and carbohydrate ratio, and so there it should be either 30:70 if the subject has no respiratory deficiency, but 50:50 if the patient is ventilated. Yes, in general, low levels or intakes of macronutrients such as vitamin A, E, B6, B12, zinc, selenium have been associated with adverse clinical outcomes during viral infections. So ESPEN guidelines recommend supplementation of vitamin A, B6, B12, E, D, B, C, selenium, and omega-3 fatty acids to support immune function in these patients. Now, every day, more than 30 minutes of or every second day, physical exercise is important, or 1 hour exercise is important to maintain fitness, mental health, muscle mass, and thus energy expenditure and body composition. Now, prolonged home stay in these patients may lead to increased sedentary behaviors, reducing regular physical activity and hence lower energy expenditure, and lead to an increased risk for potential worsening and of chronic health condition, weight gain, loss of skeleton and the muscle mass and strength, and possibly also loss of immune competence. So therefore, we must encourage them to go for exercise. I've already shown you this. And now moving on to oral nutritional supplements. These provide energy-dense alternatives, and we've already heard Dr. Khanna speak about the oral nutritional supplements, but, well, I'll also say a few words that these are alternatives to regular meals and maybe specifically enriched to meet targets in terms of protein as well as micronutrients. Oral nutritional supplements should be used whenever possible to meet patients' need when dietary counseling and food fortification are not sufficient to increase dietary intake and reach nutritional goals. Now, ONS shall provide at least 400 kilocalories, including 30 grams or more of protein per day, and shall be continued for at least 1 month. Efficacy and expected benefit of ONS shall be assessed once a month, and nutritional treatment should continue after hospital discharge with ONS and individualized nutrition plans. Now, initiating early enteral nutrition within 24 to 36 hours of admission to ICU or within 12 hours of intubation and placement on mechanical ventilation should be the goal. Initiate trophic enteral nutrition if the patient does not have escalating requirement for vasopressors, combined with enteral feeding, intolerance, and symptoms of ileus. Energy protein intake in ARDS patients treated with non-invasive ventilation is expected to be inadequate. So patients oxygenated through nasal cannula may be commonly deemed medically appropriate to resume oral alimentation. Now, recommendation to start enteral feeding should be impaired by the fact that placement of nasal gastric tube for nutrition may result in air leakage that may compromise the effectiveness of NIV, stomach dilatation that may affect diaphragmatic function and affect NIV effectiveness. So this may account, at least in part, for highly inadequate implementation of enteral nutrition program, which may result in patient starvation, especially in the first 48 hours of ICU stay, and a higher risk of malnutrition and related complications. So peripheral parenteral nutrition may therefore be considered under these circumstances. Now, patient oxygenated through nasal cannula may be commonly deemed medically appropriate to resume oral alimentation. Now, if you have a look at this table is showing you the various. Oh my God. Okay. So the nutritional support in various settings. The settings are oxygen therapy and mechanical ventilation and organ failure, whether the patient is in the ward, the patient is in the ICU for a day or two, or he has prolonged stay in ICU. And then once he's been discharged from the ICU and then he's into the ward for rehabilitation. So all this table is telling you that you have to screen the patient for malnutrition. You have to start enteral feeding ONS, and the dietary energy protein targets have to be met. The vitamins have to be given, and enteral feeding has to be preferred over parenteral feeding, and assess dysphagia and use oral nutrition if possible in these patients. Remember that patients no longer needing mechanical ventilation have high incidence of swallowing problems and consequent dysphagia, which may be prolonged for up to 21 days, which may strongly limit oral nutrient intake. So swallowing assessment and evaluation should be done, and active and passive physiotherapy should be done to optimize the patient's nutritional needs and physical condition. Now, in COVID-19 disease, concern for ischemic bowel may be greater, and a prolonged ICU stay is expected. Therefore, early switching to parenteral nutrition may be needed in high-risk patients for whom early gastric enteral nutrition is not feasible. Before the onset of respiratory symptoms, some patients do initially present with diarrhea, nausea, vomiting, abdominal discomfort, and in some cases, gastrointestinal bleeding. Early enteral nutrition may not be preferential in this subset of patients, so prefer parenteral nutrition before transitioning into enteral nutrition when GI symptoms subside. Now, critically ill patients with COVID-19 disease are usually older patients with multiple comorbidities. Such patients often are at risk of refeeding syndrome resulting from over rapid or unbalanced nutrition support provided to malnourished patients. So identify pre-existing malnutrition or other risk factors for refeeding syndrome. If refeeding syndrome risk is present, then start feeding the patient at 25% of calorie goal with the frequent monitoring of serum phosphate, magnesium, and potassium levels as calories are slowly increased. The first 72 hours of feeding is the period of highest risk in these patients.
Ma'am, sorry to interrupt you. Your slides are not moving. Hello, ma'am. Can you stop sharing and share again? Your slides are not moving.
But I think the talk is more or less over, I think.
Ma'am.
Anita? She's on mute.
Ma'am, please unmute yourself.
Okay.
Anita, your slides are not moved. Only first slide was there on dialysis and no dialysis.
You couldn't see my slides.
No. We were assuming, I was thinking that you were talking without the slide except the first slide, which said about non-dialysis.
Excuse me, I've got into some trouble. My Okay, so what do I do now? I go back.
Please share again.
All right. Okay, I'll share again, and here is my this talk. Okay.
Now you're able to see.
You
You want to go to slideshow?
I know, but I am right slideshow.
There is not there. It's there.
Yeah, right. So I was, where was I? I've forgotten. Oh, right. Okay. I still have about, yeah, I've covered this table. And then patients, yes, I've covered this part also and this part. So enteral nutrition is preferred to parenteral nutrition continuous rather than bolus. Enteral nutrition is strongly recommended as it decreases exposure of the healthcare treatment, healthcare team to SARS-CoV. And before the onset of respiratory symptoms, yes, some patients initially present with diarrhea, nausea, vomiting, abdominal discomfort, and in some cases, gastrointestinal bleeding. So early enteral nutrition may not be preferential in this subset of patients. So prefer parenteral nutrition before transitioning into enteral nutrition when GI symptoms subside. I think I have already spoken about refeeding syndrome. So feeding should be initiated with a low dose enteral nutrition defined as hypocaloric or trophic feeding, advancing to full dose enteral nutrition slowly over the first week of critical illness to meet energy goal of 15 to 20 kilocalories per kg actual body weight, and provide protein between 1.2 to 2 grams per kg body weight per day. Now, during critical illness, 1.3 grams of per kg body weight of protein equivalent per day can be delivered progressively. If parenteral nutrition is necessary, dextrose can be used in the early phase of critical illness. Now, a standard high protein polymeric isosmotic enteral formula should be used in the early acute phase of critical illness. As the patient's status improves and vasopressor requirements abate, addition of fiber should be considered. If there is a significant GI dysfunction in this patient, fiber-free formula may be better tolerated. As soon as GI dysfunction improves, fiber-containing formula or supplement should be attempted for non-nutritional benefits to the gut microbiota. Fish oil containing formulations may benefit in immune modulation and help to clear viral infections. Supplement nutrition modules such as protein packets, probiotics, or soluble fibers should be given once a day in order to cluster care. If parenteral nutrition is required in the first week of IC stay during the acute inflammatory phase of COVID-19, avoid use of pure soybean lipid emulsion, monitor serum triglyceride levels, and patients should be monitored by daily physical examination and confirmation of passage of stool and gas, record percent of calories and protein delivered. Gastric residual volume monitoring is not reliable for detection of delayed gastric emptying and risk of aspiration. And nutrition for patients undergoing prone position. Remember that enteral nutrition during prone position is not associated with the increased risk of gastrointestinal or pulmonary complications. It is recommended to keep the head of the bed elevated to at least 10 to 25 degrees to decrease the risk of aspiration of gastric contents, facial edema, and intra-abdominal hypertension. Retrospective and small prospective trials have shown that most patients tolerate enteral nutrition delivered into the stomach while in the prone position, but on occasion, a post-pyloric placement of feeding placement of the feeding tube may be indicated. No data are available on nutrition support during ECMO and COVID-19 disease. You can start early dose, low dose enteral nutrition with close monitoring of enteral feeding, intolerance, and low advancement to goals over the first week of critical illness. So the take-home message of my talk, which I really rushed through because we were already running 1 hour late, so I was kind of just pushing myself. So I conclude my talk by saying that screen patients for malnutrition, plan energy and protein intake judiciously. Vitamin B, C, selenium, and omega-3 fatty acids should be given to support immune function. Physical activity should be encouraged in these patients to prevent muscle loss and to boost immunity. Enteral nutrition is preferred to parenteral nutrition.
You're not able to hear anything?
No, I am not able to hear.
Nobody can hear.
Sorry?
Anita, go ahead, ma.
Sundar, I think you can stop here.
Yes.
Yeah, we have. I'm through with my this thing.
Okay, Ratan, go ahead, Abba. Please.
Yes.
It's your show.
Yes. Thank you, Dr. Anita Saxena, for covering the two important talks on management of nutrition during COVID times in patients who had AKI and a CKD, and the principles were well elucidated. I have one kind of question that these days we get a lot of kind of recommendations on the WhatsApp about the nutritional food, like which is going to immune boost, like many kinds of drinks are advised, many kinds of food supplements are advised. You have not touched on that. Is there anything that we can suggest to the patient to incorporate in the diet who are not on at least in acute care?
I think it's a good question. Even I was thinking of the same thing, like zinc, and I was just reading the Harvard study, whether vitamin C, zinc, vitamin D, melatonin, all this should we be adding to the diet, and what is your recommendation?
Yeah, well, I did. I don't know whether you saw that slide or not. I did mention that vitamin E, C, selenium, zinc, and all those things have to be added as immunity boosters to these patients. So if you have the supplements available, you must use them.
So that you're suggesting during the ICU phase, or even anybody with kidney problem with COVID on a routine basis they use?
I think we should be on guard for because hemodialysis patients are at risk of COVID infection. So we should be on guard. Zinc supplementation, I think we should think of that. But if a patient has COVID, then definitely these things have to be given to the patient.
Okay, that's a good suggestion because that is what people keep asking us. And there is also some thing on the transplant patients taking these immune boosters. Some evidence show that it causes rejection and some problems with the immune boosters. So that is one point which we'll have to be aware when you're dealing with transplant recipients.
Yeah.
Dr. Jha.
Just in one of the slides which I found quite interesting, that in COVID times when patients are going to miss dialysis because of many reasons, should we advise low protein diet and on?
Yeah.
That is a good side, actually.
Yeah. That is you have to advise low protein diet on non-dialysis days, and then the day the patient goes on dialysis, he should be advised to take 1 to 1.2 grams per kg body weight per day of protein. That is high, that is the normal dialysis diet, so that the patient is able to combat uremic symptoms if he's not coming for dialysis for 5 days, and then when he comes for dialysis, he doesn't go into hypercatabolism, yet he's able to get rid of the uremic toxins and the fluid that is accumulated. So that will take care of uremic symptoms. Yes.
Yes. So,
anything else, Ratan?
No, Dr. Sundar, you can ask.
I think we're already running late, and
we are running really late. Yes.
And I got a message from my former colleague, Dr. Dilip Balla. He is waiting in the queue to take part, so I will not come in his way. Thank you, Anita, and thank you, the organizers.
Yeah.
Welcome. Thank you.
Right. So thank you, Dr. Sundar and Dr. Ratan Jha for moderating the session. And well, we move on to the next session now, which is on diabetic nephropathy. And the moderator for this session is Dr. Dilip Balla.
Hi.
Good
morning. Good morning. Yeah.
Yeah.
Okay.
Hi, sir. Let me introduce you at least. Well, one of the favorite nephrologists. He's a senior director nephrology, and he's a consultant nephrologist and a transplant nephrologist. So he is working at Max Institute of Renal Sciences at New Delhi. And I request Dr. Balla to please take over the proceedings now.
Thanks, Anita. Thanks for the kind introduction. And we're running late, but it's okay. We still have important topics to discuss. We are discussing two topics today about diabetic nephropathy. The first would be none other than our illustrious and highly, I would say, acclaimed and very much recognized Secretary of the Indian Society of Nephrology is going to be Dr. Narayan Prasad. I think nobody needs any introduction about him. and he'll be talking to us about the natural course of diabetic nephropathy. It'll be very interesting to know that what has happened and has the course changed over the last 30 years that we've been in practice and we've been in nephrology. And the second talk would be the importance of glycemic control in CKD patients. This will be by Dr. Ritu. So not coming in between you, I would request Dr. Narayan to please start to share his slides and start the presentation. Once his presentation is over, we'll go on to the next talk done by Dr. Ritu Karoli. And once hers is over, if we have time permitting, we can have a small discussion. Dr. Narayan, please, can you please share your slides? Is Dr. Narayan on? I think somebody will have to call him, I think.
Sir, are you online, sir? Dr. Narayan?
I think everybody was expecting this, it's going late, so everybody is probably, do we have a second speaker, Dr. Ritu?
Dr. Ritu Karoli's ma'am is here only.
Yeah, so can I just, we can have a presentation first. Can I just have an introductory slide of Dr. Ritu, please?
Dr. Ritu, please unmute yourself.
Yeah, so Dr. Ritu will be talking to us. There's a slide shift, there's, in the presentation first, Dr. Ritu will be talking to us about the glycemic control. She is an associate professor at the Ram Manohar Lohia Institute of Medical Sciences, Lucknow. So not coming between you and her, basically I would request Dr. Ritu to start a presentation. She can, Dr. Ritu, are you ready with your presentation?
Yeah.
Yeah, please kindly share your slide. And there's a slight change in the format, so you'll be the first speaker of the session. In the meanwhile, they'll try and trace Dr. Narayan, please. Please, Dr. Ritu, over to you.
So good afternoon to everyone. At the outset, I would like to thank Anita madam for giving me this opportunity. So topic given to me is glycemic control in diabetic patients with CKD.
Ma'am, please go to the full slide mode.
So during my talk, I will be discussing about the implications of glycemic control, about the glycemic targets in CKD, and what are the recommendations which have been given by ADA, that is American Diabetes Association. So as we all know, nephropathy, it occurs in nearly 20 to 40% of diabetes patients, and it is the leading cause of end-stage renal disease across the globe. And India is not different from the rest of the world. This is about the diabetes and the renal outcomes. As we know, in the natural history of the diabetes and diabetes kidney disease, it goes from incipient diabetic nephropathy to end-stage renal disease in 20 to 25 years. And it starts from in the first stage, it starts from the hyperfiltration. And in this stage, there is the GFR actually, it increases. And it takes about 20 years to come down in the final reduction in the GFR, and the patient reaches to the renal replacement therapy. And correspondingly, there are irreversible changes also occur in the kidneys. And hyperglycemia, we all know that is the fundamental cause of all vascular complications associated with diabetes, whether it is microvascular complications or macrovascular complications. And it is true in the cases of diabetic kidney disease. If we will see this figure, which has been the guiding force by American Diabetes Association, this shows a very small part, which is green in color. So the importance of this green color is this, that in this part of the CKD, this is this part in which physicians can do something. In the rest of the yellow and in the red part, nothing much can be done as far as the reversibility of the condition is concerned. If we will see the glycemic targets which have been suggested for any of the adult patient in general at the outset of diabetes diagnosis, so that says that the ideal A1C should be less than 7%. The preprandial glucose levels should be between 80 to 130 and the postprandial glucose level should be less than 180. But these are the ideal targets and one size cannot fit all. So we have to see that the glycemic targets should be individualized. And this individualization of the glycemic targets, actually it depends upon the age of the patient. It depends upon the life expectancy, the duration of diabetes, the presence of comorbidities, then the presence of other diabetic complications, and more so, what is the preference of the patient and in which socioeconomic status he belongs to, or what is his support system. So all that actually leads or decides what should be the glycemic target of that individual patient. As far as the management of diabetic kidney disease is concerned, we all know that there is no certainty that intensive glycemic control will actually prevent the clinical endpoint of ESRD. But there is the evidence that if the early manifestations of kidney disease, if they can be reduced or they can be delayed, then the eventual occurrence of ESRD can also be reduced or it can be delayed. If we will see these important glycemic control trials, in which these trials have been done in both types of diabetes, that is type 1 diabetes and type 2 diabetes. The important trials, DCCT and EDIC, have been done in type 1 diabetes, while the UKPDS, ACCORD, ADVANCE, and Veteran Affairs diabetes trials have been done on type 2 diabetes. So these trials actually have reached to the conclusion that if the stringent glycemic control is maintained in the early part, in the early stage, then there is this microvascular complications can be reduced, and it can also bring the beneficial effect on all the microvascular complications and also in the CKD occurrence. But these beneficial effects of stringent glycemic control, they are achieved with the risk of severe hypoglycemia. So we all have read these trials, ACCORD and Veteran Affairs diabetes trials. In these trials, the type 2 diabetes patients were taken, and they also included patients with kidney disease as the participants, and they have shown the high mortality and high morbidity in these patients, and they have given us the learning that we should not treat these subgroup of patients with a target of less than 7% because they are very much associated with hypoglycemia and all-cause mortality. Then what is the role of kidney in glucose homeostasis and hypoglycemia if we are targeting the intensive glycemic control? We know that the gluconeogenesis takes place in kidneys, and there is also large amount of filtered glucose is being reabsorbed in the proximal part, nearly 90%, and insulin clearance is also by the kidneys. So what will happen if the patient has advanced kidney disease? So there will be, these patients are very much prone to have hypoglycemia. So whenever we are talking of glycemic control, we should not forget about hypoglycemia because it goes side by side. So the important causes for hypoglycemia in this subgroup of patients is because there is decreased clearance of insulin in these patients, and also there are various oral hypoglycemic agents which are not being cleared. And second reason is the impaired renal gluconeogenesis which takes place because of the reduced nephron mass. Then what should be the glycemic targets in patients of diabetic kidney disease? So it is recommended that the A1C of 7% is reasonable to prevent or delay the progression of the microvascular complications, including diabetic kidney disease. And if the patients have less life expectancy and they have associated comorbid status, or they have high risk of hypoglycemia, then the target can be extended between 7% to 8%. In patients of end-stage renal disease, the fasting glucose is recommended to have less than 140. So it can be between 100 to 140 reasonably. And 1 hour postprandial glucose can be less than 200, particularly who are on maintenance hemodialysis. And a reasonable goal of HbA1c between 7 to 8% can be maintained in these patients. And guys, glycemic control is not the only thing which should be stressed upon, and it is a part of multifactorial intervention strategies that should also address the blood pressure control and cardiovascular risk reduction in patients of CKD. Then what are all the important points which have to be addressed when we are selecting the agents of glucose lowering medications in this subgroup of patients? So as we know that glycemic control is important, because even if it does not reduce the increase in creatinine or in reduction in EGFR, but it will help us in maintaining the, at least it will not make the patient vulnerable for other complications such as infections and impaired wound healing. So glycemic control is has to be taken care of. But the other important issues which have to be addressed when we are treating the patients of CKD, that is the CVD risk reduction, then the occurrence of hypoglycemia, and if the patient is in early stage of CKD, then definitely CKD progression. So I'm sorry for this slide, that it is a busy kind of slide, and maybe that it is not very much apparent what is written in this. So this is the recommendation given by the American Diabetes Association, and this is about the standards of medical care in diabetes, and it is the latest edition, that is in 2021, which has been published in Diabetes Care. So this recommendation tells us that the first line therapy which should be in these patients is metformin, because as we all know as physicians that metformin is a very good drug as far as the efficacy in HbA1c reduction is concerned. It is a weight neutral, rather it reduces the weight, then it has a beneficial effect on lipid profile, and it has a very low risk of hypoglycemia. So metformin is the drug of choice for all the diabetes patients, and it is the first drug that is being written on the prescription of physician. And not only the patient of diabetes without any CKD or any other comorbidity, but also the patients of CKD, the metformin is the drug of choice. So it is the first drug which is to be written even in patients of CKD. But we have to remember there are certain conditions in patients of CKD that metformin can be given only up to EGFR of 45 ml. So before that we can give it safely, but if patient's EGFR is approaching 45, then we have to take caution and the dose has to be modified, and the metformin use is contraindicated in patients who have GFR less than 30 ml. Then the other thing which is being written in this, that about the other agents. So preferential agents which have to be used in patients of CKD are two. The one is the SGLT2 inhibitors. So it is written here. The SGLT2 inhibitors are in the upfront use, and they are very much given the importance in this chart. And not only the SGLT2 inhibitors, but also the second group, that is GLP-1 receptor antagonist, that is glucagon-like peptide 1 receptor antagonist. These are the two drugs which are being emphasized in the new recommendations, and these are the drugs. If we will see the other pharmacological agents which can be used in patients of CKD, so this figure shows that most of the drugs actually can be used, such as sulfonylureas, pioglitazone, acarbose, DPP4 inhibitors, which are also which act similarly as the GLP-1 receptor antagonists. Actually, they are the inhibitors of the DPP4 enzyme. So there is increase in the GLP-1 activity. So they are working on the same mechanism. Then the non-sulfonyl ureas agents, which are also the insulin secretor box. The commonly used is the repaglinide. So all these pharmacological agents, they can be used in patients of CKD. But if you will see this figure, beyond stage 3, there are only 2-3 options which have been left. The insulin is the drug which can be used throughout, but we know the problems of insulin. And many of our patients in general practice, they are the insulin is not the first choice in those patients. So even though the insulin is a good option, but it is not the preferred one. But it can be used. The best part is that it can be used always in non-CKD patients and also in all stages of CKD. But if we will see the oral hypoglycemic agents, you are left only with 2-3 options. So that is the pioglitazone, that is thiazolidinediones, which reduces the insulin resistance, the DPP4 inhibitors, and the repaglinide. So you are left only with these options. But if you will see the current ADA recommendations, they say metformin is the first choice, which has to be used as first-line treatment with all the contraindications. We have to remember that it has to be used only in CKD patients who have GFR more than 45 or in modified doses between 30 to 45. It has to be stopped if patient has to be taken for any study involving iodinated contrast or patients who are critically ill and hospitalized. So because the metformin has the potential to cause lactic acidosis in such patients, so we have to discontinue it in that subset of patients. But if we need the second line agent and metformin, either it is not being tolerated or we are not able to optimize the glucose control only with the metformin, then what are the other agents which can be used? So they are the SGLT2 inhibitors, that is sodium glucose co-transported 2 inhibitors. They can be used in patients of CKD who have more than 30 ml GFR and they have overt proteinuria in form of more than 300 milligram per grams of creatinine. So that is the preferential drug which has to be used. And ADA also says that not only the importance of glycemic control is associated with the use of these agents, but also because they are involved in reduction of the cardiovascular risk. So these agents have this important benefit. And apart from SGLT2 inhibitors, the GLP-1 receptor agonist also reduce the renal endpoint, which is in form of albuminuria, and they reduce the progression of albuminuria and also have the potential benefit in reducing the cardiovascular events. The specific agents which can be used are the empagliflozin and dapagliflozin, and they have been approved by FDA for the use in patients of CKD who have GFR more than 45. And canagliflozin can be used even in patients who have less than 45, that is up to 30 ml of GFR. And GLP-1 receptor antagonists can also be used with this level of GFR, although they require some dose adjustment. So there is a question that why these agents have given so much importance and have been put so upfront in the management of glycemic control, or in patients in the management of these patients of diabetic kidney disease. As we know that the mechanisms underlying the glomerular hyperfiltration in diabetes are incompletely understood. But the plausible mechanism which can be is that increased proximal tubular absorption of glucose via this sodium glucose co-transporter 2, which increases the distal delivery of which substantially decrease the distal delivery of solutes, particularly not only the glucose but also sodium chloride to the macula densa. If you will see this figure of nephron in a normal patient, a normal individual, or in patients with diabetic kidney disease. So in this figure, we will see that if we compare actually in this nephron structure and
Dr.
the
Ritu,
structure.
Dr. Ritu, sorry to interrupt. Another 2 minutes to wrap, please, because I think your time is. Can you wrap in 2 minutes?
Yes, yes, yes.
Yeah, please. You take your time on this.
Yes.
Dr. Bhala, Dr. Narayan is not going to join.
Then okay, Dr. Ritu, you can speak. Then you can speak. Speak at leisure. Then. Okay.
Yes. Yes.
You have the luxury of explaining it in great detail now. Okay.
No, sir. That's okay, sir.
Yeah, please do.
So I just want to express the mechanism by which they have been given so much importance in management of diabetic kidney disease, these two agents. So it has been shown in the studies that SGLT2 inhibitors, they actually reduce the renal tubular glucose absorption. They are weight neutral. They control the systemic blood pressure and the intraglomerular blood pressure, and also the albuminuria and GFR loss. And these mechanisms are actually the independent mechanisms of glycemic control. So these agents are being used not only in patients of diabetes, but they are also being used in patients who have CKD, not because of diabetes, and they are also being used in patients of heart failure. Recent data also supports that these inhibitors, they reduce the oxidative stress in patients of kidney disease by 50%, and it increases in angiotensinogen, as well as they reduce the inflammatory activity, that is the NLRP3 inflammasome activity. So with this mechanism, actually they cause reduction in the CV risk. And GLP-1 receptor antagonists have also shown the direct effects on the kidney, and these effects are actually independent of the effect they have on glycemic controls. So these are the various trials. They show that the SGLT2 inhibitors, they reduce the rates of end-stage kidney disease by 37%, and the composite kidney outcome of worsening kidney function by 39%. And they have also shown a reduction in major cardiovascular events and heart failure by the tune of 30%. Although they are not without side effects. So as we know, the important side effects in the with the use of these SGLT2 inhibitors and GLP-1 receptor agonists, the SGLT2 inhibitors, they cause lots of fungal infections because of the excess amount of glycosuria. And it is equally important for males and females. and they have diuretic effect, which can lead to reduction in the intravascular volume, and they can cause acute kidney injury. And a very important side effect in form of euglycemic decay, which may occur in patients who are suffering from acute illnesses, when the glycosuria actually masks the stress-induced requirement for insulin. So that all those side effects are to be remembered, and these agents cannot be used in patients of type 1 diabetes and other types of secondary diabetes which are associated with insulin deficiency. And the major side effects with GLP-1 receptor agonists are the pancreatic disease, and there are reports in rodents that they cause increased incidence of medullary carcinoma of thyroid and MEN and the pancreatic disease. So to conclude that the patients of diabetic kidney disease, if we are treating, they should have individual glycemic targets, and it will depend upon their age, the duration of diabetes, the stage of diabetic kidney disease, and the presence of comorbid status. So according to that, you have to set the glycemic goals in that individual patients. And as far as the recommendations are concerned, the metformin is the preferred agent, and the other agents which are the key players are the SGLT2 inhibitors and the glucagon-like peptides receptor antagonists. So they are to be used upfront. And insulin dynamics change in patients who have advanced renal failure, because hypoglycemia is very common in those patients, and they also have high risk of CVD. So the agent, whichever is being used to control the glycemia, has to address those issues. Thank you.
Talk. I believe Dr. Narayan has joined us.
Yes, sir.
Okay, Dr. Narayan. Dr. Narayan, are you on?
No, Dr. Narayan is not going to deliver the lecture because he's down with COVID.
Okay. So I think I can request my co-panelists if they are there. So we are lucky we have some time for a discussion. So Dr. Anand, if he's there, Dr. Harsh and Dr. Sabaratnam. Yeah, so Dr. Anand Banka, is he there? He's from Gorakhpur. Dr. Harshvardhan.
Sir, I'm here, sir.
I was expecting our health minister to be there, Harsh. He's from Apollo Hospital, Patna, and Dr. Sabaratnam. He's Department of Endocrine Surgery, SGPGI.
Sir, I'm here, sir. Actually.
Yeah. So I think any questions? I think I can set the ball rolling. Dr. Ritu, what would be your, for our diabetic CKD patients, taking all the guidelines into consideration, what would you suggest we target HbA1cs? 7, less than 7, more than 7, what would be the targets? One is for the optimum control of the sugar. Secondly, for the progression of renal disease. What would be your suggestion?
Looking to the recommendations and the yes, thank you. As far as the glycemic control is concerned in patients of CKD, because if the patient has early CKD, then we can look upon the glycemic control, and we can set the target as 7%. But I think most of the patients actually at the outset, they have the presence of CKD. So the ideal target should be between 7 to 8%, I think so. And particularly in our clinical practice, I don't think they have good monitoring and other facilities. So, and we should not forget the risk of hypoglycemia. So I think the target should be around, we can take it midway, that is around 7.5%.
Okay, fine. So Dr. Harsh, Dr. Anand, Dr. Sabha, would you agree, would you disagree? What would you suggest?
Sir, actually I'm Dr. Sabaratnam. I am an associate professor in endocrine surgery.
Yeah.
And
the thing is, Sabha, can you put your video on?
Yeah. Actually, the thing is, I am the only surgeon here in this August group of physicians, and your precious patient, renal transplant patients with this diabetes and CKD, Many of them have diabetic foot infections where we deal with them. And what 5 points I will like to stress for all these people, like all people participating here, there is impaired wound healing, altered immune response, accelerated catabolism, delayed recovery, and increased morbidity and mortality with patients who have CKD with diabetes. And the protocols of wound healing and management are changing now. We are following what is known as ERAS protocol for every surgery, enhanced recovery after surgery. So we do not keep the patient fasting. Like previous days, we keep the patient fasting. Now, minimal fasting and all procedures done using local blocks, not even general anesthesia, because the recovery is very...
Dr. Sava, sorry to interrupt. I think we are going away from the topic. So we were more interested in what are going to be the HbA1c levels. I'll come back to you, Dr. Anand and Dr.
Hemoglobin A1c levels have to be like the better the sugar control, the better the wound healing.
Yeah, okay,
so,
fine, fair enough. Thank you, Dr.
In
Anand.
Indian Journal of Surgery, there is an article which has been published in 2021, which said that sugars under 200 are acceptable. Previously, we wanted anesthetists were very particular that very less sugars are needed for surgical intervention. Now we do not have very strict control. Any control around 200 to 250, we do take the patient for surgery, and we think that that is the best possible answer.
Okay. Thank you, Dr. Anand. Dr. Harsh, how would you go about this? What would you think would be
I would recommend that we should go by the guidelines, which suggest that something around 7% would be the target which we should achieve in chronic kidney disease. We need to be very cautious, and definitely I fully agree with the speaker's recommendation regarding individualization of the approach. And
Dr. Anand, Dr. Anand.
As well as sir, around 7 to 7.5 is okay, basically.
Okay. So now coming to metformin, you mentioned, so we are pushing the boundaries to 30 ml and you said some 45 ml. So the recent guidelines, the KDIGO guidelines of diabetes published in 2019 have mentioned that we can take metformin up to 30 ml.
30, yes.
Yeah. So Ritu, are you in agreement with this?
Yes.
Yes, definitely.
Yes, sir. Yes, sir. Definitely.
Sir, in ADA, they say that it should be between 30 to 45, it should be in modified doses.
Okay, fine.
We can give it up to 30, but it should be modified. So the dose should be reduced.
Maximum to 1 gram.
Yeah.
So the third point is about it. Yeah.
Otherwise, we can give it up to 2.4.
Yeah. Yeah.
So what about the third guideline is for the SGLT2s? Now we have so many studies that are coming up, the DAPA CKD, the EMPA CKD. So they have pushed the GFRs up to 25 ml.
Yeah.
So do you think that, even our patients whose GFRs are falling to less than 30 ml or going to stage 4, should we give them the benefit of SGLT2s rather than withdrawing it because just looking at strict guidelines? Because the cardiovascular and the renal outcomes both are extremely good with this group of drugs.
Yes, sir. I think so, sir. You are correct that if they are already on these agents, so it should not be discontinued.
Okay.
And one thing more, we as a nephrologist, we are always limited by the hyperkalemia which the patient is having. So we have practically nothing much to offer them most of the time, because once they land up with hyperkalemia, we cannot use ACE or ARB. So I think that more SGLT2 can be used. At least some protection can be given to them.
Actually, they are also beneficial for this cardiovascular part. So I think that is another benefit of using those drugs.
Dr. Anand and Dr. Sava, what do you suggest? What about Dr. Anand? What would you suggest?
Sir, SGLT2 with SGLT2 inhibitor, basically we need also in peripheral patient, basically we keep following with the serum creatinine also. Basically, patient should be compliant to the treatment and to the follow-up, basically. Okay. They didn't turn up in the follow-up. And monitoring of sodium is also very important. Some of the patients land up in hyponatremia. Weight loss is very common. So side effects should also be considered.
Yes, sir. Very true, sir.
So that means, according now what we're doing is we're pushing the GFRs for metformin, pushing the GFRs for SGLT2s. What about the diet? Now, the latest diet says that for diabetics, we go up to 0.8 gram per kg body weight of proteins. So would you suggest that, or you will still stick to 0.6 and put them on to ketonologues? What would you suggest for the diet? Dr. Harsh, Anand, and Dr. Ritu, any views on the diet and diabetics? Dr. Anita, you can join in also, please. Because the new the guidelines on nutrition have said that we have to go away from the old guidelines of 0.6, go on to 0.8 grams. So are you in agreement with that, Dr. Anand? Dr. Harsh?
Sir, this is something which is again a very point of discussion, because 0.6, 0.8, the plant-based protein diets, a lot of literature is coming in. But I still believe that we should stick to something around 0.8. 0.6, that is very low protein diet, then definitely you have to be in consultation with a nutritionist, aggressive nutritionist, to see the concept of malnutrition.
Some people have suggested
So
0.7.
for diabetics, you start with 0.8 grams, and then as the GFR declines, you bring down protein intake to 0.757 and then 6. You can bring it down gradually. Diabetic patients.
Okay, fine. So Dr. Sabha, coming to your points now. So what would you suggest to a patient who's a diabetic who's having some wound problem? Now we can take your suggestions. What would you suggest would be the best outcome way to go about in these patients?
Sir, actually, that's a very good question. Actually, prevention is the key here. Initially, once you have detected to have diabetes with CKD, we always counsel the patients to take care of their feet, like how they take care of the eyes. Morning, how we wash our face, they have to wash the foot first, because that is most important thing, prevention. And then good glycemic control, and that is second most important thing. And third, appropriate treatment for renal CRF, and good care of themselves. These are 4 important things. And most importantly, they should give adequate attention when they cut the nails, and then, because that is where the small injury can precipitate a major infection, and they should not do any kind of intervention on their own. Even a small wound, they should consult their physician, nephrologist. And what is taught to, like now the new undergraduate books, what they teach is, don't only examine the foot, examine the footwear also. That is very, very important. As a doctor or a person who is seeing a CRF patient with diabetes, we should not just only see their feet, see their footwear also. That is most important. And adequate attention should be given to their footwear and foot care.
Okay,
this is most important.
Thank
and as I said, like, we have a wonderful nephrology department with madam is there, nutrition, so we are blessed. But many people might not have these kind of facilities. For them, it is very necessary to know what exactly, how much protein, how much calories, and especially when you have done surgery, and especially necrotizing infections of the feet, where it will be a major debridement, nutrition plays a very, very important role. And we have 80% recovery rate in our institute. So that, even with that is with great difficulty, but I always feel that this is the most important thing. Treat a patient as the whole.
Dr. Sabha, have you ever asked madam what footwear she wears? She wears nothing short of Jimmy Choo, I'm sure about that. Yeah.
I request the moderator to take up the question from the chat box as well.
Yeah, sure. So we have any questions? Dr. Anand, Dr. Harsh, any other questions? Okay, 1 minute.
I can't see any question in the chat box.
There are no questions here.
So we can wind up now?
Sure.
I have a, I'm Dr. M.K. Mitra, and may I chip in? Can you all hear me?
Yeah, sure, sir. Dr. Mitra, please go on, sir. Nice to see you, sir. How are you, sir? How are you doing?
I'm fine. I'm fine.
Yeah, please, sir, please, your question.
I had a wonderful talk with Dr. Ritu Karoli. Enjoyed the talk.
Yeah.
Congratulations, Ritu. I see you here.
Thank you, sir.
My question is, you see, it's all right that we have SGLT2 with a high profile of kidney protection in cases of CKD, fine. But our diabetics, you know, and the CKD who go, they are also hypertensive, dyslipidemic, they have ischemic heart, stroke and all that. So they have a very impressive list of drugs to be taken. And SGLT2 inhibitors are a little costly. if a patient can afford, of course, my vote always will be SGLT2 inhibitors. Having said that, if the patient who is sitting in front of you is coming from that state of society where he or she is not able to take SGLT2 inhibitors, which is an ideal drug, which I agree, according to the guidelines and the published reports, then in our Indian scenario, we have to think for some other drugs also. And I think we still feel that the sulfonylureas, the third and fourth generation sulfonylurea like gliclazide, your sustained release, the dimicrononic SAR group or the gliclazide group, are quite safe in CKD with renal patients. So we have to remember that. And secondly, short-acting hypoglycemic drugs like repaglinide, like voglibose, these are some of the drugs which we can use in those patients of CKD who are having several comorbidities and those who come from that strata of society where it will be difficult for them to have SGLT2 inhibitors for a long period of time. That's why I thought that in the Indian scenario, we should also be aware of that. And we should be aware that these are also drugs in the armamentarium, which we can use judiciously if we are not able to prescribe because of financial constraints, SGLT2 inhibitors. So I just wanted to share that with you. I don't know, I would like the expert opinion, but that's how I've been dealing with these patients.
Yeah, I think Dr. Mitra, the very pertinent and excellent points. I think we're all, the advantage of third and fourth generation sulfonylureas is that they can be given right up to GFRs of patient on dialysis. Also, you can give them. That is one advantage. But the only thing is that SGLT2s now you have so many generic available. We are lucky.
They have become cheaper now. They have become a little cheaper.
The parent, Astra's fighting. They put in a court case that their drug is priced at 80 rupees, whereas the generics are 5 rupees, 10 rupees. So so 300 rupees per month, and you're getting so much of benefit. But your point is very well taken.
Some of these, I know that
the generics are very cheap now. I know. I don't know whether
reduce. I agree with you. I agree.
The only thing is
I was just telling you that there are other options.
Yeah, sure. Very well points were taken. Very good points. Any other comments?
I just want to make a comment that SGLT2 are very weak anti-diabetic agents. So therefore, the point that Professor Mitra was making is very well taken, actually. That we can use other agents besides SGLT2, even in more advanced patients with renal disease.
Yeah, I think that's a very good point. So very good. And I think it's a real world experience. We are very happy to have you here, sir. The real world experience is extremely important for us.
Oh, thank you so much. Thank you so much. But I have really learned quite a lot with all you galaxy of people sitting here. Enjoyed, Ritu.
Thank you, sir.
Pleasure to see you. We have been interacting with under several fora anyway. But that's fine. I thought, very, very nice. Very nice.
So, shall we close the session now?
Yeah. Okay. I think I should thank Dr. Ritu for an excellent talk. And, I must congratulate you. You took us through 40 minutes very smoothly, and everybody is very much interested. And I must also thank my core moderators, Dr. Saba, Dr. Harsh, and Dr. Anand, and Dr. Anita for putting up such an excellent meeting. It was very difficult. Everybody is so much harassed in the, what we are facing in Delhi and around. It's really, but I think it was really worthwhile the time spent over here. Thanks a lot.
This morning, I'll tell you, Dr. Bala, what happened this morning. 7:30, I got a phone call that one of our workers has to be admitted in the hospital, and I was running around. When I started the introduction for the second day, I ended up saying it's the 11th session because I was with phones trying to manage getting him into the hospital, arranging a bed, and now the patient has got admitted. So everything was like in a mess because of COVID. So anyways, thank you so much for joining us all. And now we break for lunch, and we shall resume our session at 2 o'clock. Please join us back at 2. Thank you so much.
Leave meeting mode.
Dr. Akshay. Dr. Akshay, can you just share your number in the chat box?
My phone number?
Yes, yes.
All right. Did you get it?
Yes, sir, got it.
All right.
writing's not that easy.
Mr. Sudesh, shall we start now?
Arnav?
Has anybody joined in now? Hi, Akshay.
Good afternoon, ma'am.
Yeah, hi. So where are your moderators? Dr. Ansari and Dr. Sanjay?
Yes, ma'am.
Have
They
they
would be
joined?
joining soon.
Okay, great.
Yeah, ma'am.
So I thought you were going to come to my office, so I made it a point to come to my office today.
Oh, right. I am sorry, ma'am. I got stuck in rounds and then I had to come to get my PPT over here.
All right, so because
Ma'am, Dr. Ansari was joined already.
has joined?
Yes, yes.
Yeah. All right. Oh, good afternoon, sir.
Hello.
Hello. Hello. Hello. Hello, ma'am.
Saxena ma'am, hello.
Yeah, hi. So we will start.
Can you hear me, madam?
Yeah, I can.
From
Hi,
Calcutta.
Dr. Surul. Yes, Dr. Surul.
Hi.
So welcome back. We're going to start with this session 9 on management of specific conditions, kidney stone disease and polycystic kidney disease. For this, I invite Professor M.S. Ansari. He is professor and a pediatric urologist. He is in our institute in the Department of Urology and Renal Transplantation. And over to you, sir, for the proceedings.
So, Akshay, we can start it now.
Yeah.
Dr. Akshay is working with us as a fellow in the transplantation. And he will be speaking on kidney stone disease and dietary management. Dr. Akshay, over to you.
Thank you, sir. A very good afternoon to everybody. I'll be sharing my slides now. I hope I'm visible and audible and my slides are seen, ma'am.
Yes, sir.
All right, very good afternoon, everybody. I am Dr. Akshay Kriplani from the Department of Urology and Renal Transplant at SGPGI Lucknow. And at the outset, I would like to thank the Society of Renal Nutrition and Metabolism, especially you, Dr. Anita Saxena, ma'am, for making me part of this program. And today, I would like to elaborate on how diet plays a very important part in the complete management of kidney stones and also prevent its recurrence. So kidney stones or renal calculi are tiny little structures, but the harm they can cause can be enormous. Join me as I take you to the inside world of kidney stones. Well, these can be classified into 5 broad categories, depending on the type of the crystal.
Are the slides moving or?
I think Dr. Kriplani internet connection is lost.
Dr. Kriplani, where? Oh, Jesus. That's all.
Just give me 1 minute and call me.
Oh, I am extremely sorry, everybody. I think there was some issue.
No problem. Go ahead. Go ahead.
Please share again your slide.
Yeah, I'll do that. Just a second. Am I seen, ma'am?
Yes, you are seeing. Akshay, go ahead.
Sir, should I start all over because I don't know my ruk
No, you were just taking us to this 3D of a stone.
Okay, so
go to the next. Go to the next.
Right, sir. So I was talking about the dietary management in the kidney stone disease, and I was explaining
5 types of the stone. Yes.
Yes, sir. So I was just explaining how kidney stones can be a big problem, and I was asking everybody to join me as I take everyone inside the world of kidney stones. So as I mentioned, these can be classified into 5 broad categories, depending on the type of their crystal aggregate. The calcium oxalate being the most common, the calcium phosphate, struvite, uric acid, and cystine stones. After calcium oxalate, the mixed or struvite or infection stones are the second most commonly encountered, followed by calcium phosphate and uric acid. To prevent their formation, let us first understand what leads to their formation. It is a multi-step process. The first step being nucleation. Ions like calcium and oxalate that have been filtered in the urine spontaneously join together to form a solid crystal nidus. This is called nucleation. Crystals of similar composition start depositing around this nidus, called as homogeneous nucleation. And when crystals of different composition start depositing around this nidus, this is called as heterogeneous nucleation. These tiny crystals then travel down the nephron and get lodged in the renal papillae, where they undergo the next major phase, that is growth. These crystals then stick together to form large aggregates, growing to a complete stone. This is retained in the kidney, where it grows even further, only to get eventually expelled in the pelvis and the ureter. Some crystals develop into stones, while others do not. This is because there are specific stone-forming salts called as promoters, which in supersaturated urine easily aggregate together to form crystals of the stone. Presence of inhibitors do not allow this nucleation and aggregation. Most common being the citrate. Therefore, in a normal person, the urine is undersaturated and inhibitors act, therefore preventing crystallization. Whereas in stone formers, the urine is more supersaturated and lack the inhibitors, causing crystallization and stone formation. So it is this imbalance between the promoters and the inhibitors that leads to the stone formation, and the dietary management should be directed towards decreasing the promoters and increasing these inhibitors. Also, it is a very personalized approach depending on the risk of recurrence, the stone formation and composition, the underlying biochemical abnormality that is tested by the serum and the 24-hour urine analysis, and the genetic evaluation in selected children. Among the most common dietary factors influencing the pathogenesis of stone formation in India, fluid intake is one of the most important factors because it causes mechanical diuresis, decreases solute supersaturation, and regulates the urinary pH. In fact, for each 200 milliliters of fluid consumed in a day, there is a 13% reduction in the risk of stone formation. So the next question your patient will ask you is how much fluid is adequate. The European Association of Urology, or the EAU, suggests an intake enough to have an output of more than 2.5 liters per day. Also, there have been enough research stating that an intake of more than 2.5 liters per day can reduce the risk by 30 to 60%. Meta-analysis do suggest that with every 500 ml increment in intake, the risk of stone decreases exponentially, and there is enough literature evidence confirming the fact. Well, Indians consume a variety of fluids in their normal routine life. Not all of them are equally protective. Carbonated soft drinks, be it cola or non-cola, these contain fructose, which increases the calcium, oxalate, uric acid, and orthophosphoric acid in the urine, making it lithogenic. Caffeine in tea or coffee causes diuresis and increases the sodium, potassium, magnesium, along with its potent antioxidant properties. This has shown to be antilithogenic. This effect overpowers the increased calciuria, negating its previous belief to be lithogenic. Provided this is consumed more than 250 milliliters per day, as the protective effect is not demonstrated in the intake, which is below 250 ml in a day. There is enough evidence to suggest the reduced risk which these caffeinated drinks offer. A popular query in today's time is about green tea. Well, this has actually shown to be protective, but it is subject to a lot of external factors. Almost all juices are rich in citrate, which, as mentioned, is an important inhibitor of stone formation. Orange juice is the most potent natural alkalizer known for reducing the stone formation, whereas lemon and lime juices having the highest concentration of citric acid do not alkalinize the urine as much, but are also known to reduce stone formation and recurrence. Grapefruit and apple juices are still under research as there is some evidence of their lithogenic potential. Satisfying the popular wish, alcohol does reduce the risk of stone formation, although the mechanism and dose is still not defined. But its diuretic action is presumed to be beneficial. 1 to 2 cups of milk have no increased lithogenic potential. And this effect of the different juices, soft drinks, milk, tea or coffee, and alcohol has been well reviewed and analyzed in meta-analysis. Calcium is the most popular paradox discussed for renal calculi. Calcium in the intestine acts as a chelator for oxalate to prevent its absorption. A low calcium diet increases the intestinal absorption of free oxalate, eventually increasing oxaluria and urinary supersaturation of calcium oxalate stones. It has been well documented in literature that a low calcium intake has a higher risk of stone formation. Therefore, the EAU recommends a normal calcium intake of 1 to 1.2 grams per day in patients with renal calculi. Urinary oxalate causes calcium oxalate supersaturation, but diet actually contributes to only 10 to 50% of the daily urinary oxalate excretion. Still, it is recommended to limit the intake of oxalate-rich food in a diet. Calcium supplements and probiotics containing Oxalobacter formigens have been tried to decrease the incidence of calcium oxalate stones in patients who have a high oxalate diet. Food rich in uric acid should be restricted to 500 milligrams per day as it lowers the urinary pH and promotes uric acid crystallization. A diet rich in sodium causes increased calcium and cysteine excretion and promotes sodium urate crystal formation. This prolithogenic action overrides its diuretic and alkalinizing property. A daily intake of 0.5 grams of salt is adequate for maintaining homeostasis, whereas a single teaspoon of table salt contains much more than that. A 6-gram increase in salt increases the calcium excretion by 40 milligrams per day. Studies on the DASH diets, that is the dietary approach to reduce or stop hypertension. This is a diet low in sodium and has seen to have a significant reduction in stone formation. Therefore, it is recommended to restrict the daily sodium intake to 4 to 5 grams per day. Potassium is a potent inhibitor for stone formation by decreasing the calcium in the urine and increasing the urinary citrate. Proteins, especially animal proteins, due to their amino acid and purine metabolism, increases the calcium, uric acid, oxalate in urine, and decreases the urinary citrate, potassium, and magnesium. This is not true for the dairy or the vegetable protein. So when in a study, protein was limited to 0.8 grams per kg per day, the urinary calcium, oxalate, and uric acid were found to significantly reduce, and the urinary citrate increased. Therefore, it is recommended to limit the animal protein intake to 0.8 to 1 grams per kg per day. Fruits and vegetables are a rich source of magnesium, which is a potent inhibitor of crystallization. When fruits and vegetables were restricted in a normal subject, urinary inhibitors decreased and promoters increased, leading to supersaturation. Vice versa happened when in a hypocitrate patient was given a diet rich in fruits, leading to reduced supersaturation. Although fatty diet increases calcium, oxalate, uric acid, sodium, and sulfate in the urine, it has not been proven as an independent risk factor for stone formation. In fact, the latest fad of the Atkins diet, popularly known as the keto diet, which is a no-carb, high-fat, and high-protein diet, is highly lithogenic. Similarly, the lipase inhibitors, popularly used for weight reduction, also leads to hyperoxaluria. Vitamin C intake should be limited to 2 grams per day as it increases the oxalate excretion. Omega-3 fatty acids inhibits the prostaglandin synthesis and therefore decreases the calcium excretion. So to conclude, the dietary management of stone disease should be targeted to the underlying biochemical abnormality, the prevalence of which might differ as per your geographical location or the demographics. Maintaining a balanced diet with an adequate fluid intake is fundamental. Restrict animal protein, salt, canned food, soft drinks, chocolates, and other oxalate-rich food. Do not encourage excess vitamin supplements. As clinicians, we cannot advise alcohol, but orange and lemon juices could be encouraged. Do not restrict calcium, and fruits and vegetables should be promoted as they are a rich source of potassium, citrate, magnesium, and fiber. Thank you so much.
Thank you, Dr. Akshay. And this was very enlightening. And I'm sure that all the participants must have been taken to the another world, the way it was presented with beautiful animations. And it was very comprehensive in managing the dietary factors, how we can reduce this stone formation. Because we all know that stone disease is not a genetic disease, but somehow like diabetes and the hypertension, this is also a lifestyle disease. That is why it has been seen, whether it is the adult population or pediatric population, it is the change in the lifestyle. We are becoming more sedentary, right from using to remote to the androids. Life has become very slow. And secondly, the food habits are also costing our dear in the form of that we are mostly dependent on stored foods, canned foods, which are quite high in salt content. And yes, and the salt in the recent times has been studied extensively. Those who are having higher salt contents, they have more chances to have manifold hypercalciuria. And the oxalate in Indian diet is already available, especially in the northern part of the India, where we are mostly dependent on the monotonous diets. We are repeating vegetables so frequently that oxalate is all the time available in our intestine. And secondly, it was nice to see that newer elements like potassium, magnesium, and the citrates, if we are regularly having incorporated into our diets, they can take us away, far away from the stone formation. And finally, a comment that we should not forget the regular food intake. So for an adult, it is 2.5 liter urine output. So to maintain that, you have to understand how much fluid you have to take. A rough guide which can be applicable to all pediatric and the adult population is that if you are staying indoor, then 30 ml per kg body weight will be sufficient. But if you are an outdoor, like, because there may be difference between me and a rickshaw puller, there may be difference, a taxi driver who is all the time in the sunshine, and I'm most of the time in the air conditioned floor. So you have to maintain, if you are having a field work, then you have to maintain the fluid intake more than 40 ml per kg body weight. If you are staying, children are staying indoor, then 30 ml per kg body weight is sufficient if you are a regular stone formation.
Right, sir.
So we have Dr. Sanjay also, if you want to add anything to this for the information of the participants.
Good afternoon, sir. Basically, often we see patients with a bilateral small renal stones. We don't have the stone analysis because they have 3-4 millimeter stones or unilateral 3-4 millimeter stones. And when we do the basic metabolic evaluation, we found there is no abnormality. In this kind of patient, I have found that often they see the internet nowadays everything is available on the Googles, but it's on the discretion of the reader. So ultimately they come in a situation and often they said we are taking only potato and rice, nothing else, because everything else has predisposing for stone formation as per their internet knowledge. So these are the patients when we should give a very balanced advice. We don't know what is the stone composition because we don't have stone analysis. The basic metabolic evaluation is normal. So, Dr. Akshay, if they ask what kind of dietary modification they want, so what advice you will give? Because 50% of stone patients in our OPDs are this kind of patient. Ultrasound showing 5 millimeter, 4 millimeter stone in the lower pole, nothing else. So, what kind of dietary advice you will give this patient? If you want to give a focused dietary
Right, sir.
advice, you cannot give them a details advice. So, what are the focus advice you would like to give? You be 2, 3, 4.
Yes, sir. So there are some general measures and then there are some specific measures. So the general measures is a high fluid intake, which is a must. General reduce in the animal protein, decrease in the salt intake, reduce oxalate diet. So these are, and decrease in the uric acid, that is animal protein diet again. So these are general measures. There are specific measures which we follow only after the metabolic evaluation of that particular patient. Now that happens either with the stone analysis or with the metabolic evaluation, which includes the serum and the 24-hour urine analysis. This gives us whether the patient is having.
As I said, stone is not there. As I said, stone is not there, and metabolic evaluation is normal. So you have no clue to give him specific advice. So if you want to give 3, 4 advice, then what you would like to give? One is fluid.
Right, sir.
Can you hear me?
Yes, sir. So in a first time stone former, not a high risk patient.
So other 2 advice which I commonly give in my OPDs to the patients is, second is reduce salt intake, and third is adequate calcium intake. It should not be. Right, what do you mean by adequate calcium intake?
So normal calcium, which
there is some problem in the connection, I think.
Yes, sir. So in a general Indian diet, milk provides an adequate calcium. So milk, eggs are good calcium, and calcium in the vegetables are again good. So I would encourage calcium and not to immediately start with calcium supplements.
Right. So calcium rich diet, right?
Request to the moderator, please go to the next one. We are short of time.
Okay, thank you, Dr. Akshay.
Thank you,
wonderful.
Thank you, sir.
And thank you, Dr. Anita, really giving us opportunity through this. It is your society is growing.
You're still the moderator, so you can't sign off. You're not signing off right now. We have another talk on ADPKD. Yes.
I think my time is also over, so I was happy.
No.
Okay.
See, having polycystic kidney disease along with stone, it is such a difficult thing to manage. So I just wanted both of you to be around for the next talk also.
Okay, Dr. Sanjay is an expert of ADPKD.
All right, great.
Can you hear me? Hello?
Yes, sir. Yes, sir. We can hear you.
So, right now I am sitting in my hospital, so I cannot take off the mask. I hope I am audible. So, at the beginning, at the onset, I must thank Madam Dr. Anita Saxena for arranging such a beautiful conference among this pandemic. And I also thank all other organizers. And I'll start the presentation. The presentation is ADPKD.
Hello.
Just. Can you see the slide? Can you see the slide?
Yes, sir. Yes, sir.
Yes, we can.
Thank you. So the topic is ADPKD. Does nutritional intervention help? So as we know that polycystic kidney disease is probably the most common genetic nephropathy and is an important contributor to end-stage renal disease among those who are less than 70 years. So it is a multi-system disease. 50% of them, they develop renal failure, and 50% they develop hypertension at young age, and most patients have hypertension by the time they develop end-stage renal disease. Now, if you look at the structures of the kidney, there is a filtration is remains stable for many years, but as the cysts progress, there is a more rapid decline after 50% of function is lost, and they grow continuously. Why? Because there is new cyst formation, and already the existing cysts, they get enlarged. So basically, if you look at this particular diagram, initially whatever was the amount of healthy tissue, that is gradually coming down. There is a progressive increase in the cysts, and there is a reduction in GFR. And with that, there are a lot of symptoms that appear. There are certain symptoms you can look, which are acute symptoms, as we know. There may be cyst rupture, there may be pain, there may be recurrent UTI or cyst infection. Sometimes the kidney stones, what Madam was already telling. And in the chronic problem, initially there is a concentration defect, then there will be hypertension, there may be some degree of proteinuria, and ultimately there may be progressive loss of renal function along with changes in the vasculature. Now, if you look at the genetics of ADPKD, as we all know, they are caused by the mutation in polycystin 1 and polycystin 2 genes. Now, what are these polycystins? Polycystins are certain proteins which will maintain the normal phenotype of the tubular epithelium. So, thereby through the mechanism of the primary cilia. Now, when there is a deficiency because of this genetic abnormality, either of these polycystins, what happens? This phenotype is changed. So, usually it is a resorptive phenotype in the epithelium. So, there is a resorption occur. But when there is a change in this polycystin, the deficiency, the phenotype changes to a more of a secretory type. So, thereby there is a lot of secretion inside, and thereby the cyst they gets enlarged, and simultaneously there is increase in the cellular proliferation, and there would be some degree of apoptosis here. In fact, it has been found that 85% of all ADPKD are because of the mutations in PKD1, which is located in chromosome 16. And these patients are usually young, and the average age onset is roughly 54 years in patients with PKD1 mutation. Whereas the PKD2, it is the location is the chromosome 4. The disease progresses more slowly, and the average age of end-stage renal disease is a little higher, that is 74 years compared to 54 years. Now, if you look at the pathogenesis, I am not going into the details of the pathogenesis, but if we understand the pathogenesis, we will understand why we can intervene, whether nutritionally or therapeutically. So if you look at the picture, there is a deficiency of either of the polycystins, either polycystin 1 or 2. So as I have already mentioned, there would be a change in the phenotype. And if you look more closely intracellularly, there will be decrease in calcium, and decrease in intracellular calcium will lead to increase in CAMP. This increase in CAMP that leads to ultimately all the changes. Then there is another pathway which is mTOR pathway. We know that from our transplant scenario, the mTOR inhibitors like rapamycin, which has been also used because of this mTOR. They also cause increase in mTOR that cause cystogenesis. There are other mechanisms like AMPK, ERK. I am not going into details of that. But you look at there is aerobic glycolysis. So glycolysis is also important to maintain this cystogenesis. And you can see the AVP, the arginine vasopressin, that if it is increased in the body for whatever be the reason, there will be further increase in the CAMP. And so increase in AVP will lead to further cystogenesis. So we have to do something which will reduce the AVP level in the body. Now, loss of kidney function is usually irreversible, what I have already mentioned. There is an enlarging cyst, compression of the surrounding parenchyma, and progressive loss of kidney function. Now, looking closely at this pathogenesis in our mind, so what can we do? Does really nutritional intervention help in these patients? Now, there are certain data available which have shown that in chronic kidney disease from ADPKD, there may be certain factors, certain dietary modification, which will definitely retard the progression and ameliorate the disease process. So the key question is that if there is we know that in chronic kidney disease, there are definitely so many nutritional parameters which we can modify. So other than the usual management of chronic kidney disease, is there any other dietary modification which we can do, which will go beyond the usual management of CKD and will help these ADPKD patients? So just to make it brief, then I will come into details. That you have to limit how the sodium. We have to hydrate and give the right amount of fluid. Eating high quality protein in a smaller portions. And as kidney becomes more damaged, probably we have to give a food which should be lower in phosphorus and potassium. So overhydration is a common strategy. This is being prescribed like in the ADPKD in the early stage. If we give more water, what happens? If you give more water, there will be reduction in plasma osmolality. So because of the reduction in the plasma osmolality, ultimately the AVP secretion is less. So in a way, overhydration is doing just what probably tolvaptan does in some way. Tolvaptan, what it does AVP suppression because it is an vasopressin receptor antagonist. So it reduces, so by giving more water, we are reducing osmolality, and so thereby the AVP level is decreasing. Now, what would be the question is what should be the optimal water intake? Is there any calculation? So it is estimated as 10 milliosmol per kg of the body weight, but it varies greatly with diet. So you just cannot tell how much solute you are. So usually the average is 10 millimosmol per kg. So thereby, because of these controversies, there are certain guidelines like Australian guidelines. They tell that probably you should just satisfy the thirst. May not be some role of overhydration, but there are certain other guidelines who categorically mention that if you overhydrate the patient and reduce the osmolality of the urine less than 280 milliosmol per kg, there is a suppression of the AVP, and so thereby there may be slowing of the progression of the ADPKD cystogenesis. Now one can calculate if you measure the 24 hours urine solute load. So suppose somebody is making a 600, so you divide it by 280, and then you add the insensible loss. So this will lead to the water. What is the amount of water you should prescribe in this patient? Now the problem is that sometimes it is very difficult. I mean, ideally you should measure 24 hours urine solute load, but whether it is practical in our OPD patients, so that is probably not practical. So that is why people are telling you can check the overhydration or underhydration just by check the urine osmolality. And there is one factor which we are not commonly doing, but certain places they do, that is called plasma coaptin. Coaptin is one factor which is co-secreted with AVP and easier to measure if it is available. So from plasma coaptin level and urine osmolality, you can get what should be the amount of solute load. So higher intake of sodium is associated with higher osmolality and thereby an increased release of vasopressin, which impacts the growth of cysts. And higher baseline sodium intake is also associated with greater decline in GFR and greater increase in total kidney volume. We know that in ADPKD, by MRI, you can measure the total kidney volume, and total kidney volume is an important biomarker of progression of renal disease. So sodium intake should be optimal, should be rather little lower, so that you can reduce the progression of cyst formation. So what should be the amount of sodium in a ADPKD patient? It has been found in various guidelines, the Spanish guidelines, the Canadian guidelines, that usually normally in a hypertensive patient, what the amount of salt what we prescribe, that is usually less than 6 grams salt per day or less than 2.3 gram sodium per day. That is sufficient also to reduce the osmolality component in a ADPKD patient. So the guidelines specifically mention that patients treated with tolvaptan. So all patients you should give a low sodium diet, which should be less than 2.3 in ADPKD patient. But hypertensive ADPKD and those who are on tolvaptan, like many patients of our ADPKD are on tolvaptan, there you should give a sodium restricted diet. Otherwise, there may be tolvaptan resistance. Now, protein intake, there is no definite guideline in the early ADPKD, but some prefer that probably a very low protein diet will not help, which will rather cause malnutrition. So a normal is around 0.75 to 1 gram per kg per day. Protein is sufficient for ADPKD patients. But once the GFR progressively goes down. So if the GFR is less than 30, it is like any other CKD patient, so 0.8 gram per kg per day. Now what else? So sodium restriction, adequate overhydration, and some amount of protein restriction depending on your GFR, that is advisable. What about caffeine? It has been found that caffeine, it inhibits the phosphodiesterase and thereby it increases CMP level. So as I've already mentioned that whenever there is an increase in AVP, which will lead to increase in intracellular CAMP, and this leads to ultimately cystogenesis and progressive loss of renal parenchyma. So whether you should drink a lot of caffeine or not, I will tell that there is no hard data to tell that you should not drink caffeine, but probably from the ideas, it is better that you avoid a lot of caffeine, whether it is coffee, tea, and even aerated drinks which contains a lot of caffeine. So probably it should be reduced to less than 3 cups per day. This is an average thing. What about phosphorus? It has been found that we know, every one of us know that FGF23 is a marker which increases in CKD stages, even in early stages, and which leads to ultimately phosphate excretion through the urine, and sometimes this FGF23 high level is associated with the progression of the renal disease, other than the mineral metabolic bone disease. So it has been found that ADPKD patients, they have found to have a high FGF23 level, and so probably there may be some degree of phosphorus restriction which should be provided, which should be less than 800 milligram per day. So less phosphorus, little less protein, low sodium, and high water. This is the standard thing what we should do in an ADPKD patient. But there are certain recent preclinical studies, especially in the rat models or mouse models, where they have shown that some other dietary modification which may reduce or improve the eventual outcome of ADPKD. So this is the area of active research, which includes calorie restriction, ketogenic diets, low phosphate oxalate, and all these things. In fact, one particular study, they have shown that there are a lot of metabolic sensors in this cyst, and there should be some insights on metabolic reprogramming of the ADPKD cells, and there will be some impact of calorie restriction and ketogenic diets. So basically what happens, as I have already told, that if you remember the first diagram, there is aerobic glycolysis which is also causing there is some effect of the intracellular CMP level and the mTOR level. So the glucose availability, that is very important. So if you do a calorie restriction, which is a driver of ketogenesis, has shown to reduce the renal cyst growth and fibrosis in preclinical ADPKD. Low calorie or ketogenic diets have delayed preclinical ADPKD progression, but there are no definite human trial to tell that if you use ketogenic diet or if you use a low calorie restriction, it will definitely help you in PKD progression. So prior to the exploration of ketogenic diets, calorie restriction and ketogenesis are shown to reduce renal cyst growth. And one particular study, they have done intermittent starvation rather than total calorie restriction, which had led to some sort of inhibition in the glycolysis process and thereby reduce the cyst growth. So mild to moderate food restriction, 30 to 50% reduction of calories, that has also helped in the experimental situation. The mild reduction in food intake, 23%, that slowed disease progression in an orthologous mouse model of ADPKD through mTOR modulation. And in fact, we know that mTOR modulation we can do with rapamycin, which also showed a beneficial result in experimental animals, but probably because of the mTOR inhibitors, a lot of side effects, they have not really come into vogue when we are really talking about human ADPKD. Phosphate intake, as I have already told, there should be a low phosphate diet, which might result in slowing of the kidney size. But high phosphate diet, they can cause calculus formation. There is a basically deposition of the calculus, which phosphate in the crystal deposition in the collecting ducts, which lead to accelerating disease process. Oxalate, as we know that, as already mentioned in the last lecture, that a patient with stone, the diet should be low oxalate and normal calcium. Similarly, in ADPKD patients, they are at increased risk of kidney stone formation, and plus already there is a chance of crystal formation may promote CKD progression. So in experimental animals, it has been shown that in PKD rats, increased urinary calcium oxalate promotes cystogenesis and PKD progression, in male but not in female animals. So there is a trend of juicing. So now sometimes we recommend, or that in the nutritionists they recommend that you should give a lot of juices to make someone healthy. But we have to understand that lot of juicing may lead to lot of oxalate intake, and which may lead to kidney injury in ADPKD, and the patient should be warned not to take lot of juices as it is advisable, not advisable. Now one can ask me how to change osmolality with diet. So as I'm mentioning that if there is an increase in the osmolality, there is an increase in the AVP, and if there is a decrease in the osmolality, so there will be AVP suppression. So how can we change osmolality with diet? So probably in some people they advise that plant-based proteins, they may be more beneficial to keep your osmolality low. Avoid snacking on high protein foods. Avoid double protein in the same meal. Limit dairy to 1 cup per day. Load your plate with fresh fruits and vegetables and whole grains, which will also keep your osmolality little low. Now, there are a lot of guidelines. I'm not going into details. Our students who are hearing, they can note it down and they can go through various guidelines. So I conclude that there is an increasing clinical and preclinical evidence that diet is a disease modifier in polycystic kidney disease, and it can have some role in to slow the CKD progression. But one important thing that what we always highlight, the dietary management of disease is compliance, because ADPKD patient in the early stage, they are other than there's a big kidneys, they are otherwise almost normal, so they don't have any symptoms. So even if you tell them to take a lot of water or low protein or low sodium, so they often follow. There's a poor compliance, so we have to tell them repeatedly so that at least they follow to certain extent. Thank you very much.
So thank you, Dr. Sural. And this was really a wonderful lecture. And I really like the concept of AVP and its lithogenicity. And the only thing is a very micro concept, which is not easily modifiable. But I find in most of the diseases, nearly 80% of the factors in stone formation with cyst or non-cyst are similar. Whether it is a fluid or dietary calorie intake or different types of vitamins and the salts also. But this is really interesting to know that in the last 2 decades, change in our dietary habits, especially the high calorie diet, has definitely increased the incidence of stone disease worldwide. And that this concept of low calorie diet, how it can be implemented into in our clinical practice will be really a game changer. As you said that it is a double-edged sword. Too much low calorie may also lead to starvation, and too much restriction in the protein also may also return to the protein malnutrition. So how we can strike a balance between the two? So can you tell us further, Dr. Sural?
That is what is the importance of our nutritionist. So sometimes what we do, we just tell our patient, we tell them to follow whatever we are advising, but it is very important that we refer them to a dietitian, a nutritionist. We will definitely counsel them and tell them that this is the amount of calories. Every time whenever you prescribe something, you have to understand that what should be the protein, what should be the carbohydrate, whether it is ADPKD or CKD. Sometimes we give reduction in protein, we tell you reduce phosphorus, but we forget the calorie. So we have to give the adequate calorie. We depends on the patient's body weight or the standard body weight. So the calorie should be maintained, and at the same time, what you want to reduce, that should be reduced. Sodium reduction is very important, that we can already tell, but ideally what the books are mentioning, which is a little impractical to measure the urinary sodium every time or urinary solute load. So, and coaptin is not available probably regularly. So ultimately you have to use your own clinical acumen, you have to consult the dietitian and tell them that it is very important you reduce the sodium. Regarding the hydration, whether it is a stone patient or ADPKD, what I always tell that it is very important that night water drinking, which is often missed, towards the nocturnal water drinking, because people they take a lot of water till they go to sleep, but then overnight there is some amount of dehydration. So in fact, it has been found that in ADPKD or stone patients, the nocturnal drinking is very important. So I advise my patients that you take at least a big glass of water while you are retiring to bed, and if you get up and go to the toilet, you take another bottle of big glass of water. So this night water drinking is very important, I think.
I agree with you, Dr. Soral, because this is a very practical point you raised. Because there were some studies also, this was highlighted that the maximum crystallization of the stones basically occur in the night time. So if the patient can take some water in the middle of the night, that might further reduce the risk of the crystallization as well as their stone formation. And secondly, I would like to know your thoughts. How frequently you are prescribing him ready-made heavily for potassium citrate or magnesium citrate, now syrups available in the market besides beyond your dietary management?
I personally don't use much, but I would like to know what is your experience.
Yes, yes. I think Dr. Sanjay would like to speak on this because urologists are very frequently using potassium citrate, magnesium citrate, and a combination of both. Dr. Sanjay? So what are your thoughts about, because we are frequently using potassium citrate, magnesium citrate, and urologists are very frequently using.
Sir, I didn't get your question, sir. There
So
was some
I was asking Dr. Sural, because in the market now there are potassium supplements in the form of potassium citrate and magnesium supplements also in the form of magnesium potassium citrate. So do they really work or it is just a placebo?
Sir, the role of potassium in stone disease management is not very well defined. However, there is a definitive role of citrate. It has been seen that in stone nucleation and in stone formation, low citrate is one of the major culprit. So the citrate definitely helps in patient with when we get a metabolic evaluation and there is a citrate value is on the lower side or low citrate, so it does help. But as a blanket therapy, the role of citrate supplementation, be it in the potassium, sodium, or sodium, potassium, magnesium citrate, is not very clearly known. So we should avoid as a blanket therapy. But if there is a definitive citrate deficiency, or if you feel that on metabolic evaluation citrate value is low, then citrate supplementation should be given.
So if you see the Western and the European literature, nearly 30 to 40% of the stones are formed in hypocitrate urea. While contrary to this, the Indian patients, they hardly demonstrate any kind of metabolic abnormality, including this hypocitrate urea. And we have almost tired or exhausted to find out. We hardly get more than 10 to 15% of underlying abnormalities. I do not know what are the reasons. And hypocitraturia prevalence in most of the studies in India is to the tune of 10 to 15% in various literature. So it is significantly less and less as compared to the Western counterpart. Yeah, that way you are right, absolutely, that if you are prescribing to OD, it might just be a placebo, or patient might, this might help to the patient that at least patient is taking some water along with potassium citrate. So that is a conditioning therapy.
Right, sir. Dr. Sural, I want to ask one question to you.
Yes, please.
Am I audible, sir?
Yeah. Yes, you are.
So it was nice. It was nice lecture, and it's really nice to know so many dietary modification in polycystic kidney disease, which we often forget, at least in urology OPD. Probably that's why we always refer the patient to nephrologist whenever we get a polycystic kidney disease, irrespective of the level of creatinine. There are certain dietary restrictions and dietary modification you said. Is there any supplementation which may help in ADPKD patients, which may reduce the progression of ADPKD patient? Just for my interest, like some vitamin or some other kind of supplementation.
Dietary supplementations or medicine?
In the form of, I meant to say supplementation, vitamins or anything like any minerals or anything which may help in reduce the progression of ADPKD. Anything known like that?
I don't think so. There is no. There are certain. There is something called nutricals, like some herbs and all. They have been tried recently. There are some recent data, but there is no clear answer to that. Regarding the other supplement, I am not sure.
Right.
And one thing is that the carbohydrate-rich diet increase the osmolarity of the blood, right? Urine. So there is restriction of sodium is fine, but what about the carbohydrate restriction?
That is what, not only that, the thing is that there is a glycolysis, the anaerobic and aerobic glycolysis, there is a balance. And when this balance is altered, there is the, what I was trying to tell you in that picture, that there is an increase in the CAMP and mTOR, which ultimately lead to progression of the cyst, and there will be cystogenesis. So, but they are surprisingly, they have found that low carbohydrate diet is not helping you much. But rather than, if you give more ketogenic diet, so which contains lot of fat, then automatically if you give more fat, that there will be reduction in carbohydrate. That somehow through a hexokinase mechanism, rather than just depletion in the glucose, there is this alteration in the glycolysis media, and they're trying to this is a little complicated. I mean, there is some shift from mitochondrial oxidation to aerobic glycolysis, and this ketogenic diet is probably helping there. But just giving low carbohydrate diet and rather glucose depletion, that is not helping much. But these are all experimental stage, so we don't have really human clinical data just to substantiate that what should be the actual diet and what should be the actual carbohydrate measurement to prescribe in this patient. So the reduction in sodium, little overhydration, little rest, reduction in protein, that is only what is available till now, the data.
Okay, sir. Thank you. Thank you.
Thank you so much.
So can we wrap up the session now?
Yes, ma'am.
All right. Thank you, Dr. Ansari, and thank you, Dr. Sanjay, and speakers for such a wonderful session and an excellent panel discussion. We now move on to our next session. And the most, I think people are looking forward to this session. This is on dietetics, session 10, on meal planning in CKD. The moderator for this session is Dr. Bharat Shah. I invite Dr. Bharat Shah, who is Director, Institute of Renal Sciences, Global Hospital, Mumbai. Over to you, sir.
Ma'am, sir will join in a while. I just speak to him.
All right. Okay. So we have with Dr. Bharat Shah.
I think you invite the next.
Dr. Tarun Chinoka.
Yes, I am here, ma'am. Good afternoon,
and
ma'am.
Dr. Anita Jetwana. Yeah, hi. Good afternoon, Dr. Tarun, and welcome to our
Thank you for the invite. Thank you very much. I appreciate it.
Yes. And if Dr. Bharat Shah is taking time, you can set the ball rolling. You can invite the first speaker.
Sure. Thank you, ma'am. So my experience is not anywhere close to Dr. Bharat Shah, but since he's taking a little bit time, and instead of wasting time, let us start with the first talk. So let me tell you, give a background. So as a clinician, when a patient comes to us, we know the guidelines. We can advise them low protein diet, pre-dialysis, and high protein diet, post or on dialysis, this much of calorie intake, this much of fat, and all these things. But it becomes very difficult for patient to understand. So they need a meal planning, and that can only be done by a qualified nutritionist or dietitian. Right. So with this in mind, I think panel discussion will happen later on. Let us start with the first speaker, Dr. Ritu Singh, who is going to talk on meal planning in pre-dialysis CKD patients. Over to you, Dr. Singh.
Good afternoon to all of you. It's great privilege to be here with you all eminent speakers. Today, my topic is meal planning in pre-dialysis patient, but due to certain technical glitch, I am not able to share my slides. Can I speak a little later as a second speaker? Please excuse me.
Sure, but your slides are visible, ma'am.
Okay. I think Sudhir ji has been here.
If you don't mind, you can continue and you can ask him to move the slides.
Okay. Thank you so much. Thank you very much. Meal planning is important for CKD patients. Sudhirji, please share the slides so that I can speak.
Ma'am, already share, ma'am. I have already shared.
But I can't see the slides.
Let me check.
Yeah. When we talk about nutritional intervention in CKD patients, usually we face some challenges, and these are uremic buildups, anorexia, protein energy wasting due to three factors: less ghrelin secretion and more leptin secretion, increased inflammatory responses causing protein energy wasting, as well as little synthesis of proteins. Apart from this, electrolyte imbalance, especially sodium and potassium and phosphorus, and fluid imbalance due to poor excretion of water causes a great toll on the health of CKD patients. Bone mineral disease and anemia. These are two things that also make patients' nutritional intervention program even more difficult to manage meal planning. And dyslipidemia is another factor that has to be taken into consideration while planning diets for CKD patients. Next slide, please. Yeah, so while planning meal, some objectives should be set by the nutritionist or dietitian, that what they have to do. So first of all, the first objective must be to maintain the ideal body weight, because usually the CKD patients are cachexic, they don't want to eat, they even don't want to face the dietitian, they even don't want to talk about food. So it becomes really difficult to feed these type of patients. Apart from this, maintaining proper muscle mass is also necessary to make the patient healthy, and to restore what the renal functions have been the patient is having. So one should be very cautious that how much electrolytes and how much protein, how much calorie the patient should be given, and further degeneration of renal tubules and filtration rates should be stopped or ceased. And bone mineral densities should maintain to normal, and one should try level best to reduce the incidence of fractures. And to maintain electrolyte and fluid balance should be the prime objective of the dietitian while planning diet for the CKD patients. Next slide. There are some steps in meal planning. First and foremost, dietitians should get a proper general information of the patient, including age, sex, religion, what the patient is going through, what is the present problem, what is the past history, what are the associated diseases. Usually the patient have a type 2 DM, hypertension, or sometimes other diseases too. Apart from this, detailed dietary history must be taken. 24 hours recall help the patient to know what is the recent or the present calorie and protein intake of the patient, so that he can take step by step to reach her objective or to reach her nutritional goal. And biochemical parameters are play pivotal role in planning diet for the CKD patient, because serum creatinine, blood urea, and sodium potassium, these are important biochemical parameters that should be taken into consideration before planning diet for CKD patients. Anthropometric measurements are very important to know the nutritional status of the patient, whether the patient is having proper weight or not, the patient is cachexic or there is muscle wasting. This all can be done only by doing a proper nutritional assessment, by taking weight, computing BMI, as well as taking skin fold thickness. So these anthropometric measurements must be taken before planning diet. And fluid intake and urine output should be taken into consideration if the patient is having pedal edema or facial puffiness or increased blood pressure. after taking these information either from nephrologist prescription or directly from patient, the MDA computation should be done. MDA is modified dietary allowances. This is an individual allowance for a individual patient. Next slide, please. So the next slide. Yeah, thank you. How the modified dietary allowances can be done? Usually the calorie intake should be 30 to 35 kilocalorie per kg, ideal body weight, but sometimes it becomes difficult. So if the patient is older than 60 years, it should be only 30 kilocalorie. And if the patient is young, you can go for 35 kilocalorie. And in diabetic patients, it should be 25 kilocalorie in order to maintain the glycemic level. Apart from this, protein allowances should be set according to GFR, glomerular filtration rate, that can be computed by different formulas are available. Fat should not, one should not afraid of fat while planning diet for CKD patient, as the patient may be dyslipidemic, but the selection of fat should be done intelligently. Fluid should be according to urine output if edema is there, otherwise 2 to 2.5 liters of fluid should be allowed to the patient. Unnecessary fluid restriction causes constipation, dryness of mouth, and other problems. Sodium restriction, yes, of course, should be low. It should be around 2 grams, or if we talk about the in form of salt, it should be 3/4 teaspoon. One should take into consideration that light salt should not be used, because they are usually sodium is usually substituted through by potassium. They have potassium chloride, and which is not good for CKD patient. They have potassium poisoning, hyperkalemia. Hyperphosphatemia is also an important feature which is contributing to bone mineral disease. So the phosphorus level should be less than 800 milligram to 800 milligrams, and the fiber, especially soluble fiber, should be 20 to 30 grams per day. Next slide. When computing the protein allowances, it has been seen that if the GFR is more than 60, that is stage 1 and stage 2 CKD, you should give ideal protein to the patient so that muscle wasting cannot be take place. If the GFR is in between 59 to 30, one should give 0.8 gram protein, and if the GFR is less than 30 to 15.7, and if the patient in stage 5 CKD, that end stage renal disease, less than 0.6 gram protein per kg ideal body weight should be given. And the precaution should be taken that the whatever protein you are providing, the 60% should be from high biological value. Next slide. Next slide, please. Yeah, I have made 3 meal plans. They are comprehensive meal plans in which I have given 1800 kilocalories and 60 gram protein for stage 1 and 2, that is ideal protein allowance. Here I have given cereals around 8 exchanges. You can see the quantity of one exchange just this in the second column. So 8 exchanges of cereals, and pulses 1.5 exchange. Care should be taken that 1 portion should be from soy protein. Milk and milk products are given normally 2 because they contain essential amino acids which are highly needed for muscle building. Fruit and vegetables are given normally. Fruit and vegetables should be given normally to each and every CKD patient, unless and until the patient is not having hyperkalemia or serum potassium level more than 4.6, 4.7, or even 5. And egg, fish, and poultry should never be abstinent from the diet in stage 1 and 2, because they are good source of protein, and care should be taken that they should be given with phosphate binders. Fat should be around 6 exchanges, 4 exchanges, that is around 20 grams, and sugar again 6 exchanges, that is around 30 grams. So when you plan a diet by this comprehensive menu, you will get around 1800 kilocalorie and 60 gram protein, which will be good for stage 1 and stage 2. Next slide, please. In stage 3 and 4, as cereal contains proteins of low biological value, so I have cut off cereals and I will replace it with sugar. Don't go for a refined sugar. It will be some sago, a helping of sago porridge or sago khichdi type of thing, and or arrowroot powder can be added in the wheat flour to reduce the cereal protein, and pulses also reduced to 1. Milk and milk products remain 2. One should be from soy milk. Fruits and vegetables are normal because the patient usually do not have hyperkalemia, and if there is hyperkalemia, the fruit should be restricted. Egg and poultry has been reduced to 1 with phosphate binders, and fat and sugars have been increased in order to maintain the calories. Again, I will repeat that the fat should be selected intelligently. Next slide, please. In stage 5, if you can see or you can notice, the fat and sugar levels have been slightly increased in order to get the calorie content. But if the patient is having diabetes, sugars can be omitted, and then you will get the 25 kilocalorie per kg ideal body weight energy and around 30 to 35 grams of protein. So here I have made 3 comprehensive menus which can be used for CKD patient in different stages in pre-dialysis state. Next slide, please. Some guidelines which should be followed while planning diet for CKD patient. The cereals which you are using should be refined. Brands should not be used because they contain a lot of phosphorus as well as potassium. So some options have been picturized here. Next slide, please. Yeah, whatever protein allowance has been set must be met properly in order to reduce the serum creatinine level, because as we know, if we will provide less of protein, more protein catabolism will take place, and that will contribute to elevation of serum creatinine level. One more thing I just want to share here, that the egg whites, when compared with whole eggs, contain very less phosphorus. They contain only 5 milligram of phosphorus as compared with whole egg that contains around 95 milligrams of phosphorus. So egg whites can be easily used for a CKD patient, even if you want to remove the phosphorus from the diet. So egg white should be, the attendants and the patient should be counseled to start. Even I just counsel them to start egg white even if you have not ever eaten eggs, because they are going to help you in so many ways. So one should take care that the whole egg should not be used, but egg white should be the part of diet of CKD patients. Yeah, next slide. Some protein sources should be avoided as egg yolks, nuts, beans, mutton and beef, whole pulses and cheese, because they contain a lot of phosphorus, as well as some sources contain potassium too. Next. When we talk about pulses, as it is an integral part of Indian diet, we cannot remove it, and plant protein has been shown that it has good effect on CKD patient. But whatever pulses you are going to use, they should be washed or dehusked, and soybean should be a part of pulse exchange, as it contains good amount of protein in a small portion, as well as it contains less phosphorus. Next. Milk and milk products should never be removed from the diet, because they are important for essential amino acid source. And milk can be used as yogurt, dahi or thick buttermilk in order to provide probiotics to the patients. Next. As I have told, we should not remove animal proteins from the CKD patient's diet, because they are a good source of protein, and they should be used with phosphate binders to give good protein and net protein utilization value to the diet. Next slide, please. There are some fishes that are low in phosphorus. I just want to add from the last slide those are panfish, cod, and tuna. If the patient wants to eat fish, you can say that half exchange of these fishes can be used in order to give satiety to the patient. So fruits which can be used are here picturized. They are low in potassium and can be used safely if the patient is not having a hyperkalemia. The raw fruits should not be used. Fruit should be fully ripe. And if the fruits can be peeled off, the potassium content can be removed. Fruit juices, packed or fresh, should not be used in the diet of CKD patients. Next slide. Usually, we say that green leafy vegetables are lethal to CKD patients, but some green leafy vegetables have low potassium content and can be used occasionally. That is fenugreek, cabbage, and onion leeks. And if other green leafy vegetables are being used in the diet of CKD patient, they must be properly leached to remove potassium. Though leaching not only reduce potassium, but also reduce so many micronutrients. So one should not encourage leaching, but once in a while, if the patient wants to eat something of high potassium, leaching can be done. Next slide, please. Other vegetables, as we know, vegetables from cucurbitaceae family, they are good source of soluble fibers. Bindi, guarfali, that is guargum, French beans. They can be used safely for CKD patients. Patient want to eat potato. If the patient want to eat potato, as it is high in potassium, potato should be peeled properly. It should be cut into small pieces, cooked, and broth should be removed, and potato can be used safely as it is a good source of calories, and it will add calories to the diet, which is usually insufficient in CKD patients. Next slide. We should not afraid of fat because of dyslipidemia. Fat should be in the diet and properly in the diet of CKD patient because it is a concentrated source of energy. But as I have said, they should be chosen intelligently. Mustard oil, olive oil, they are cardioprotective. They can be used. And half teaspoon of deshi ghee should be in the diet of CKD patient. That will make the diet palatable, as well as they are important source of short chain fatty acids, and these short chain fatty acids are required for the proliferation of gut microbiota in the lumen. So it can be used safely in CKD diet. Next slide, please. Probiotic, one should not forget probiotics when planning diet for CKD patient. Yogurt, buttermilk, and fermented vegetable and foods like idli, dhokla, etc. should be added in the diet in order to proliferate the good microbiota of intestine that will maintain the intestinal integrity as well as enhance the absorption of nutrients and medications. Next slide, please. Yeah, some frequently asked questions to the dietitians by the attendants and the patient. They don't want to eat food, anorexia. So small and calorie dense meals like porridges, sago porridge, chawal porridge, that must be added in the diet. Meals should be small. It should not be elaborated if anorexia is there, but it should be small but calorie dense, like laya, sattu, kheer. That should be given to the patient. That will not only provide the sufficient calorie, but also to protein to the patient. Next slide, please. Flour should be always wheat flour. No mixing of flours should be done. If protein intake one has to cut down, then it can be added with sago powder or arrowroot powder, and the flour should be always sieved in order to remove bran. Next slide. If the patient is not having edema or facial puffiness or increased blood pressure and proper urine output, 2 to 2.5 liters of fluid should be allowed to the patient. Unnecessary food restrictions should be avoided. But if the patient is having these problems, then the fluid management should be done. Next. Salt is injurious for CKD patient. Less salt is advisable, around 3¼ teaspoon, and care should be taken to not to take light salt because they contain potassium. Other salty food items like pickles, chutneys, jam, jellies, and bakery products that have hidden salt should be avoided. Next slide, please. Yes, this is important. Usually patient comes with low hemoglobin and asks us to increase some iron-rich food items in the diet so that hemoglobin can be improved. But you have to counsel your patient that here hemoglobin cannot be improved by diet. Here pharmaceutical management has to be done either in terms of iron supplementation or erythropoietin injections or through blood transfusion. Diet cannot help in avoiding or correcting anemia, renal anemia. Yeah. So diet, iron-rich food should not be incorporated in the diet when you are dealing with anemic patient. Thank you for your patient hearing. Thank you so much.
Dr. Bharat Shah, please take over.
Yeah, Tarun, you go ahead.
No, sir, please take over. Take over.
Okay, so for the next talk, we have Ms. Ipsita Chakraborty, who is going to talk to us about planning meals for patients on hemodialysis and peritoneal dialysis. So over to you, Ipsita.
Thank you, sir. Thank you, organizer, for inviting me in this amongst this panel, this esteemed panel, and a special thank you, Dr. Anita ma'am. So I'm sharing my slide. My slide is visible?
Yes, very well.
Thank you, sir. My topic is meal planning in maintenance hemodialysis and peritoneal dialysis. So prior to dialysis and hemodialysis, peritoneal dialysis, the basic structure, basic points have been discussed by Dr. Ritu Singh. So I will take it forward from our session. So we all know renal disease. To start with, we have normal functions of kidney. And because of some diseases, this GFR goes down and we develop lots and lots of complications. So to start with, normal functions are there, but we may have hypertension, diabetes, obesity, and many other congenital problems also. So CKD risk factor reduction is there, lower BP. So what we have to do, we have to control our BP, we have to control our diabetes, we have to maintain our weight loss, weight management. Complications of CKD like uremia, managing of anemia, prevent malnutrition, and we have to undergo replacement when the disease is increasing and it reaches stage 4 and stage 5 when it is ESRD, and the GFR reaches below 15 ml. So we need to go in for dialysis or transplantation. These are the two only options left. So these are the basic reasons why ESRD is there, like diabetes mellitus, hypertension, glomerulonephritis, interstitial disease, cystic or hereditary or congenital problems, and neoplasmic tumors. But if I consider diabetes mellitus, 40.3%, almost 40.3% of the population is having ESRD because of diabetes, and followed by hypertension, and rest follows. So metabolic pictures of renal disease, it's accumulation of metabolic waste products like urea, uric acid, creatinine. We always find this elevated urea, elevated creatinine a patient when land up in a OPD chambers or as a inpatient. Decreased excretion of urea, which leads to uremia, metabolic acidosis, hyperlipidemia, hypertension, glucose intolerance, and catabolism is also there. Increased levels of catabolic hormones like cortisols and adrenaline. Anorexia and undernutrition is there. When your creatinine and urea is high, patient is in such a state, doesn't want to eat anything, so automatically intake goes down and patient becomes malnourished, and they get collect a lot of information from their relatives, from their neighbors, so they stop eating even whatever they are allowed to eat. And in these cases, we have electrolyte derangements like sodium, potassium, calcium, phosphate, anemia due to failed erythropoietin release. Here also, lots of wrong ideas and inputs they get from relatives and family members. So they are having some juices of some green leafy vegetables or some vegetables or some fruits. So that then also they land up with hyperkalemia. And because of all this, they have malnutrition. So which leads to protein energy wasting syndrome in a CKD patient. So it's a very vicious cycle. The uremic toxins are there due to that cachexia, hepatocatabolism, inflammation, malnutrition due to undernutrition, low nutrient intake. Patient is having comorbid conditions with diabetes mellitus, cardiovascular disease, infection, aging, increased production of inflammatory cytokines, anorexia, acidosis, anemia, oxidative stress and carbonyl stress, volume overload, low nutrient intake with prescribed dietary restrictions. Patients usually are given lots of dietary restrictions. Even in addition, they do additional restrictions. So with that, they land up in severe malnutrition. Along with that, they have endocrine disorders, vitamin D deficiency, increased PTH, diabetes, decreased insulin level, IGF signaling, nutrient. When they start dialysis, they have nutrient loss during dialysis. So for that, they require dietitian's consultation so that they increase their protein intake and what correct type of protein, what correct quality of protein, quantity of protein to be taken, that needs to be taken care of. Even these cases, they have low albumin, transthyretin and lipids are low, increased CRP, body weight goes down, BMI goes down, body fat goes down, they have sarcopenia, and which ultimately leads to mortality, increased mortality rate or increased hospitalization and poor quality of life. So for that, we need to do in this condition, patient lands up in the hospital in a OPD chamber, maybe from doctor, maybe directly to us. So first we need to do the assessment, which includes the height, weight status, frame size, arm anthropometrics, appearance, amputations. Diet history, we need to take appetite or intake of the patient, food preferences or choices, allergies, intolerance, taste changes, acute or chronic GI concerns. If patient is diabetic, might have gastroparesis, swallowing and chewing concerns, urine output, pica, religious or cultural beliefs, supplement intake, homeopathic treatment, and nutritional knowledge. These are all we need to know. Along with that, we need to know, because these days elderly person may be living alone or maybe husband and wife, they are living, they are very elderly. So we need to know the shopping and cooking abilities and facilities. Psychosocial problem like emotional support and economic limitations, depression, adjustment to the disease and treatment compliance, medication with its side effects and compliance, and physical limitations like abilities. Some may have inability to walk, inability to go to the market, the shopping, and doing everything. So all these we need to look into, and all these we need to keep a track so that the diet we advise that particular person can follow. These are the laboratory analysis for normal value of those tests. These are the blood parameters, blood workups, which needs to be done for our patient, for our CKD patients. And we need to look into the value, whether the value is decreased or increased. Depending on that, we have to prescribe the diet. When it comes to the elevated workup blood parameters or deranged blood parameters, can be used in all cases of AKI, used in late or last stages of CKD. What are the stages? It can be done through peritoneal dialysis or hemodialysis, or if it's hemofiltration like arteriovenous or venovenous, and ultimately which leads to renal transplant, maybe cadaveric, maybe through living donor. Today I'll be dealing with peritoneal and hemodialysis, diet in peritoneal and hemodialysis. This is a very simple picture. On the left hand side, patient is undergoing hemodialysis. On the right hand side, patient is undergoing PD. In a global dialysis perspective, India, it's a little a slide way back in 2018. 210,000 new patients develop kidney failure each year, amongst which patient 175, almost 75,000 patients were on maintenance dialysis in 2018. That's why I said it's a little earlier old slide. Dialysis modality, the blue part is hemodialysis and reddish maroonish part is PD. So 94% is on HD and 6% is on PD. And the funding of the dialysis, around 50% of the total person who is undergoing dialysis, 50% is self-paid, 30% is state funding, the grayish portion 10%, and the peach color another 10%, which is equally divided by the employment's best in insurance or through charity. So recurring cost for one HD session, it's 1,100 to 4,500, ranging from which unit you are undergoing the dialysis. The total cost, it's a capital plus recurring to a health system for one HD session for a public sector hospital, around 4,100. These are KDOK guidelines for HD and PD. The protein, it has to be more than 50% of high biological value. For HD, it's 1.2 gram per kg body weight. For PD, it is little higher, 1.2 to 1.3 gram per kg. Energy, if the patient is less than 60 years, it has to be 35 kilocalorie per kg. And if it's more than 60 years, it's 30 to 35. Same in the case of PD. Phosphorus 10 to 12 mg per gram, protein or 18 to 800 to 1000 mg per day, adjust to the meet of the protein needs. And for PD, it's 10 to 12 mg per gram or the 800 to 1000 mg per day. Potassium 2 to 3 gram. Output plus 1000 ml, we have to limit the intradialytic weight gain. And for PD, we need to maintain the fluid balance. Sodium 2 gram for HD and 2 to 3 gram for PD, but for that also we need to monitor the fluid balance. Calcium less than 2 gram, including binder load, maintenance. Serum, we have to maintain the serum calcium within normal limits. The same in case of PD. Vitamins and minerals, I am coming in the next slide, and fiber, it has to be 20 to 25 grams per day. Vitamin C for HD and PD, the same, 60 to 100 mg per day. With vitamin B6, the same, 2 mg per day. Folate, the same, 1 to 5 mcg per day. Vitamin D, 15 international unit per day for both cases. Zinc also the same, 11 to 15 mg in an individualized. B1 is to 1:1. I mean 1.1 to 1.2 mg per day for hemodialysis patient, and for PD 1.5 to 2, and others we need to follow the RDA. What are the goals when when we plan our therapy? What are the plans? We have to provide an attractive and palatable diet, because they have a psychological problem. We can't have so many things, so they are basically depressed. So we need to counsel them that you can have little bit of modification, little bit of moderations you can have. You have to control edema and the serum electrolytes, prevention of nutritional deficiency, prevention of renal osteodystrophy, and prevents of nutritional. Modified food first advised. Along with that, if patient cannot have, nutritional supplements are available, and which can be diluted in a very lesser amount of fluid in a good quantity, so that gives you good amount of protein with in a very minimal quantity of fluid. Yeah, even I also recommend for my patients, like 100 of fluid, you patient is add in severe cases, IDPN for hemodialysis patient, IDPN can be given, and TPN can be given when patient cannot be given through GI feed cannot be given. Albumin, again a controversial key nutrient. Depressed value like PM, fluid overload, chronic liver or pancreatic disease, steatorrhea, inflammatory GI disease, infection, catabolism, surgery, abnormalities in protein metabolism, acidosis. And for elevated values, we can find dehydration, high dietary protein intake. So for dialysis treatment, 10 to 12 grams of free amino acids are lost through HD. So losses increases with glucose-free dialysate, and for PD, 5 to 15 grams of protein lost as albumin. Protein, already I have shared that it has to be 50% has to be from high biological value. 1 to 2 to 1.5 gram protein per kg. Standard body weight, average protein comes to 80 grams protein, 50% of which should be high biological value. It should include poultry, fish, turkey, eggs, cottage cheese, soya, and protein alternatives, protein bars, protein powders, and supplement drinks can be given. Lipids, we need to look into this. Recommended fat intake, it should be less than 30% of the calories. Saturated fat should be less than 10% of the total calorie. Sorry. Omega-3 supplementation for elevated TG patients, it should be given. Potassium, which is a very important micronutrient, which we need to look into while making a diet chart, dietary advice for dialysis or HD or PD patients. 2 to 3 grams per daily, but it has to be considered along with the serum potassium level. We have to prescribe low, medium, and high fruits and vegetables while prescribing a diet. Portion size should be given. Avoid salt substitutes, because people might think I'm having low sodium, but low sodium salt or different salts which are available in the market. But we have to remember, if sodium content is low, so another other electrolyte in the blood. So total sodium salt should be restricted. Don't go for any salt substitute. And total salt matters. It doesn't mean that patient comes to me and said, I'm not adding any extra salt on top of my feed. Additional salt doesn't matter. It's the total salt matters. Whether you are having the food salt free and you are adding salt on top, or your whatever amount of salt is included, allowed for your daily consumption, that can be added in your cooking, and you cook with that. Both way it can be done. But I'm not having additional salt, but my cooking, my preparations are high in salt. That cannot also be done. Avoid high avocado, tomato, nuts. Like potato, in some cases when a patient's potassium is under control, we can give some amount of potato just to add up to some calorie, because it doesn't contain a good amount total calorie intake. We give little potato to a patient depending on the potassium content, serum potassium level of that patient. For phosphorus, dietary intake is approximately 800 to 1000 mg per day. So if suppose 1000 mg per day, so weekly intake is 7000 mg per week. The approximate absorption is approximate 60%. So if it's 60% of 1000 mg, that comes to 600 mg per day and 4200 mg per week. We need to have phosphate binder. So 300 mg per day is removed that in a week, 2100 mg is removed in a week. So through dialysis removal, HD remove 700 per HD, so 2000 if it's a thrice a week. So 2800 mg per week. In that way, low phosphorus, high phosphorus foods are like dairy products, beans and nuts, processed meats, chocolates, pancakes, waffles, biscuits, cakes and cookies, sardines, whole wheat and bran cereals. And low phosphorus food, non-dairy creamer, cream cheese, white flour products, ripe products. These are low sources of phosphorus. Inorganic phosphorus are absorbed easily. So before buying any packaged food, we need to go through the nutritional facts. We need to go through the label because of FSSI. In these days, all our packaged foods contain these nutritional facts. So need to go through the nutritional facts where it is written whether any additional phosphate is being added to that packaged food. Like in the phosphoric acid, sodium hexametaphosphate, calcium phosphate, disodium phosphate, trisodium phosphate, monosodium phosphate, sodium tripolyphosphate, tetrasodium pyrophosphate, or potassium tripolyphosphate. In these names, we can find phosphates in our packaged foods. Calcium, we need the calculation like 4 minus if for albumin less than 4 minus albumin into 0.8 plus the calcium value. For hypercalcemia, the calcium-based binders, supplements, vitamin D analogs or treatment, diet of 45 foods, lysate calcium levels. For hypocalcemia, vitamin D, calcijates, supplements between meals. Fluid, it's a very important thing which we need to look into for a CKD patient. Liquid or fluid intake for adequate urine output. Normal fluid intake we have to maintain. For inadequate urine output, urine output plus 500 ml, like suppose 100 ml of urine output plus 500, that discard the liquid consumed after measured, like one person is given 1 liter. So to discard that amount of fluid from that bottle. We have to limit the intradialytic weight gain 2 to 5% estimated dry weight. So sodium, if it's more than 1 liter of sorry, if it's more than equals to 1 liter fluid output, 2 to 3 grams of sodium and 2 liter of fluid. If it's less than 1 liter, 2 liter of sodium. Just a minute. Sorry, 2 grams of sodium and 1 to 1.5 liter of fluid. If it's a patient is anuric, 2 grams of sodium and 1 liter of fluid, but it has to be individualized. We need to look into the intradialytic weight gain, blood pressure, residual renal function, increased restrictions. If increased intradialytic weight gain, congestive heart failure, edema and hypertension is there. On the left hand side of my picture, there is a small spoon which contains 1 gram of salt. So a person who is salt restricted for renal disease, one can have this small, it is available in the market, so that can have an exact measurement of salt, whatever is prescribed by the dietitian. Optimum fiber, we already said it has to be per day. Renal multivitamin containing water-soluble vitamins, dialysable take after dialysis, limit total vitamin C. C increases, so automatically increased oxalate level and calcification of soft tissues and kidney stones. Individualize the increase of iron, vitamin D, calcium and zinc. Oral supplements, modular protein bars, meal replacement versus snacks. Instead of giving snacks, meal replacements can be given. Evaluate the potassium and phosphorus. Do not buy any OTC product. Oral supplement barriers are there, like compliance, fluid restrictions, palatability and cost. For tube feeding. We need to go through, check the renal formulations, barriers are acceptance, intolerance, tube replacement, fluid intake, and assistance. IDPN, here oral intake is maximized without improvement when there is no improvement in the status. Usually requires documented malabsorption diagnosis. Benefits are supplemented during treatment. Dialysis clinics have individual rules and criteria where IDPN can be given. For that, we do not require any additional tube or access is needed. Clinicians use several strategies, but there are barriers to nutritional counseling, which include skepticism about the effectiveness of the nutritional intervention, lack of specific knowledge and training about the therapeutic nutrition, lack of specialty clinics, absence of guidelines, and inadequate number of dietitians available. All patients should receive nutritional counseling based on an individualized care plan. One diet doesn't fit all. We have to remember for every cases. So to summarize, poor nutrition is common in renal diseases and has adverse consequences. Nutritional counseling and part of approach to CKD and dialysis patient routine. Both nutrition must be included in the nephrology unit and personalized nutritional plan worked out for each and every patient. And it's, again, I'm saying it needs an individualization. Thank you so much.
Thank you, Ipsita. This was a very good coverage about principles of nutritional management in dialysis patients. But it would have been nice, Ipsita, if you could have given us some recipes which could have covered practical aspects of management and meal planning for patients who are on dialysis. One in nutritional principles is one thing, and what possible recipes we can provide to them is what in practice would be more useful. So it would be nice if you could tell us about a few recipes for patients who are on hemo or peritoneal dialysis.
So normally I recommend my patient to have normal diet. I do not tell them to have something different from what his or her family members is having, because they have a psychological problem. When they start with dialysis, they have like financial issues, they have health issues. As it is, they were on low protein diet, so they are physically, they are cachectic, so lots of mental issues are there. So I tell them to have, like, they can, like dal and dal products I restrict, because the area of the country I work, so they have a good amount of non-veg items. For dialyzed and PD and HD patients, they can have fish or chicken and egg white, like curd and chena. They can have, like milk I tell them to avoid, as it is counted as a part of liquid. So
that is exactly what I'm sure everyone would want to know, that from a practical point of view, let them eat the usual diet. So when it's the usual diet, then they can eat well and the nutrition can improve.
So suppose somebody doesn't want to have paneer, so I tell them just grate it and make it as stuffed paratha. So they will like that they're enjoying that they're having paratha. Even children come to me who is undergoing dialysis. So they have that, like, I am segregated from my friends. So they should have that psychological support. Even some biryani sort of a thing can be made at home. Not from the shop, but it can be made. I always instruct their parents or the normal adult population.
Comment from Tarun.
Yes, sir.
I fully agree with you. In fact, in my opening remark itself, I said that all these principles and guidelines we clinicians are aware of. Where we lack in guiding our patient is what meal planning we should offer, which right now she said. So it is always helpful from practical standpoint. If I tell my patient to restrict their protein, he won't understand anything. So we have to actually give a meal plan. So this is what you eat, this is you avoid, and this is what you restrict. So I think that would definitely help. So I have several questions which we can discuss during the panel discussion. I think if you agree, we can go into the next talk.
Yeah. So The next speaker for us is Ms. Zamrud Patel. And without taking much time so that we have time for panel discussion, over to you, Zamrud.
Sir, thank you so much. And I thank the organizing team and Dr. Anita for having me here. I'll start my screen sharing. So we've already heard the nutritional management for stages of chronic kidney disease and the therapy for renal replacement therapy. The topic that is given to me is on nutritional management in nephrotic syndrome. Now, nephrotic syndrome is a disease which we see in children more often, and therefore the dietary management may be a little challenge because as such to feed children, it is little difficult. And when they have a disease, it becomes a little more difficult because we want to give them some nutritional restrictions. So coming to the definition of the disease, nephrotic syndrome is a disorder characterized by losses of large quantity of proteins, and you see high level of cholesterol and low level of albumin. So probably the challenges that we need to face for planning diets for nephrotic syndrome is the protein content of the diet, the salt content, and the fat content. Now, the common symptoms in patients with nephrotic syndrome that are seen are swelling. That could be swelling on the face, it could be a generalized swelling, it could be the swelling in the extremities or the abdomen. You can have frothy and cola-colored urine. There is weight gain, that is, of course, the retention because of the edema, and of course, poor appetite. Now, these are the common symptoms, and thus dietary management for these children becomes little difficult, and it is a challenge to manage such children. So what are the nutritional challenges that we face when we are planning diets for such children? So as I've told, first it is the proteinuria, second is the edema and fluid overload, and third it is hyperlipidemia or dyslipidemias. So talking about the dietary management for proteinuria. Now, there has been a lot of debate regarding the amount of protein that needs to be given to nephrotic patients. Probably in the early 20th century, a high protein diet was recommended because there was proteinuria, and it was thought that if one gives a high protein diet, probably you can maintain the serum albumin level. However, a number of studies have shown us that these high protein diets are not beneficial to patients of nephrotic syndrome, probably lowering or moderate reduction of protein intake, but providing good energy intake is very important to maintain the positive nitrogen balance in these patients. So now what we use is a protein intake, if you see. So further studies have also suggested that a high protein diet causes damage to the filtrate barriers of the glomerular capillary, resulting in increased protein losses. And that's the reason today we use a protein intake of 0.8 to 1 gram, of which 50% of protein should be of high biological value. And this can decrease the loss of protein in urine without adversely affecting the serum protein levels, that is the albumin level. Again, it has been found that patients of nephrotic syndrome, there is a little work which is done on the use of vegetarian soya protein, and they found that it is useful. But probably since we are talking of children and soya is a protein, probably it has its own flavor, and in many children, it may be a challenge to incorporate this soya diets. So now coming to the second part, talking of the dietary modification for energy and protein intake, edema and fluid overload. Now, again, salt intake needs to be individualized in these children. Normally, this spoon that you see is the 1/4 teaspoon measuring spoon. If you level your amount of salt and you fill into this and you level this, this is about 1 gram of salt. So depending upon how much gram of salt you are prescribing to your patient, you can give that many amounts of this spoon, and they can measure their salt intake, and it can be given to the children. Now, what needs to be avoided in them is the tin and the canned foods, the packed food, because again, the preservatives which are used, which are sodium salts. Again, a lot of all these packet foods in the form of the chips, popcorns, puffs, the soups, the pastas, ready pastas, the dips, the salad dressings, the sauces which are used, these again are rich sources of sodium, which is a hidden sodium, because they contain different varieties of salt or probably the preservatives. So this needs to be restricted, and measured amount of salt needs to be given. Now, when we are restricting the salt in these children, we need to definitely add flavor to the food. And these flavors are readily available in our kitchen in the form of lime juice, vinegar, kokum, tomato, tamarind, amchur powder. You have these herbs and spices in the form of spring onion. You can use mustard powder, cinnamon powder. Probably these things add flavor to the food with the limited amount of salt that we are recommending to these patients. Again, we have developed a lot of adjuncts and recipes for giving to our patients. So this is just to show you an example of a kokum chutney, where only kokum, roasted jeera, and sugar are just grinded together. So these recipes are easy to make also, because this is when it is served along with the food, it makes the food tastier. It's a guava chutney, because guava is a food. Even if somebody has a potassium restriction, you can incorporate. So just using mint, sugar, lime, and green chili crushed together, it can give a very good side dish, which the people will enjoy their food with a limited amount of salt that is recommended. Now, these are the publications that we have, where we have giving all these recipes that I've just spoken. There are a number of other recipes which are there for the snacks and other main course recipes, desserts, which are there in these publications that I'm just showing you. Probably to get a hand on this, you can visit our website at www.Narmada Kidney Foundation. You will get these publications and these recipes there. Now, after talking about the salt restriction, fluid restriction is also important. When we are talking of fluid restriction, first thing that we need to make the patients understand is what are the foods apart from water which have to be incorporated, which have to be calculated. For example, your tea, coffee, milk, lassi, chaach, curd, soup, jelly, custard, ice cream, soft drinks, juices. These all are foods which have to be calculated for the fluid when you're consuming these on daily basis. So whatever amount you are calculating, say if you're having total of this of 300 ml and your fluid restriction is 1 liter, so probably you've minus 300 and 700 you can have as water. Now, if you're restricting the fluid to so low levels, you need to give them options. So use of peppermint or candies, or making ice cubes, where you have the ice cube trays which are labeled with the volume of water that is going to go into each cube. Probably you can flavor these cubes, but just by putting some lime juice or some ginger juice, and then teaching patients to use thick curd or hung curd instead of curd, using thick dal instead of using thin dal, probably making paneer rather than using milk. So these are some ways of saving on the fluid so that they have some amount of water to drink. Use of small glasses and small cups to, you drink their liquids, avoiding of salty and fried food. These all are some of the tips that we can give our patients when we are talking of restricting the fluid in the diet. Now, at our hospital, we work very closely with our patients, where we conduct this diet workshop. And probably this was one of the workshop where we made bakri pizzas for our pediatric patients, and we had made charts which were totally salt free. And definitely these are the ways in which we can help our patients to eat with the food, make the food tasty, eat the food, get the right nutrition along with their restrictions. Now, talking of the third modification, that is hyperlipidemia. Now, we normally see nephrotic syndrome elevation in serum lipid concentrations, and normally the advice to patient is to modify the fat intake by using polyunsaturated and monounsaturated fat rather than using saturated fat. So they are supposed to have normal fat intake, and the recommendation says about 500 to 600 grams of fat per person per month. So probably it works out to about 4 teaspoons of oil plus ghee in a day. So you have to give them normal fat intake. You do not stop their fat intake, but you add to avoid deep fried foods or too much of nuts and oilseeds, probably if they are used in the gravies, because in many religious cooking ways, like in Maharashtrians, they use coconut and groundnut in cooking. So probably you need to restrict that, but the normal intake of fat needs to be recommended for these patients. Avoiding too much of deep fried foods, too much of butter, ghee, cheese, cream, bakery foods in the form of cream, biscuits, wafers, chips. These are all hidden sources of fat that come into our diet. So probably you need to restrict that, but allow them to use the normal fat intake. Now, when we talk of this, probably when we are trying to restrict the salt intake, trying to cut down on the protein intake, and to give them the fat in limited portions, what we need to understand is that we need to prevent malnutrition and to ensure adequate energy intake. And how do we do so? We allow our patients to use probably the supplements, the type of supplements that they need, probably if their intake is of energy is not adequate, because adequate energy intake is very important for correct utilization of proteins. Okay, so even if you're using a nutritional supplement, probably the type of the supplement that you're going to be using will depend on the extent of the sodium and the fluid restriction or the protein restriction that your patient has. So you have a variety of supplements which are available in the market. Depending upon the need for adding the energy, probably you can look at low protein supplements which are available, which would give you the adequate energy intake if this energy intake is not adequate from the diet. So adequate energy intake we do need to consider. That's very important. So probably providing tips of, like earlier speakers have also mentioned this, eat frequently small and frequent meals, add arrowroot or sago flour to wheat flour for making your chapatis or making any snacky items. You can apply the amount of oil and ghee that is recommended to you. Probably use of starches in the form of root vegetables like potato, sweet potato, suran, arbi can be added. So probably if the sugars are not a problem, so sugar, honey or jaggery can be incorporated in the diet. Desserts can be made out of sago or arrowroot, which are helpful for our patients. So this is just one some recipes that we had generated. Actually, these recipes we had made, when we had made these recipes, we had made them as fried recipes. Then this was for very low protein diet people where we wanted to give them energy. But now when we tried for these patients who have high lipids, probably the same recipes where you can use rice flour, arrowroot flour combination, you can put some spice to this, and you can make the similar way like you make your sev or puri at home or your shakkar paris or jeera sticks, and you can, rather than frying, you can bake these recipes. So probably you are adding calories, and here you may not, if you want to restrict your proteins, probably that's the reason we use rice flour. But if you want to even give some amount of proteins, you can use wheat flour along with arrowroot flour and make these recipes. Another advantage is that in the market, patients do not get these products. So when we provide these recipes to our patients, they look forward and they have some options available to have as mid-morning and mid-evening snacks. So they really look forward to these recipes. Now, another importance of nutrition is based on the response to the treatment. People who respond to the steroids, okay, there are no major restrictions that these patients need. So steroid responders, there are no major dietary restrictions that you need to give to patients with nephrotic syndrome. The frequent relapsers and steroid dependent patients are the ones who are vulnerable to steroid toxicity, and they have to pursue dietary restriction. Then we need to monitor their hyperglycemia status, their hypertension. Probably for them, the salt restriction has to be more stringent, and again, you have to think of giving them constant exercises. For people who are steroid resistant, again, there may be a decrease in the kidney function. Their nutritional status can also worsen, and they will have to continue the salt and fluid restriction. So we need to really counsel them well and give them adequate energy intake. And probably some of them may also need the low protein diet restrictions if their kidney function declines further. So depending upon the status of their response to the treatment, probably the dietary restrictions needs to be considered. So thank you, friends. This is all I had to share. This is our team from Global Hospital. Thank you for your patient listening.
Thanks, Amrut. Tarun, can you take over and...
Sure. So I have a few questions. Before that, I think there is third panelist, Dr. Anita Jantan. Is she there? Has she joined? She hasn't spoken. Dr. Anita, is she with us?
I'm sure she should have joined because she
If
knew
Anita
she was
Jaktana is not there, Anita Saxena is always there.
Sir, I think I'd leave it to you too. I mean, Dr. Anita Chitani should have joined. I do not know what happened.
I didn't see her name.
Anyways.
Okay, if she joins, so can I start a few questions, sir, with your permission, Dr. Bhatt?
Yes, Tarun, please.
So I've noted down some questions. So a couple of questions to Dr. Ritu Singh. She talked about meal planning in pre-dialysis patients.
Yes.
So one question was, as you suggested, and we all know that protein restriction is part of management of pre-dialysis CKD patients. Is there an evidence, strong evidence that which kind of protein, animal protein or plant-based protein is useful for these patients?
Sir, it is a subject of long discussion. But as much as I know and I have read, that animal protein has better assimilability. Its assimilation is easy. As I have told you, the egg white has 100% absorption and assimilation. Plant protein get assimilated and digested only 40%. So you have to give large amount of plant protein if you want to see the NPU score. So a small amount of animal protein will do the same as the large amount of plant protein. This is the one factor. And the second factor for which we are afraid of animal protein is phosphorus content. So some animal proteins which are low in phosphorus can be included in the diet. And the third thing for which we are afraid is acidity. Metabolic acidosis. This can be corrected only by other alkaline diets if too much of animal protein is used. But as I see in my patients, supporting the animal allowance with, protein allowance with a small part of albumin, as in egg white, helps them too much to recover from malnutrition. That I have seen in my practice, sir.
Your comment, sir, Dr. Shah?
So, Tarun, I gave a talk yesterday on plant protein
Yes, sir, you have given
in chronic kidney disease. Thank you, Anita, for giving me that topic, because it's important in our country where large majority of people are more vegetarians. Even if they are non, their food intake is more of vegetarian than non-vegetarian. And if you look at theoretically, there is an advantage of plant-based protein, because what causes progression of kidney disease is glomerular hyperfiltration. And studies have shown that plant protein causes less of glomerular hyperfiltration than animal protein. The biochemical changes, the phosphorus load with plant-based protein is less than with animal protein. The sodium load is less. The fiber content is more. So putting all these things together, theoretically, plant-based protein would be preferable in patients with chronic kidney disease. And there was a study which I showed, which looked at, this was a survey. In United States, they have National Health and Nutritional Survey, where they looked at about more than 1,000 people with glomerular filtration less than 60 ml per minute. And they looked at consumption of protein and the type of protein. So those who had a relatively higher plant-based protein intake had a slower rate of progression of kidney disease and lower all-cause mortality. So when the ratio of plant protein to total protein was more, there was a lower all-cause mortality in those subjects. So this is what I reviewed. Actually, in our country, we have a bigger potential to study this.
Yeah, because these are all observational studies. We should design a prospective study where we can compare. My another question was, it was both for pre-dialysis and dialysis patients. See, the KDOKI 2020 guideline also says the patient should take lots of vegetables and fruits to decrease the acid production, net acid production.
That is alkaline.
Summer are the months where patients are actually very angry, because lots of fruits, melons and mangoes and all these come in, and we tell them not to take them. How to manage, especially for diabetes, where there are further more restrictions? So both in pre-dialysis and dialysis patients, how should we manage it?
Ipsita, would you like to comment?
Actually,
I think there's a net problem.
Can you please repeat the question?
Yes,
because
sir.
it just freezed.
Tarun, can you repeat the question for Ipsita?
My net actually some disturbance was there. It freeze totally.
Okay, Zamrud, would you want to add on what Tarun said?
So basically, when we are talking of the fruit portions, we are not restricting all fruits for all patients. Even for diabetics today, we are recommending taking, but the portion sizes needs to be controlled. And again, fortunately, all patients of chronic kidney disease do not have a challenge of potassium. So we can recommend using of these fruits. And today, if you see our new IFCT, the guidelines have for us for nutritionists also have changed. Now today there are certain varieties of mango which are low potassium. So probably you can use those foods to these CKD patients who even have a potassium challenge. Melons can be used, but the portion sizes needs to be controlled. That's important, and they can definitely enjoy. And probably one thing that we can recommend when it comes to vegetables is to leach vegetables and use. Yeah, there would be losses of water soluble vitamins and minerals, but probably for the time being when we are doing the leaching process to incorporate more variety to the diet, probably we can give them a B complex or a multivitamin, ask the nephrologist to add that one tablet, and we can definitely allow them to use the variety. Because I am sure that the more the variety, the better the nutrient intake of the person, the better the you're giving the seasonal available fruits and vegetables. So the nutrients gets, the diet diversity scores become better, and definitely the patient gets better nutrition.
Yes. Any more comments, questions? Tarun? Tarun, are you there?
Yes, sir, he's joined, sir, he's there. But I think it must be just connecting.
Okay. I'm sure there must be some comment from you, Anita.
So I'd like you to, there was one of the presenters who were talking about anuric patients taking 1 liter of fluid. So I'd like you to please, so that there is no confusion about it. So a patient is anuric and you're giving a liter of fluid to the patient, definitely, it's not a very healthy thing for the patient. So I'd like you to expand on this and on how much fluid the patient should be given.
Tarun, you would want to respond?
Sir, actually, I lost my connectivity. I didn't get the entire. So how much fluid? Is that the question for a CKD patient?
Yeah. Actually, we just want that there should be clarity that when the patient is anuric, you have to restrict fluid, and to what extent is the fluid requirement? Because if you give, say, a liter fluid liter of fluid to an anuric patient, then it's going to puff up. So how do you how would you advise the dietitians to go about the fluid? Actually, this is something that the clinician should be deciding how much fluid the patient is taking. But if supposing a patient asks a dietitian, how should she handle it?
Yeah, so my take is usually for an anuric patient on dialysis, I suggest them to restrict water to 750 to a liter. But then it depends on individual patient as well, how they are behaving. Somebody who has got a poor cardiac function and is likely to go into heart failures with higher salt and water intake, then definitely will have to restrict more. And more important is salt restriction rather than just a fluid, because if they keep on taking lots of salt, water is going to tie up with the salt as well. So 750 to a liter for an anuric patient with restricted salt and individualized depending upon their intake. And then obviously in summer months, I go a little liberal, tell them to take 250 more because they are very thirsty at that time. And I would take Dr. Shah's opinion as well.
So Anita, it's very difficult to ensure good nutrition when you have a very restricted diet, including restriction on the fluids. So if it is possible, the main factor for most of our patients is the affordability. So if affordability is not a problem, I tell all my patients to get dialyzed at least 3 times in a week. When they are on peritoneal dialysis, it is not a big problem. We can achieve a good negative ultrafiltration and the liquid intake can be liberal. But even in hemodialysis patients, when they are on dialysis 3 times in a week, I do not see much of a problem of lot of interdialytic weight gain when they are allowed 1 to 1.5 liters of fluid. Because eventually we want to ensure that the nutrition does not suffer.
So wouldn't you like to, adhere to the basics that probably are that it is previous 24 hours urine output plus 500 ml. Is this not the basic fundamental
not
that has to be followed
who are on dialysis, because you remove whatever is the weight gain during dialysis. So for dialysis, that principle does not apply of urine output plus 500 ml.
Okay.
Right, Tarun?
Yeah, I agree with you. I mean, we can remove both. Ultrafiltration has to be taken into account while advising for fluid intake, both in PD and HD.
Yeah, PD though there's hardly any problem because PD is like making urine every day. But for patients, because in our center, not every patient is on thrice weekly dialysis because of financial constraints. Only when our patients have this uncontrolled hypertension that we push them towards thrice a weekly dialysis. Otherwise, they are usually on twice weekly dialysis, and that's when we expect our patients to be following the rule that, well, it's previous 24 hours urine output plus 500 ml if they're not animators.
So Anita, if they take 1 liter of liquid in a day, if they are not dialyzed for 2 days, they will be in positive of 2 liters. 1 liter will be insensible loss, 500 ml per day.
Yeah.
So their net positive balance would be about 1 liter, which can be managed on dialysis on the 3rd day.
The main problem that you encounter is that patients are not very compliant. So you'll have to be very careful. If you allow them too liberal amounts of fluids, they take it further. You see, if you tell them a liter, they will go up to 1500. So that's the usual story. And if you're in a situation where you're not able to dialyze patients too frequently for whatever reason, then you get to a problem. So that's the only reason why you have to be a little more rigid and strict with the patients, because they're usually non-compliant. Usually, most of them.
Yeah. Sir, I have a few questions, but before that, if you agree, there are some questions from the panelists from the question answer chat box. Shall we take that, because that is more important? They're participating.
Yeah.
Shall I read the question? Yeah. So what this question is to both doctors as well as Dr. Ipshita. Can you clarify about the bone mineral management in PD and HD? What kind of supplements of vitamin D, and do you give any other thing for parathormone management? This is a question from the audience.
For vitamin D and parathormone management, being a dietitian, I'm not supposed to prescribe any medications. So medical management we do not do, and we do not prescribe any medicine basically. So this is not not under my purview.
That's okay. That's okay. Sir, you want to take that question as a clinician?
So what we normally do is, we know all these patients are deficient in active vitamin D. So we give them active vitamin D to correct the calcium. We correct the phosphorus with phosphate binders. And when after this, if their PTH level remains high, then what we desire a level of up to 300. Then we put them on sinacalcet to control their parathyroid hormone levels. Is there anything different that
I think you're right. The most important thing which can be managed through that is phosphorus, and phosphorus is the leading abnormality which leads to mineral bone disease as well as increase in PTH. So phosphate balance can be somewhat attempted by dietary management, and that can roll in. And then, as you rightly said, medicines will be required, both as a phosphate binder or maybe sinacalcet or even active vitamin D for suppression of PTH. There was another question. I don't know whether this is applicable. It should be applicable. The question is, again, my question is that what should be the practical protein intake in hepatorenal syndrome in cirrhotics? Protein intake in HRS, hepatorenal syndrome. This is from the audience again. Any dietitian would like to take it?
So hepatorenal syndrome, probably we will normally give the protein requirement would be between 0.8 to 1 gram per kilogram body weight is what we can normally calculate. Do not go for a very high protein. Yeah.
It is more like a ARF type of condition when hepatorenal syndrome is there. So usually 0.8 gram is good for this type of patients. Too much protein restriction will not help in healing of liver cells.
Do we have more time for
Sameer Mahindra there? Sameer can put in a word. He's a gastroenterologist.
Yeah, Sameer. Yeah, Dr. Sameer, there you are. Hi, Dr. Sameer, can you put in some words? Hepatorenal syndrome, how would you like us to treat?
You're muted, sir.
Please unmute yourself.
Yeah, hepatorenal syndrome. What are you talking specifically about hepatorenal syndrome?
Yeah, protein intake in hepatorenal syndrome.
Hello.
Very specific question. Yeah, protein intake in hepatorenal syndrome.
Protein intake in absence of encephalopathy, it has to be 0.75 to 1 gram per kilogram. There is no need of restricting protein with no encephalopathy. If there is presence of encephalopathy, overt encephalopathy, then we need to restrict protein. Otherwise, there is no indication of restricting protein. We generally give 1 gram per kg per day.
Right.
We do.
So a couple of questions, comments about PD. See, when we calculate the calorie intake, we should also attribute that from the dextrose-based PD solution, patients absorb lots of calories. For example, if they are doing 3 exchanges of 2.5%, they might be absorbing about 50 calories per liter. That means 300 calories. So that should also be taken into account. Since Dr. Amit Gupta is also there, many of our, not all, but many of our PD patients, they complain that they have this sense of fullness. And even when they are hungry, they are not able to eat. So how do we manage this problem of PD patients?
That's a huge challenge, and I'm sure that you're also faced with the same thing as most of us are. So probably you have to make them eat while they have drained out and before they fill in the next bag. So that's one solution. And because dextrose as such it creates satiety, the glucose in the bag creates satiety. So I think that what the advice that I give these patients is that you eat after you've drained out, finish your meal, and then you can drain in again.
Yeah, Dr. Shah, your comment? Any comments on this?
No, I think you and Amit are the ones who do a lot more PD and see a lot more cases. So you would be the best to answer this.
Another very important point, sir, which Zamrud did mention is that especially in children, childhood nephrotic syndrome, salt restriction should be practiced only till they are in relapse or they are in proteinuria. Once they achieve remission, I think immediately by 11 to 15 days, they usually get remission. The salt restriction should not be continued because otherwise children do not eat at all. Zamrud, do you agree with that? You did mention this.
Yes, very true. Yeah, it's very important because this is one restriction which actually does not give them that appetite only. Though we use substitutes, we are working with them for other things, but still the appetite does not come to normal. So that really helps them. True.
One problem that many of us face is the problem of flatulence. Many of your patients complain of flatulence, abdominal bloating. So we have Professor Ghoshal with us, who's done a lot of work on gastrointestinal motility, luminal. So whether he can put in a word about how to deal with flatulence in patients with CKD, in patients of CKD or on those on dialysis, because they say they're not able to eat.
You see, a lot of time, the flatulence problem may occur because of small intestinal bacterial overgrowth. So typically, we tend to check for small intestinal bacterial overgrowth. We use a glucose hydrogen breath test. Also, flatulence may be diet related. By diet, I mean that there are ingredients in the food which are called high FODMAP food. High FODMAP stand for fermentable, oligo, di, monosaccharide, and polyol. So these high FODMAP food are responsible for flatulence. So therefore, we suggest to these patients that they should avoid excess of high FODMAP food. Interestingly, all the non-vegetarian foods are low in FODMAP, and complex carbohydrates are the ones which are high in FODMAP. And third thing is that some drugs, if the patient is already on, the drugs can lead to flatulence. The examples are if a patient is getting lactulose, if he is getting isabgula husk, they cause flatulence. We have seen that a lot of physicians prescribe too much PPI, and people think PPI is the medicine for gas. PPI is not the medicine for gas, rather PPI causes generation of more gas. So if the patient is on PPI, particularly high dose, and even sometimes we have seen multiple PPI being used, so stop those. These are the three methods.
Over to you, sir, Dr. Shah.
So, Professor Uday, if someone is complaining of flatulence and they are on PPI, would it be helpful to stop the PPI? Would charcoal tablets help them? What will help them?
Charcoal doesn't really help, I tell you, though conventionally speaking, people think charcoal absorbs gas, but truly speaking, it doesn't really happen. So what happens is if somebody is on PPI, I'll review the indication for PPI. If the PPI was absolutely necessary, yes, we'll give. But I'll tell you, PPI is more often misused rather than used rightly. Now, if somebody did not have indication for PPI, I'll stop PPI. But to reduce flatulence, I will prescribe either a probiotic or antibiotic. By antibiotic, I mean rifaximin, 550 milligram thrice daily for about 10 days. But if those who have very mild problem and you are very skeptic about using antibiotic, there I would say probiotic, reduction of dietary FODMAP, and removal of the offending drugs may help.
Okay. Okay. Fine. Do we have more time or we move to the
No,
next?
sir, we are over time. We are over our time we have.
Okay. So we bring this session to an end. Thank you all the participants for your wonderful presentation.
I also thank Dr. Anita, all the speakers, and my co-panelist, Dr. Bharat Shah, for this opportunity. Thank you very much.
Thank you very much.
You are muted, Dr. Anita Saxena. You are muted.
You're on mute.
Okay. Thank you very much, Dr. Tarun Jaloka, Dr. Bharat Shah, and I'm sure Dr. Anita Jitana must have joined. I don't know what happened, but anyway, and thank you all the speakers and particularly our experts, the gastroenterologists, who have really given us a very good insight into the way things have to be tackled. So now we move on to the last session of the day, that is post-renal transplant management of our patients. So in this, for this, I invite Dr. Ghoshal, UC Ghoshal, to moderate the session. Dr. Ghoshal is a professor in the Department of Gastroenterology in our institute, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And along with him is our very dear friend, Dr. Samir, who is also a gastroenterologist. So, sir, over to you now for the proceedings.
Yeah, thank you, Dr. Anita. It is nice to moderate this session at the end. I know people are very tired, but still we'll try to make the session interesting. Dr. Samir Mahindra, who has been already introduced, is professor of gastroenterology at SGPGI Lucknow, will be talking of management of diarrhea in post-renal transplant patient. Dr. Samir, please. And we have 20 minutes for this session.
Yeah. Thank you, Professor Ghoshal, for a kind introduction. Can you see my slides?
Not yet. Not yet. You see it again.
Can you see my slides now?
Yeah, yes, we can see.
Can you see my PowerPoint? Full screen. Can you see the PowerPoint presentation?
Yes, sir.
Yes, sir. Just go to the full screen mode.
Just put it on the PowerPoint, show and present.
Yeah, I'll do that. First of all, I want to thank the organizing committee for giving me a chance to be a part of this important meeting. It's always a pleasure to work with nephrologists because we interact with them very often on different issues. And the topic given to me today is a very relevant topic where we interact with the nephrologist very often, that is post-transplant diarrhea. Now, diarrhea is seen in approximately 20 to 50% patients with solid organ transplant, and whatever data we have from India, it's approximately seen in 60% patients. And diarrhea may predispose to adverse effect of drugs. It can lead to opportunistic infections. It can lead to malignancy and possible graft dysfunction with increased mortality. Post-renal transplant are, pardon? Can you hear me?
Dr. Samir, continue. Dr. Samir,
Post-renal
and I'll request everybody to mute except the speaker.
Post-renal transplant patients are generally immunosuppressed, and they are generally having polypharmacy. Mainly, we are concerned about broad spectrum antibiotics. And to define diarrhea, which has been a major problem in various studies related to post-renal transplant diarrhea, has been definition of diarrhea. Now everybody uses the WHO definition, that is acute diarrhea is up to 14 days, persistent diarrhea beyond 14 days, and chronic diarrhea, which is beyond 1 month. This should be very clear. Post-renal transplant diarrhea has been a neglected entity so far. And if you look at the data available, cumulative incidence has been 11.5% at 1 year, rising to 22.6 at 3 years. And different clinical trials have shown frequency around 9 to 33%. And there was a very interesting study published in, I think, 2007. It's the Scandinavian Renal Transplant Recipient Questionnaire, where they looked at the reporting of diarrhea, and they sent the questionnaire both to doctor, the treating physician, and the patient. And there was huge discrepancy between reporting of diarrhea. 53% patient felt they had diarrhea, and only 7% felt that they had diarrhea. So there has been an element of kind of, clear definition about diarrhea. People don't take it seriously, and that is one of the reasons why there have been problems with the study on this topic. And it's not only for diarrhea. Other GI companies also had similar picture. This was a very interesting data which we had, which I mentioned that in 1 year, 2 years, and 3 years. But what was more important in this data was then when the diarrhea was caused by non-infectious unspecified cause, the rate of graft failure and patient death related was almost double. And if it was an infection which was not specified, it was 1.5 times. So whether you have non-infectious cause for diarrhea or infectious cause of diarrhea, these patients are more prone to graft failure and increased mortality. This was another study which looked at prolonged diarrhea. Prolonged diarrhea, they meant, was beyond 1 month. And what they looked at was relationship of rise in serum creatinine with cause of diarrhea and duration of diarrhea. And what you can see is that when the cause was infectious, the rise in serum creatinine was much higher as compared to a non-infectious cause. And when the duration of diarrhea was more than 10 days, these patients had more renal derangement and possible graft failure. So it is very important that any diarrhea which comes, it has to be tackled quickly, because prolonged diarrhea can lead to significant morbidity in these patients. Now, the impact of post-transplant diarrhea is very variable. It is multifaceted. It can lead to dehydration, weight loss, steatorrhea, malabsorption, and certain unique complications seen in subsort of patients like enteric hyperoxaluria, which leads to oxalate nephropathy and possible graft failure. Quality of life is definitely affected. There have been many studies, and there are increased incidence of drug toxicities. And ultimately, there is increase of graft rejection and possible mortality. This is a South Korean study published in 2019 in nephrology, which looked at patients who had diarrhea and patients who did not have diarrhea, the incidence of graft rejection. And you can see that there was significant higher rate of graft rejection in patients with persistent diarrhea. So persistent diarrhea is associated with significant graft failure and possible increased mortality. This slide it shows basically the effect of post-transplant diarrhea, which I've mentioned. and it includes increased graft loss and mortality. Now, coming to etiology, etiology is multifactorial. We can have infectious cause, which can have non-infectious cause. And among the infections, it can be bacterial, like Clostridium difficile and Campylobacter salmonella, which are relatively common, along with small intestinal bacterial overgrowth, which is coming up as a very important cause of diarrhea in these patients. Viruses, CMV is a known virus, and norovirus or Norwalk-like virus is coming up as a very important cause of chronic diarrhea in these patients, which we need to keep in mind. Among parasites, if you look at Western data, the spectrum is different, but if you look at data from our country and Pakistan, Giardia and Cryptosporidium are very important causes of diarrhea in these patients. Among non-infectious causes, we have immunosuppressive medication, which we all know, mycophenolate, tacrolimus, and even sirolimus. And what is most important in this slide is non-immunosuppressive medication, which includes not only antibiotics, but we have other drugs like antidiabetics, laxatives, PPI, which can lead to diarrhea. We need to look at these medications, and therefore a detailed drug history is very important in these patients. This slide shows Western data which show the etiology. If you look at this, there's an 18-month single center study over 500 patients, and both hospital-acquired and community-acquired diarrhea. Approximately 1/3 of the patients had infectious cause, and remaining 2/3 had a non-infectious cause. And if you look at Indian data, there's a most recent retrospective study from Bombay, published in Indian Journal of Gastroenterology 2020, which looked at acute diarrhea. Mean duration of diarrhea was 3 to 4 days. They had 47 patients with 64 episodes. Approximately 50% were attributed to infections, and 82% had graft dysfunction during the diarrheal episodes. And mean increase in serum creatinine was much higher in non-infectious causes of diarrhea as compared to infectious. But good thing was the resolution of acute diarrhea happened in majority of the patients within 3 days, and return to pre-diarrhea serum creatinine was achieved in 87% patients at 3 months. So if we tackle acute diarrhea, we can salvage many of these patients without causing significant chronic morbidity. Now, there are different causes of diarrhea, but what we need to look at is the spectrum of infection. Infection generally comes into picture beyond 3 months post-transplant, majority of these cases. In the first 3 months, non-infectious causes are the common cause of diarrhea, and which basically means drugs. And beyond 3 to 6 months, the infection takes over. And if you look at the spectrum, if you look at 6 months, common infections are viruses and Clostridium difficile and Cryptosporidia. But when you go beyond 6 months, most of the infections are community acquired, and they include Campylobacter, Salmonella, Enteropathogenic E. coli, and small intestinal bacterial growth. So this timeline is very important because it gives us an idea that what kind of infection are the possible etiologies in a subset of patients who come to us. Now, if you look at the different organisms, this slide is important because it tells you the timeline, that is the interval post-transplant. For example, Clostridium difficile, it generally occurs within first 6 months of post-renal transplant. Bacterial overgrowth, incidence is seen more frequently, and it generally happens beyond 6 months. If you look at parasite, Cryptosporidia generally also happens within first 1 to 6 months, and incidence in our subcontinent is much higher, both from India and Pakistan, which I'll discuss. And norovirus or Norwalk-like virus is a very important cause of chronic diarrhea, and generally it happens beyond 12 months post-renal transplant. So this timeline gives us an idea what kind of infection we are dealing with. This is the Western data. If you look at diarrhea of infective urine, overall wide prevalence 38 to 77%. In India, experience having between 50 to 70%. And the etiology depends upon from where we are getting the data, developing versus developed world. And there is a significant difference in the spectrum. For infections, standard microbiological assays, unfortunately, has got a low yield around 20 to 30%. But fortunately, with newer molecular techniques, multiplex PCR, we have got very good yield in evaluation of these patients. This is the data from our center, Dr. Dharmendra Badoria study, which looked at post-transplant diarrhea coming to hospital for admission, and approximately 10% renal transplant recipient developed diarrhea. And if you look at the spectrum, the commonest organisms were Cryptosporidia and non-Cryptosporidial infection. But equally relevant is that drug-induced diarrhea was seen in approximately 30% cases. So it's a combination of infection and non-infectious causes which we need to keep in mind while evaluating these patients. This is a recent Pakistani study from Karachi, Sindh Transplant Center, which what I want to pay attention is the spectrum. The most two common infections were Giardia and Cryptosporidia, and followed by Entamoeba. So the spectrum is a little different in the West as compared to our subcontinent. No talk on this topic is completed without mentioning DADEX study. This was basically an open, non-randomized, multicentric study which looked at non-immunosuppressive factors involved in severe diarrhea. They had 108 patients with severe diarrhea, and they had a very good step-by-step approach to evaluate these patients. And what they looked at is, step one was the stop non-immunosuppressive drugs which can potentially cause diarrhea. So a detailed drug history is very important. Step two was microbiological stool evaluation. Step three was to exclude CMV infection. Step four was to exclude SIBO. Step five was adaptation, that is modification of immunosuppressive therapy, followed by colonoscopy and then empirical therapy. And this, on the left-hand side, you can see the various drugs which can cause diarrhea are mentioned, but this is not the complete list. We need to have a more detailed drug history so as to find any drug which can cause diarrhea. Stool examination, cultures, stains for acid-vast bacteria, for ovacyst, and possible Clostridium difficile toxin if the patient comes early post-transplant. Screening for viruses if available, and CO was excluded by hydrogen breath test, and colonoscopy with mucosal biopsies were taken even when endoscopy was normal, and empirical therapy with antidiarrheals, dietary modification, or probiotics were attempted in a subset of patients who did not give a diagnostic yield on the previous steps. This was a very nicely done study, and on the left-hand side, what you can see is when they looked at the drugs, immunosuppressive drugs, where they needed modification or stoppage, MMF, as expected, was the incriminating agent in majority of these patients, and 2/3 of these patients responded to reduction or stoppage of mycophenolate. And tacrolimus was another important cause, which was responsible for approximately 50%. And what basically it shows is that if you see on the right side, this is the algorithmic approach, step-by-step approach, which helped them to find the etiology in almost 90 patients after 180 patients, and approximately 28 patients they couldn't find an etiology. They gave empirical modification in diet, probiotic, and only 17 out of 108 patients, they could not find a diagnosis, they could not stop the diarrhea. So this is a very important study. It shows that how we should go about evaluating these patients. The only problem with this study is that if there is a multifactorial diarrhea, then it's a problem. But what we can do is we can take steps 1, 2, 3, 1 go. If it doesn't work, step 4, 5, 6. So it basically guides on how to evaluate these patients. And the importance of this study was that changing immunosuppressive should be clear. It should not be the first step these patients come with diarrhea. That should be the last step, because changing immunosuppressive can lead to increased graft failure and possible mortality. Now, there are two types of tests we can do. We can do a classical microbiological technique test or molecular test or multiplex PCR. Multiplex PCR are much better now. They are much more rapid. Their range of microorganism detection is much higher. And even if low level of microorganisms are there, they can be easily picked up. This is a study recently published in Journal of Microbiology where they looked at classical techniques versus molecular technique. Molecular techniques scored highly over classical techniques. So now that is the standard of investigation in these patients wherever facilities are available. These are 3 assays which I have mentioned, and Luminix X-tag is the method which we use especially for Norwalk virus, the norovirus, and which has got a very good diagnostic yield of more than 90%. Coming to effect of immunosuppressive agents, we all know which are the common drugs: tacrolimus, cyclosporin, and possibly steroids, mycophenolate, and they can have variable presentation. And these are the endoscopy pictures which show MMF-induced hyperemia, superficial erosions. If we take biopsy, we find some mucosal infiltration with plasma cells and neutrophils. I'm sorry for the slide, but I mentioned the drugs. Now, there are certain things which we need to remember about immunosuppressive agent-related diarrhea. They are not uncommon. Highest incidence seen with MMF, relative risk is 1.57. The histology may mimic Crohn's disease with predominantly cryptitis, crypt distortion, or predominantly graft versus host disease with predominant apoptosis. Tacrolimus and sirolimus causes milder kind of diarrhea, which are most of the time self-limiting. There's another picture which shows superficial aphthous ulcers and Crohn's-like ulcers in patients with MF-induced colitis. Now, as being a gastroenterologist, we get reference for endoscopy in these patients. And the question asked is, do we need an endoscopy? Now, there are various logics to do endoscopy. Sometimes what we find is severe duodenal villus atrophy. We don't know the etiology. But then these are the patients where we need to think about modification of our immunosuppressive regimens. And sometimes what happens is CMV colitis is there, but the PCR in serum is negative, which happens in 20% cases. So sometimes the biopsies help. And even endoscopic picture can give an idea. In post-transplant, renal transplant, de novo inflammatory bowel disease is 10 times more common. And occasionally you find conditions like large bowel post-transplant lymphoproliferative disorder, which can be picked up on endoscopy with biopsies. Endoscopy has got a role. This is a study from, again, Dr. Dharmendra Bhadoria group, where they looked at patients who had serology negative, strong clinical suspicion of CMV. They did endoscopy in 6 patients. There were no lesions. We took random biopsies, and they turned out to be positive. So where a clinical suspicion is high, we need to have a low threshold for doing endoscopy. This is a study recently published in Aging 2020, where they looked at the colonoscopy data on 34 patients. Diarrhea and GI bleed were the commonest cause. And if you see, adenoma was found in approximately 20% and colitis was seen in 14%. MF colitis was the commonest cause. So what I personally feel is, if you have a persistent refractory diarrhea and if you have other GI symptoms which are not responding to conventional therapy, then there should be a low threshold for endoscopy. This is again a Pakistani study from the same center, Karachi Transplant Center. If you look at this data, diarrhea, weight loss were the commonest indication of doing endoscopy. And if you look at endoscopy findings, in upper GI endoscopy, 2/3 of the patient had finding in stomach, duodenum, and colon. And CMV colitis was the most common cause in the lower GI, and giardiasis was the most common cause on upper GI endoscopy. So symptoms should decide whether endoscopy is indicated or not. Coming to individual infections, Clostridium difficile, one of the very common cause, most common cause of nosocomial diarrhea. Spectrum varies. Generally happens early post-transplant. Main risk factor is risk in gut microbiota, that is antibiotic use. Gold standard is cell-based cytotoxicity, but enzyme immunoassay has come up as a very reasonable alternative, which is rapid and quite sensitive and specific. And complications are known, but the most important thing about Clostridium difficile is relapse. Relapse is seen in 33% cases. And we have now therapy for these patients, but sometimes these infections can be persistent or relapsing, which can be a problem. Role of FMT and monoclonal antibody against the toxins is promising, but not enough data on immunosuppressed patients like post-renal transplant is available, but they are appearing to be promising mode of therapy in refractory cases. CMV, 5 to 20% post-transplant, generally happens at 3 to 6 months time frame. And risk factors are seronegative recipients of seropositive organs. And we have effective therapy in the form of oral valganciclovir or IV valganciclovir in patients who have severe disease or who have symptoms like nausea, vomiting, which doesn't allow them to take oral medication, or patients who are not responding to oral valgan. And immunosuppression is the main thing which has to be done. And biopsy shows CMV antigen on immunoperoxidase staining. Different modalities, now conventional PCR and real-time PCR and CMV-PP 65 antigen are the test of choice. Biopsy is positive in approximately 1/4. If we get the typical owl-eye internuclear inclusions, we are lucky, but you can't rely only on biopsy. We need to have PCR to make diagnosis of CMV. Small intestinal overgrowth, Dr. Ghoshal was discussing just now. It is coming up as an important cause. Approximately 10 to 12% patient of post-transplant diarrhea generally happens after 6 months. And what we need to look at is that we have effective therapy for it. We can give rifaximin for 10 to 14 days, and most of the time patients become all right. So you should have a low threshold for looking for small intestinal bacterial overgrowth, as shown also in that study. Norwalk or norovirus is a very important cause. We need to pay attention. Approximately 20% of severe post-transplant diarrhea, it generally happens 1 year post-transplant. And approximately 94% of chronic diarrhea and 80% of episodes of diarrhea-induced acute renal failure with graft rejection. It has got a very typical biphasic illness, typical acute diarrhea-like illness with chronic phase with intermittent symptoms. And what is more important is long-term viral shedding is very common in this. And a lot of these patients were initially suspected to be MMF-related diarrhea, but now it appears that they were related to norovirus and not MMF. We don't have specific therapy for it. It's basically reduction of immunosuppression, which works. We have now multiplex test, that is multiplex X-TAC GPP, which is very effective, can be used, and diagnosis is very good. Sensitivity and specificity is more than 9%. Cryptosporidia, we have data from our center also. Generally happens 1 month post liver transplant, post renal transplant, and conventionally visualization of oocyst in the stool was considered, but not very sensitive. Now we have immunofluorescent assays and ELISA to pick up cryptosporidia infection. And what this study from our center showed that 12 out of 34 patients had acute graft rejection, mainly caused by TAC toxicity and dehydration in patients who were cryptosporidium positive. So a combination of TAC toxicity and cryptosporidium can be potentially lethal. We need to be very careful. A little bit about dysbiosis of gut microbiome. It's a very promising area to work in, and there have been a recent study with in clinical medicine which looked at the microbiome composition of renal transplant recipient with healthy controls, and what they found on Shannon diversity index was their renal transplant recipient had lower diversity of gut microbe, and use of MMF was related to a lower diversity. So what we need to look at, the gut microbiota of these patients is different, and there is lower diversity. So a lot of work is going on, and I'm very sure that this is going to come as a very big thing in these patients, especially who are affected with infections. Post-transplant lymphoproliferative disorder, very uncommon as a cause of diarrhea, generally present with bleed and obstruction or perforation. And we need a biopsy for a definite diagnosis, and reduction of immunosuppression and possibly use of rituximab is the treatment. This is a slide which shows the therapy for different infections. We all know that. And this is my last slide, which tells you about the algorithm. When a patient comes with post-transplant diarrhea, first we need to look at non-immunosuppressive drugs causing diarrhea. Then we need to look at conventional stool testing. That is basically, we look at stool routine, we look at stool lactoferrin.
Dr. Samir, your time is up.
Yeah. And sorry, sir, but 2 minutes more. Last slide. We need to work for malabsorption. We need to look for stool in small intestinal bacterial overgrowth and using multiplex PCR. And then if we find something, fine. If there is no pathogen, fine, then we go for the symptomatic treatment. And if we find specific cause like CMV, then we have therapy for it. And if there is significant weight loss, GI bleed, or significant malabsorption, then endoscopy definitely is warranted. My take-home messages are diarrhea in transplant recipient is common and can lead to significant morbidity. Physician should be familiar with common causes which leads to post-transplant diarrhea. Diagnosis is imperative to prevent adverse events. And most importantly, step-by approach to the diagnosis of these patients is always required. Now we have newer tests which have got very high sensitivity and specificity to pick up infections, and modification of immunosuppressants should be justifiable. And why I show this graph on the right hand side is this is 2007 data. The first thing physician used to do was to reduce the immunosuppressant dose, which should not be done. We need to look at other causes of diarrhea in these patients before thinking of meddling with immunosuppressive drugs. And of course, local data is essential to get more information in our patients. Thank you.
Thank you. So since time is already up, we'll go to the next topic. And at the end, if time permits, maybe 1 or 2 questions even on this topic. I think the organizer agrees to this plan. The next topic is follow-up and nutritional advice for VKD by Dr. Manas Patel. Dr. Manas Patel is assistant professor in the Department of Nephrology in our own institute. Dr. Manas, please. Dr. Manas, unmute yourself. I'm sorry, you are associate professor. Great. So unmute and continue.
Yes, sir. Yes. My slides are visible, sir.
Yes, these are visible.
Yes. My topic for discussion is follow-up and nutritional advice for voluntary kidney donors. So when I searched this literature, how to follow up our living voluntary kidney donors and what is the nutritional advice. So initially I thought whether there is some information about that, or it's a new topic, or it's an emerging topic, or especially on the nutritional advice part. So I was astonished that I actually could not get very much literature about what is the nutritional advice we should advise to our kidney donors. So coming to first basics, what happens after donation of a kidney? We know we have two kidneys and one kidney is transplanted to the recipient. So the voluntary donor is left with 50% of the renal mass. So it is akin to any pathological condition in which we do a unilateral nephrectomy. So what happens is the other side kidney undergoes compensatory hypertrophy with increase in GFR of almost 70% in 2 weeks. And as we follow up, like 6 months or 1 year follow up, there is further increase. There is further a little increase occurs to up to 85%. So this donors, though they are normal people by definition, but they have decreased GFR as compared to their previous to donation. So next, coming to what happens in long term. So there are very few studies, and one of the studies, Altold study, assessing long-term outcomes in living donors. This is mainly done in US. So they basically measured the GFR between 6 and 36 months after kidney donation. So what they saw actually is there was a gradual decline in control. Control population was the normal population, mostly from that area. So there was a 0.36 ml decline per year. Whether in comparison, the donors have actually increased the GFR by 1.7 ml per year. So by 3 years, they have increased GFR in comparison to their controls. So what happens to this increase in GFR after 36 months remains unknown. So whether this is a physiological increase in GFR or it is a adaptive mechanism, what we nephrologists call as hyperfiltration, we still don't know. So, and we have to keep in mind that in general population, GFR declines with age. Mostly after 40 and 45 years, our GFR declines about 1 to 1.2 ml per year. So, and it varies across individuals. Like in African Americans and in Caucasians, the decline is more rapider than in whites. Also, the decline is more rapid in males in compared to females. So this we have to keep in mind. Initial 3 months, initial 33 years, it is okay. It increases. After that, what happens, we still don't know. Next, and if we compare kidney donors versus matched or unmatched general population of that demography with the same race or like same gender composition, we see that overall survival is similar between the same population and between the donors. What about cardiovascular? Some studies have seen that they have actually less cardiovascular mortality in comparison to their population, and some studies have seen that cardiovascular mortalities are about the same. This may be due to a selection bias, but still this is the what evidence says. What we see, if we see the finer details, there is increase in left ventricular mass, decrease in aortic distensibility, there is increased incidence and severity of hypertension, there is increase in baseline troponin T levels, and there is increase in baseline albuminuria in kidney donors. So, but this is not translating in all studies to increased cardiovascular mortality. Some studies even have shown decreased cardiac mortality. But these are mostly like 5 years or 7 years follow-up, not beyond. So what happens after 7 years or 10 years or 20 years, say, it is still difficult to say. There is no evidence about that. Coming to whether these voluntary kidney donors are at increased risk of renal diseases themselves. So there is a definite increase of relative risk of about 8 times, but absolute risk is very less. So it is similar to the general population, that is 0.5 in 1,000 person years. So we can say that there is a little absolute increase in incidence of end-stage renal disease in voluntary kidney donors, but the absolute increase is nearly similar to the general population. There is some evidence also that these donors are at increased risk of gout. This may be related to decreased excretion of uric acid due to lower GFR as compared to their normal population. In females specifically, they have poorer maternal and fetal outcomes in almost all the 4 studies which were done on pregnancies which happened after kidney donation. So there is increased incidence of gestational hypertension and preeclampsia. There is increased incidence of gestational diabetes. There is increased incidence of fetal loss also. So these are the outcomes. These are the not very long-term outcomes, but short-term outcomes. This is the evidence. Now coming to high-risk groups. So whether all kidney donors are subjected to this outcomes, or there is a subgroup which are more likely to have these outcomes. So we call them as marginal donors, like they are borderline donors because there is no other donors available in the family. We consider despite knowing that they are not the ideal candidates for donation, still somehow in some countries or even in India, we accept them. That is older age donation, lower GFR at donation, if they are former smokers or even smoking currently, and they have presence of microalbuminuria. They have some controlled hypertension, because uncontrolled hypertension they cannot donate. Diabetes in some countries, even controlled diabetes is they are allowed to donate kidneys, and pre-diabetes. African American in United States, there is a lot of studies on African Americans. They are at increased risk of developing end-stage renal disease after donation. It is specifically associated with high-risk alleles of APOL1 gene and females. So these are the high-risk groups. These are the high-risk groups in voluntary kidney donors. We need to follow them, and we need to intervene them if some hypertension or albuminuria or there is decreased in GFR, or they turn out to be a chronic kidney disease. Now, how to follow up? So the basic principles are identification of individual donor clinical problems through surveillance. We have to actively follow them. Prevention of diseases that may cause CKD, hypertension, diabetes mellitus, cardiovascular disease, because they are the part of population, they have their incident risk factors, and even after donation, they have their incident risk factors. So they are even prone as in general population. And low GFR, if that is meeting in the diagnosis of chronic kidney disease, which is used for the general population or any patient, it should be staged as CKD and it managed according to the stage. Now, the initial guidelines, first guidelines about follow-up or management of this voluntary kidney donor scams came in Amsterdam Forum. That is very old 1997 guidelines. As in general, they say, as in general population, based on age and other medical risk factors like hypertension, proteinuria, hyperlipidemia, impaired glucose tolerance test, kidney donors should undergo regular long-term follow-up of body weight, blood pressure, blood glucose, serum creatinine, and urine analysis. But they further does not define how regular, how long, and how frequently and other details. Now next came KDIGO guidelines. This is around in 2007 or 2007 guidelines. In chapter 19, they have written some 4 guidelines to follow up these patients. That is, personalized post-donation care plan should be provided before donation. So they have to be told about these complications, probable complications after donation, and follow-up care recommendation, and how often. So many countries have their own guidelines, and the same things, blood pressure, BMI, creatinine with GFR estimation, albuminuria, and now they add here review and promotion of healthy lifestyle on regular exercise. And obviously it's the psychosocial aspect of donations. Donors should be monitored for CKD, and those meeting the same criteria was included. And donors should receive age-appropriate healthcare maintenance and management of clinical condition according to their clinical regional population. That is obvious thing. So now coming to what countries follow. Obviously, United States has mandatory 2 years post-donation follow-up at 6 months, 1 year, and 2 years, both laboratory and clinical outcomes. And they have now in last 2 years, they are trying to increase it to further 5 years, 10 years, and 15 years. United Kingdom has follow-up of almost up to 15 years. Europe, they have recently in 2015, they have started a consortium which is following this patient. And Swiss have already in their transplant program, they include, they follow up these patients up to 10 years. Coming to management, so again, very little data was, very little evidence was there that how to manage this patient. So basically, these are all expert guidelines, not very evidence-based, and these are extrapolated from the other diseases or from the general population. So overall, there is maintenance of general and kidney health maintenance is important. We have to reinforce healthy lifestyle practices. Most of this has been discussed in the last one day and today, so no need to repeat that. Healthy dietary habits, maintenance of healthy weight, regular aerobic exercise, and avoidance of nephrotoxic exposures like tobacco, NSAIDs, and other drugs. Coming to primary prevention, that is manage the risk factors for kidney disease, lifestyle modification with physical activity, dietary advice. So mostly what I got is avoidance of high sodium. Again, what is high? Nowhere I was able to find. So we can derive this high sodium is more than 3 grams as in general population. Excessive protein intake, again, what is excessive? I could not find specific to this population. So again, maybe this is same for CKD stages 1 or 2, whatever we advise for our patients. Prevent and manage obesity, that is obvious. Improve glycemic control and blood sugar control if they are diabetic. Ensure adequate hydration and identify genetic risk factors. Like in some families, there is familial kidney diseases. So if it is identified, then they have to be managed like that. And coming to second, if some patients, if some donors are staged according to kidneys, CKD stage 1 or stage 2 or stage 3, then basically we have to manage proteinuria by either ACE inhibitors or ARBs or SGLT2 inhibitors. Low sodium and low protein diet. It is almost same management in our diabetic and non-diabetic CKD. More plant-based sources. It was also expert opinion based. No evidence was there. Effective pharmacotherapy like ACE and ARBs, and other additional CKD risk factors has to be managed. So concluding my talk, so in this topic, we have very poor follow-up even in Western countries. The data, some data is there about short-term outcomes in voluntary kidney donors. Long-term data, still fewer data is there. Follow-up recommendation based on expert opinion. They are not graded in most of the guidelines. And nutritional advice probably is an extrapolation from other diseases like diabetes or CKD or overall population. It is not evidence-based. Thank you. Thank you.
Thank you. Now we'll go to the last talk. The last talk is very, very important. Should vegetarianism be the preferred approach to low protein keto analog supplementation? By Dr. K.S. Nayak. Yes, Dr. K.S. Nayak. So, Dr. K.S. Nayak, please. Yeah, you have to unmute. Dr. K.S. Nayak is a senior nephrologist at Virinchi Hospital at Hyderabad. Dr. Nayak, please unmute and start.
Thank you for the kind introduction. Can you see my slide? No?
No, not yet. It is coming. Okay. It is coming. It is coming. Yes, we can see your slide. Just put it in PowerPoint so and start.
Yeah, I know that. Yeah. Okay. This is I'm very happy to be amongst the participants of this 7th advanced course in renal nutrition and metabolism. Mine is a very relevant topic. Should vegetarianism be the preferred dietary approach to keto analog? One moment. Can you hear me?
We can hear you. We can hear you. Please go ahead.
Yeah. So should vegetarianism be the preferred dietary approach to keto analog supplemented diet in chronic kidney disease? Chronic kidney disease is a global health challenge, and diet is the single most CKD-related risk factor for death and disability. So much so that diet is fundamental to nearly every aspect of care in the patient of CKD, right from the early stages and right through the different stages of CKD, and ultimately till they need renal replacement therapy. So much so that medical nutritional therapy plays one of the most important roles in preventing and treating all the comorbidities of chronic kidney disease. The problem, however, is the diet the dietary regimen for chronic kidney disease is one of the most restrictive of any chronic disease. I'll go through my topic in the following sequence. I'll talk about the concept, the benefits, the pitfalls, and talk about vegetarianism and keto analogs, and some take-home messages which you can use in clinical practice. Now, paradoxically, the word vegetarianism is derived from the Latin root vegetor, which actually means give strength and health. And there is a difference you should understand between vegetarianism and veganism. Veganism is a very expensive, so much so that you actually need to pay more to be a vegan. Vegetarian food generally is cheaper than non-vegetarian food. It's a easier source of though mostly not first-class protein, but it's the cheaper protein to eat than the non-vegetarian. But veganism is expensive, and the concept of veganism not only is restricted to eating non-vegetarian food, it's an associated philosophy that rejects the commodity status of animals, and what is popularly known as vegetarian, that aspect is the dietary vegetarians. Additionally, they refrain from consuming animal products such as milk and honey also, which actually are derived from animals. But we vegetarians in India, when we talk about the vegetarian drinking milk and honey is not an issue of being classified as a pure vegetarian. The ethical vegetarian avoids use of animal products for everything, including for fashion products like these mink coats and some such in clothing, which the fashion industry thrives on. And environmental veganism talks about global warming and the cycle of eating more non-vegetarian food and bigger animal farms and cattle producing methane. And you should realize that cattle produces about 80% of the methane that is emitted from the Earth's and into the environment, and causes deficits in the ozone layer and leads to global warming. So more non-veg food, bigger the farms, and it's a cycle. So that is another aspect which the vegans follow. India is predominantly vegetarian, a lacto-vegetarian, not vegan, which means Indians do not consume eggs. And that's a big setback for us. They, however, consume milk, unlike the vegans. And as you can see, almost half of the pure vegetarians live in India. You can see the dark blue coloring here of the country, out of which we have about maybe about 500 million are vegetarians and about 100 million to 150 million are vegans. We have very different types of those who come from the nutrition background will know this. We have the lacto-vegetarians who have milk, ovo-lacto-vegetarians who have egg and milk. Many of lacto-vegetarians, we convert them to ovo-lacto-vegetarians. Ovo-vegetarians who do not drink milk because of probably lactose intolerance, because the lactase is an enzyme which is not there at birth in human beings. And if you stop drinking milk for maybe a year or two, you lose the, you go into milk intolerance. The fruitarians eat the fruits, grains, nuts and fruits without destroying the plant. Pesco-vegetarian, which probably is the best diet to follow, is a vegetarian diet plus fish. Those who are from Bengal, you can see here a very high percentage of non-vegetarian. This is because of eating fish, because fish is considered a vegetable of the sea by most communities in Bengal. Jain vegetarians, they don't even eat anything that grows below the soil because they think they're killing the bacteria. The vegans have already spoken about. The Indian non-vegetarian is a unique category. The true non-vegetarian is the Western non-vegetarian who have non-vegetarian breakfast, lunch, and dinner, whereas the Indian non-vegetarian actually can be classified. They fall better, their dietary pattern, with the vegetarians because they have meat probably once in a week or once in 2 weeks. So their dietary intake, and if you are missing a weekend, you might lose out the fact that they have taken a little bit of non-vegetarian food. Now, Indian chronic kidney disease guidelines were set up in December 2013, and the nutrition in chronic kidney disease, I had the privilege of being associated with Dr. Bharat Shah in developing these guidelines. And at that stage itself, unlike what has come out in 2021, now 2020 actually, the KDOKI NKF guidelines, I'll talk about that in the ensuing slides. We recommended ketone law supplemented diet with regular dietary monitoring, and we had an opinion that a vegetarian who has chronic kidney disease does not have to start eating meat, but they should be under regular dietary monitoring. Also, we suggested that they have small frequent meals and snacks, not 2 to 3 times, but up to 5 to 6 times, minimize dietary restrictions, evaluate drug nutrient interactions like giving iron, calcium binders, they are phosphate binders, calcium supplements, medications for GI symptoms, so give them prokinetics if necessary. And a study done by Behere and Bharat Shah showed that the unrestricted vegetarian diet in a CKD patient was giving quite a good amount of protein. The WHO FAO guideline is 0.5 should be the minimum protein intake per day per kg per day, but unrestricted vegetarian CKD diet is 0.64 plus minus 0.15, which is quite adequate. But if you are restricting proteins, then If you are restricting proteins, then you have to supplement preferably with keto analogs. And the role of dietitians and the innovative recipes is very important. So the dietitians help them by increasing good class, high class vegetarian protein, which tofu, which is actually the cheese made out of milk, tempeh. These are all Far Eastern diets. They have biscuit-like nutrients which actually come from soya beans, then natto, and this is a particular the wheat protein seitan, which actually looks like a non-veg, tastes like non-veg, but actually is made out of wheat. So it's called wheat meat. And then the dietitians can juggle around with nut butter, soy milk, yogurt, and cooked dried beans and beans, unsalted nuts, and milk and dairy products, and somehow ensure that they consume enough proteins. The benefits of vegetarianism. Way back in 1990, in Kidney International, Contesis showed clearly that he fed one group of volunteers for 3 weeks on animal protein, another group on vegetarian protein. The animal-based protein diet increased GFR more than similar amounts of plant-based proteins. You can see the black circles, the dark circles are all the GFR of the animal protein, and these are the vegetable protein. Similarly, the GFR, there was a renal plasma flow was higher, so there was hyperfiltration in the animal protein diet, whereas in contradistinction to the vegetarian protein, where there were lower renal plasma flow. So protein modified rather than protein restricted. This is a very important point. Protein modified rather than protein restricted diet may be advantageous in the long-term management of CKD. Now, ERIC study is one of the landmark studies. It's important, though it's an observational study, there were 12,000 adults with normal renal function at baseline, and they were followed up for 23 years, and a lot of their medical data was collected. About 800 papers came out of this ERIC study, which is atherosclerosis in risk in communities study, and the effect of vegetarian diet on nutritional status and renal function and risk of all-cause mortality in patients with CKD. 2,600 plus patients developed CKD stage 3. The primary endpoint of this study was CKD stage 3 or a decrease accompanied by a decrease of more than 25% from baseline at the 23-year follow-up. So 2,600 patients developed CKD stage 3, and a significantly high risk of CKD in individuals consuming more protein from red and processed meat. The hazard ratio was 1.23, whereas those who were mainly eating vegetarian and dairy source, they had a reduced risk of incident CKD with a hazard ratio of 0.76. It's a very significant difference. And this confirmed that there's an association between development of CKD and the type of dietary protein sources rather than the total protein intake. And this was further validated by the popularly known as NANES study 3, and the Adventist Health Study 2. Adventist, for your information, is an interesting subgroup of Protestants who present a health message that advocates vegetarianism. So these also gave the same conclusions as the ERIC study, but these were surveys and observational studies. So we should only give these studies should be considered carefully by those offering dietary guidance, because they are not randomized controlled trials, so there can be bias creeping in. The other important diet that is now found to be useful is the Plado diet. This has been propounded by my friend Kamyar Kalantarzadeh, who was the president of the International Society of Renal Nutrition, past president. And the Plado diet basically is a plant-dominant low-protein diet, where the plant-dominant source is more than protein source is more than 50%, sometimes up to 70 or 80%. and the total protein is only 0.6 to 0.8. A compliance, it is a patient-centered diet because the patient and the nutritionists interact and decide what is the type of plant source that the patient prefers. This ensures that there is palatability because it's a patient choice, and also not only palatability but also compliance because the patient themselves are choosing it. Sodium is restricted, and the important aspect is there's a high fiber intake up to about 40 grams, a minimum of 25 grams. Energy is minimum 30 to 35 kilocalorie, and they are very regularly, strictly monitored. So what happens is with the plateau diet, you get a constriction of the afferent arteriole. Many of them we use the RAS inhibitors like ARBs and AC inhibitors. So they dilate the efferent arteriole, and then you have a moderately low sodium diet. So there is reduced intraglomerular pressure, reduced GFR, reduced hyperfiltration, a typical what do you call synergism between these three. And I would think that this would work very wonderfully well for especially diseases which are predominantly due to hyperfiltration like diabetic nephropathy, where the progression is 3 times that of chronic interstitial diseases and ADPKD. Now, another important source of benefit from vegetarian diet is the decrease in acid generation, which is definitely higher in the acidogenicity of animal-based diet is very high. How it helps, this cannot be replicated by giving oral bicarbonate. When it comes from the diet, it has better side effects. And this interesting, what do you call, a review article written by Donald Wiesen in JASN in 2020 shows what happens is the metabolic acidosis that happens because in CKD, which is exacerbated by taking a animal source of protein, it stimulates production of intrarenal paracrine hormones, including angiotensin 2, aldosterone, and endothelin-1. It's actually, in the short run, a beneficial effect, and it increases the aciduria. So there is an attempt at correction of metabolic acidosis. But what happens is, on the long run, it sets up a vicious cycle whereby to maintain the aciduria, all these paracrine hormones are upregulated, and because of the continuous aciduria, what happens is interstitial inflammation and fibrosis sets up, and that sets in what is called a vicious cycle. And to break this vicious cycle, we need to have a plant-based diet and reduce the metabolic acidosis. Also, chronic metabolic acidosis stimulates ammoniogenesis, leading to ammonia-induced complement activation and deposition of C3 and C5b9, which is actually membrane attack complex, where 5 monomeric complements get together, and these attack the tubulointerstitial region, producing tubulointerstitial damage and perpetuating renal injury. And prevention of chronic metabolic acidosis by taking a plant-based diet attenuates these adaptive response and slows CKD progression. This is a very, very important explanation how metabolic acidosis produces chronic kidney damage. Numerous studies showing vegetarian diet benefiting hypertensives, the Adventist Health Study 2, numerous meta-analysis, 7 controlled studies, 32 observational studies have shown that the systolic blood pressure and the diastolic pressure in both controlled and observational diets were lower in vegetarians. Similarly, the incidence of diabetes type 2 is less in ovo-lacto vegetarians than in with the omnivores, showing that they were the ovo-lacto vegetarians when compared with the omnivores, the vegetarians had more insulin sensitivity than the animal people eating a non-vegetarian diet. And the degree of insulin sensitivity correlated with the number of years on vegetarian diet. So validating that, again, systematic reviews and meta-analysis showed that combined with exercise, the vegetarian diet was associated with the dramatic reduction in use of glucose-lowering medications, HbA1c, and fasting blood glucose. Gut microbiota was referred to in one of the previous talks, but uremia leads to loosening of these tight junctions, and there's a leakage of the pathobionts, the bacteria, the pathogenic bacteria, and the bacterial components into the systemic circulation. And when there is uremia, these tight junctions are loosened. This process is reversed by a plant-based diet by reducing FGF23, lipopolysaccharides, paracresol sulfate, the indoxyl sulfate, trimethylamine oxide, and the advanced glycation end products, increases the clotho and the short-chain fatty acids such as butyrate. All these lead to tightening of this the loosened tight junction. In fact, we ourselves have completed the study of the acronym EPROC study, efficacy of probiotics in the conservative management of treatment of chronic kidney disease, with many of these as secondary endpoints and seem to be working well. There's a higher intake of phosphate in plant-based diet, but actually this phosphate does not get absorbed. So the end result is that the phosphate absorption is higher in animal-based proteins, because there is what is called the phytate and enzyme indigestible, in the presence of the indigestible phytate binding to the plant-based phosphorus makes it indigestible and passes in the feces. In the vegetarian diet, and also fruits and vegetables are less likely to have phosphate-based preservatives that are often used for meat processing. The higher fiber intake leads to enhanced GI motility. This is very important because there is a feeling that if you give vegetarian diet, there might be more chances of hyperkalemia, but that is not true because of the enhanced GI motility, reducing the motility, the total transit time to less than 40 hours. The potassium absorption is minimized in those who are taking a higher fiber, and also those who are taking the meat-based diet. Potassium is also, along with phosphorus, an important additive that's often found, and they have actually they have a higher chance of developing hyperkalemia. The pitfalls of vegetarianism. This is the role of dietitians, where it's very important that they come in and make sure the risk of protein energy wasting is minimized if we use keto analogs. In inadequate essential amino acids, again, use keto analogs. Undermining obesity management. If dietitians give importance to the glycemic index of their vegetarian foods, I don't think there is an issue. I've already addressed this issue of high potassium load and hyperkalemia, and also of palatability and adherence are interlinked. Some of the nutrient deficiencies like these should be managed and can be supplemented through the vegetarian source itself. And the dietitian is a very important part of this, and I would call them the keystone of this arch of management of chronic kidney disease. Anthropometry, using the Harpenden calipers rather than plastic cheap calipers. Usage of BIA, either with the sophisticated quantum one which we use, and then the basic one which is like a weighing scale, is very important. Now coming to keto analogs and the concept of vegetarianism, Liliana Garnieta from Romania was the first one in 2016 who came up with this study. Though it was study had many caveats, she was the first one to suggest that a vegetarian diet may benefit, may be more beneficial to those who are taking keto analogs. So her study started off with this was a prospective open label randomized controlled study, vegetarian, 2 arms, all vegetarian, 0.3 grams of kg per day protein, the VLPD diet, and the LPD 0.6 gram per kg per day. These took 1 tablet per 5 kg of keto analog. These ones took 1 per 10 kg. 1,413 patients were screened, and the problem was because of their culture, the Western culture, about 45% of patients dropped out of the study immediately, saying that they could not accept a vegetarian diet. And as the study progressed, another 40+ % patients dropped out because they could not stick to the low protein diet. Ultimately, they could analyze only 207 patients for their primary endpoints. You can see clearly here that they didn't do the 24-hour collection. That's one of the problems with the study. They used the EGFR, but in the EGFR, you could clearly see that those who were taking the keto analogs benefited a lot. Those with the keto analogs and vegetarian diet, only 13% as compared to 42% of those who did not take keto analog. There was a 50% reduction in EGFR and reaching ESRD, and those starting renal replacement therapy dialysis, only 11% in the keto analog group, whereas 30% in the low protein diet without keto analogs. So this point is important because here you may ask me why do we need keto analogs? Can we just give vegetarian diet and have the benefits? No, you can clearly see here vegetarian diet still led to a high incidence of reaching the primary endpoints here, whereas while adding keto diet along with vegetarian diet, there was a much better result in the keto analog group. The same findings in a scatter graph here. We ourselves did a study where predominantly our patients were vegetarian, and we also had the same two arms and the same body weight. We had, as you can see, 178 patients were from stage 3 to 5, and 122 patients were put on one arm, and they were on this low protein diet with 0.6 gram protein per day and 1 tablet of keto analog and per 10 kg, and the other group 56 patients 1 tablet per 5 kg and 0.3 gram of body weight. We found fantastic results. We did a 24-hour urinary collection. Urea nitrogen estimation is very important to make sure that they're compliant with the diet prescribed. And there was, as you can see, negligible screen failure and dropout rate. They were followed up for 12 months, and you had a baseline here of creatinine clearance. And actually, there's an improved creatinine clearance at the end of 12 months in both groups. So that's an amazing result with keto analogs. Study done prior to ours by Sunil Prakash also showed very good results. They used a placebo instead of a control group. They had placebo, and they also used in many cases 24-hour protein. 24-hour instead of 24-hour urine collection, they did a DTPS scan. They found good results with the keto analogs. So the conclusions I come to now. This was the KDOKI NKF guidelines. The chair was Al Pikisler. Their conclusions were that they were not very sure. They had their fingers crossed because most of the studies of vegetarianism, whether it slows progression of chronic kidney disease, they say yes. They had a hard endpoint of studies up till 2016. They did not even include the Liliana Garnieta Romania study, which I had shown. So they say that we cannot recommend it carte blanche by saying that, yes, you should take vegetarian diet. We at least need some randomized control trial over a period of 10 years to come to that conclusion. But they were very clear that keto analogs, in patients who were CKD 3 to 5, who are metabolically active and non-diabetic, should get a 1A recommendation, which is actually the highest recommendation in their guidelines. Just got released in the KDOKI, this in the along with the Academy of Nutrition and Dietetics. Whereas as a counter to this, the International Society of Renal Nutrition and Metabolism, the chair of this was Kamer Kalantazadeh. They said that a lot of studies have come after 2016, which are, though not randomized controlled study, are reasonably good observational studies. And so they would rather come up with fresh guidelines whereby they would recommend vegetarian diet. And there is no doubt in their mind that keto analog should be recommended, but whether vegetarian diet is important or not, I think they believe yes. So coming to the last slide, what I would say is yes, the NKF, KDOK NKF guidelines and strongly support LPD diet with ketone analog supplementation. We believe that given the mechanism of action of ketone analog, there's no reason why a diabetic nephropathy should not also benefit. The Garnier study I've already spoken, so compliance is very important. Protein energy wasting need to be addressed prior to starting SLPD initiation. You cannot start protein restriction in a patient who's already malnutrition. So correct the malnutrition. Ka supplementation will be mandatory to compensate for lack of protein of high biological value if a plant-based diet is prescribed with strict nutritional involvement, nutritionist involvement. A plateau diet, which I've spoken of, plus vegetarianism may be beneficial. Ideally, however, more long-term RCTs will help resolve these issues. So given the present knowledge, a vegetarian diet supplemented with ketone analog is reasonable, easier in India. We should take the benefit out of this because we have a huge base of vegetarianism and use it to our advantage. And a non-vegetarian can continue to do so with protein restriction, additional ketone analogs. And ketone analogs, most importantly, should be prescribed in the right dose to achieve optimum benefits. So there's no point in giving one BD, one TDS. You should give it at least one tablet per 10 kgs, something like 6 to 7 tablets per day. And mind you, the cost of ketone analogs is much less, is one fourth the cost of dialysis. So if you can delay dialysis by 2 to 4 years, then you have saved a lot of money for the patient. So the right patient, right dose, and right time.
Thank you so much. Thank you so much. I think we are quite.
I welcome you. This is a very important last slide. 2024 International Society of Renal Nutrition and Metabolism, which is the most important meeting for renal nutrition, is happening in Hyderabad. I welcome all of you and come to this meeting in Hyderabad and interact with the international community. Thank you.
Thank you so much. Thank you. I think organizer, do you have time for any question because we are already delayed? So it is the organizer.
We are running late. I think we have to wrap up because we should wrap up now.
Thank you so much. Thank you. I think we listened to 3 talks. All 3 are important. And I'm sure there will be a lot of questions. But because of shortage of time, we have to wrap up. I thank all the speakers for their comprehensive deliberation. Thank you so much.
And I'd like to thank Dr. Arpana Iyer, Dr. Manas Ranjan Behra, and Dr. Ravi Kushwaha, who are here with us. And they were actually supposed to be taking up the panel discussion. But unfortunately, we are running out of time. And so we have to, move on. But thank you all for being here and, for really making this session so very interesting. And it's the whole day has been a very, very fruitful day for all of us. I think the deliberations have made a lot of difference. And I think we've picked up new things, new ideas, and we can go ahead and move ahead till we have the next advanced course next year. So can I request Dr. Bhalla to please join me now? So
Yes.
would you like to say something?
Yes, thank you. Dr. Amit Gupta is saying something.
I'm fine. I didn't want to say anything. I thought maybe you could have taken a few questions, but then that's.
Oh, no, the questions they didn't allow. So just on behalf of Society of Renal Nutrition and Metabolism, I sincerely thank everyone, in fact, especially the faculty who have really taken so much of efforts and prepared their thoughts. It was all excellent thoughts with good review of literature and very good message in every presentation. And it was very well attended by so many nephrologists, physicians, as well as nutritionists. And the credit for this successful meeting goes to none other than Dr. Professor Anita Saxena for her hard work and dedication and passion, and really looking every minute details of the program. And I will definitely, Dr. Amit Gupta has definitely been very active in the scientific program and overall flow of the conference. And I request Dr. Amit Gupta also to say a few words. And finally, Professor Anita Saxena is going to conclude. Professor Amit Gupta, sir.
Yeah, thank you, Anil, for this, for letting me talk. And I think we really enjoyed all the lectures that were given, and they have been of extremely high quality and have been very informative for most of us. Because I learned a lot of things from every talk. Actually, there was some very small points, some very significant points that would at least help me in my day-to-day clinical practice. And I'm sure most others would have done the same. Unfortunately, we didn't have much time for question and answers, because that is an important part of every conference. But I hope the next time people would send in more questions, which we can answer, because those things need to be cleared up. And these are occasions where, meetings where we can clear up our doubts and also make suggestions which would be helpful to others. I'm really grateful to Professor Anita Saxena for having organized this in a grand manner, and to all the speakers who've done a great job. Thank you so much.
Thank you, sir.
Thank you, Dr. Gupta. And I would like to announce that this year, the SRNM, the Society of Renal Nutrition Metabolism's annual conference is going to be held in Mumbai. And the organizing secretary is Dr. Umesh Khanna. And I do hope that all of you will join us. I'm sure it's going to be on the virtual platform only. And I really, from the bottom of my heart, I thank all the moderators, all the panelists, all the speakers for sparing their time in these COVID times. I've had a bad day today because I was running around for getting a worker of who works under me for admission, because it really became serious. So I can understand how things are, and amidst this time, if you are here with us, this means that you do have passion for promoting renal nutrition in India and in the world. So is Dr. Narayan Prasad here? No, I didn't think Dr. Narayan Prasad is here. So thank you very much, everyone. Thank you, the virtual team, for being with us and being so very helpful that you really took all the tensions off us, and we, in these hours of business, we were able to still conduct this virtual conference. Thank you so much.
Yes. And the meeting and more also deserves.
Yeah, that's what the
yes,
virtual
yes,
team, that's what I
yes,
said.
Yes. Thank you, madam. Thank you.
Also, I'd like to thank the pharma companies who've supported
Yes,
us.
yes,
Because yes, without their support, anything like this is not possible, because everything costs. So thank you so much for being with us.
Thank you, madam.
Also the audiovisual team.
Yes.
Yeah, that's what the virtual team, that's what I said. you.